You work for the NHS. You've had a great idea, you've made it happen, and it's made a big difference to how we can learn from COVID-19 and enter a new normal. Ideas like yours drive improvement and they deserve to be shared. That's what Bob does. Amplifying good ideas like yours across the NHS so as many people as possible can learn from, adapt and implement your idea. The further good ideas are shared by the Bob community who learn from them, the greater improvement we can achieve. You made a change. Share your solution with others. Speak to Bob.
Hello everyone, I'm Mark Southern, one of the co-founders of Bob Health.
And I'm Neil Crump, the other co-founder. So thank you very much for joining us for this introduction. This was meant to be played or actually live yesterday morning, but as many of you might be aware, the giant platform blew up as 20,000 odd people logged on. So our session all went drastically wrong and stopped recording. So we are re-recording it on the night of the 1st, and this will be played on the morning of the 2nd. So this is a recording, but we are live in the room, the chat. So if you have questions, pop them in the chat and we will answer them live. So the other thing just to say is that we are obviously that hashtag people are tweeting about the conference on the hashtag Giant2020. And for this track, the hashtag is hashtag unpack the how. So unpack the how. And the Bob Twitter account is at bob.health, dot spelled D-O-T. So it's B-O-D, D-O-T, sorry, I'll start again. So that's B-O-B-D-O-T-H-E-A-L-T-H, bob.health. So without further ado, we will start the presentation. So Mark and I are here to talk about unpacking the elusive how-to behind good ideas across the UK healthcare system. And so I'd like to introduce you to bob.health. And here is the website. Our rally call to NHS staff is you've made a change, share your solution with others. So what Bob exists because we're a completely free service for the NHS, and we have a self-guided writing engine which makes it easy for NHS staff to create
You work for the NHS. You've had a great idea, you've made it happen, and it's made a big difference to how we can learn from COVID-19 and enter a new normal. Ideas like yours drive improvement and they deserve to be shared. That's what Bob does. Amplifying good ideas like yours across the NHS so as many people as possible can learn from, adapt and implement your idea. The further good ideas are shared by the Bob community who learn from them, the greater improvement we can achieve. You made a change. Share your solution with others. Speak to Bob.
Hello everyone, I'm Mark Southern, one of the co-founders of Bob Health.
And I'm Neil Crump, the other co-founder. So thank you very much for joining us for this introduction. This was meant to be played or actually live yesterday morning, but as many of you might be aware, the giant platform blew up as 20,000 odd people logged on. So our session all went drastically wrong and stopped recording. So we are re-recording it on the night of the 1st, and this will be played on the morning of the 2nd. So this is a recording, but we are live in the room. The chat, so if you have questions, pop them in the chat and we will answer them live. So the other thing just to say is that we are obviously, lots of people are tweeting about the conference on the hashtag Giant2020. And for this track, the hashtag is hashtag unpack the how. So unpack the how. And the Bob Twitter account is at bob.health, dot spelled D-O-T. So it's B-O-D-D-O-T. Sorry, I'll start again. So that's B-O-B-D-O-T-H-E-A-L-T-H, bob.health. So without further ado, we will start the presentation. So Mark and I are here to talk about unpacking the elusive how-to behind good ideas across the UK healthcare system. And so I'd like to introduce you to bob.health. And here is the website. Our rally call to NHS staff is, you've made a change, share your solution with others. So what Bob exists because we're a completely free service for the NHS, and we have a self-guided writing engine which makes it easy for NHS staff to create an impact story which will basically accurately capture the problems they faced and the insights they gained about making a change at the local level. So those changes could be big changes, so it could be a service overhaul of an entire sort of a ward or a department, or it could be something as small as a roster change and sharing that experience with other people. Now, this all started because a number of years ago, I attended a meeting where this chap is on the screen. He's called Andrew White. He has a role within Devo Mank. He was based in Salford, and he was talking about how they actually, introduce a new medicine into the system. And as he talked, he started talking about how, they were looking at the data, the phase 3 data again, they were looking at the health economic modelling. So I put my hand up and said, well, haven't MHRA and haven't NICE already done that? And he was like, yes, Neil, they have, but that's what we do, we dig into this. He talked some more about it, and I put my hand up again and I said, look, Andrew, have you not, are you the first person to introduce this innovation? He's like, no, we're not the first. We do ask around a bit, we tend not to find anyone. So yes, we reinvent the wheel pretty much every time we implement something. So I thought that was a bit mad. So I went bounding up to him at the end of the session and said, can I come and see you? So he said, yes. So the next week I jumped on the train, went up to Salford. We went to Tesco in the cafe, and Andrew kindly sat with me. We had fish and chips, and we talked about the challenges that he faced around introducing innovation into the system, and I was hooked. So the problem that we are digging into as a organisation, which is the next slide, is the challenges that when starting an NHS project, big or small, NHS staff find it hard to discover the experience and practice of others who've delivered something similar. So this is the problem that we are helping to solve through the platform, and the one that really was brought to the fore by Andrew. So we developed the concept. This is the team of 7 of us on the slide who developed the core concept. So there's myself there, then there's Frida, Stephen, Arthur, Laura, Chris, and there's Mark. And the arrow's pointing at both Frida Kutunda and Laura Bailey, who both worked really closely with me and put a huge amount of blood, sweat and tears into developing that concept. So I just want to say huge thank you to the amazing Frida and the amazing Laura. So moving on to the next slide. People often ask us, why are you called Bob? Well, basically, Bob is the person that you turn to in an organisation, and you ask them, have we done something like this before? So that's who Bob is. Bob is that person with institutional memory. They've been around for years, and that person that when you ask them, they can say, yep, 6 years ago we had an initiative like that. They can jump on the server, they can pull down resources, and then they can be really helpful. So that's who Bob is. That's what we're trying to create online.
Thanks, Neil. So looking at this challenge of experience sharing, why is it so hard? So when, as Neil mentioned a few years ago, we got together around this challenge, and since then we've been talking to numerous folk across the NHS in varying different roles. And we know change is difficult. Change is difficult in any setting, and this is even more pronounced in the NHS. And some of the things and the reasons we heard behind that were that, well, since 1990, when the National Health Service and Community Care Act was created, it formed an internal market. And because of that, it meant that we have these highly devolved, legally independent structures, organizations, sorry, and really the incentive there was for them to focus on their own performance. And so it was more competitive than collaborative. And although it has changed a lot over the last few years, we still carry some of that legacy with us when we look at the health system. And there is also tremendous efforts across the system to try and address that. So change is hard. It's also been tricky because of the structure of the NHS. And so as we come out of this now, looking at the situation, there still needs to be more work done to really move that on. So those are some of the things we heard. And there's Betty looking very confused. So looking at the individual level, why is it so hard in practice to do this? So beyond just the system level, for the individual, we know that everyone's busy, and especially people in the NHS, and especially over the last few months. People are busy, and there is a little incentive to find the time to share. And that's something we just heard. It's natural, it's human behavior. As well as that, if someone does go out there and they want to try and find a project that's similar to what they're about to embark upon, they do what we all do. We start with Google and we go looking for information. What they might find, if they're lucky, is information that's published. It's rather haphazard. It might be in silos. And what it tends to not have is what we call the how-to elements. And so it might have a top line headline, and there might be a couple of bullet points. But what generally is missing are those lessons learned and those very specific things that people have done that, if they were replicated, could really lead to some successes with their projects. So that's another thing that's missing there. And finally, what we also heard was that when someone has, it's not an individual, but when an individual and a team have brought together various aspects around a project, and they've made this amazing change, they've delivered results, when they move on a few months, years down the line, sometimes if these experiences are not captured, then those are lost. They're lost, and the organisation cannot find them again because it's the people that have moved on. So those are four of the key things that we heard around why experience sharing was so hard in practice, and some of the things that we've used to help build Bob. So on this, actually, there's a couple of sessions which we've got in the agenda today, and these sessions really look at the human factors involved in capturing knowledge and experiences and sharing them. And the first one is called Building Confidence in Sharing Your Good Ideas with NHS Colleagues, and this features a couple of our authors from the Bob platform, talking about their experiences of sharing their ideas, why they've shared them, what they learned from the project themselves, and also by sharing the information on the project. And then we've got another session directly afterwards, which is looking at the theory behind spreading and scaling ideas and innovation. So again, looking at those human factors, we're joined by some behavioral scientists, some psychologists, a digital sociologist there to really unpack some of those human factors, which really are quite fascinating as to why things move and why other things don't move. So that's some flags for some interesting sessions today in this Bob track. All you have to do is stay in this channel and you can get those. And then just revisiting Bob itself, and this is a picture of all the amazing people that have been part of the team over the last couple of years, really pushing us to where we are today, all the way from the beginning through to us having a real life functioning product. And one thing that unites all of these people is our values. And we're really keen to share these values. And they are being kind, collaborative, resilient, and trustworthy. And I have to admit, when we first started this exercise of building the values, I thought, oh, this is a really cheesy corporate exercise, isn't it? But actually, looking back now, this is actually probably one of the most important things we did. And we did it very early on when we were setting out our company, because we hire against these values. We evaluate whether or not an organization is worth collaborating with, and really it defines who we are and who we want to work with, who we want to be with. And very important, actually, one of the key things one of our hires, Nick Vogt, said to us when she joined was, actually, you know, your values are pretty similar to NHS values. And for Neil and I, that was a big tick in the box there, knowing that we are aligned with the right organisation. So very important for us to keep these values. And it's important because, as I said, looking at the collaboration partners we have across the NHS, Oxford Health NHS Foundation Trust were the first collaboration partners we had. So Dr. Jill Bailey and Professor Charles Vincent are two of the people there that we work with. Actually, when we started working with Jill, when we first met with Jill a couple of years ago, we all sat down around the table and Jill was describing some of the challenges that she had faced around sharing and dissemination. And Neil and I expressed our kind of vision and goal for Bob, and it was just immediately like, oh, we're saying the same thing here. This is fantastic. So we immediately have this shared vision, this shared purpose, and shared values. So it's really important to us, and we continue working with Oxford to this day. And one of the ways in which we've been working with our collaborative partners and others across the NHS is really co-creation. So everything we do on Bob is built with NHS staff in mind. And so what that looks like is it's either research with NHS staff, or it's actually designing and creating and mocking up screens, making sure the language is correct and that things look correct in terms of an NHS mindset. And as you can see, some images from a workshop that we could do when we were able to be in the same room together. So we've been working closely with 28 NHS staff Bob champions to do this, and it's something we'll continue to do. Bob is always going to be built with NHS staff helping us along that journey. So just looking at some of the pieces now that might motivate people to share. And again, this goes back to all these interviews that we've done, these conversations we've had with various people across the NHS. We know that in terms of people's role, it certainly is part of a number of people's job role to share. And whether that be an innovation type role or a quality improvement role, many roles have this as part of what they do, whether it's official, formal, or not. And it's about knowing certainly where, how to do these kind of things. Where is the best place to share? How do I do this? For a lot of people that we spoke to, they said, well, yeah, I'd love to do it, but I've never done this before. How do I begin? Another piece is altruism. Now, we believe most people that work in the NHS, this is just kind of almost a point of entry, really. Everyone has this belief. Everyone is there because they want to help other people. We know that's important. So it's a big driver, because in sharing your knowledge with other people, you're helping other people. Ultimately, you're helping patients at the end of the day. And the third thing is, these projects that we're talking about, as Neil mentioned, they range from big to small, but ultimately, they're always a team that's about solving or resolving something and coming up with an outcome which is a positive outcome for people. And in doing that, people want to share that. And in doing that, they can be recognised for the good work they've done as a team, because it could have taken a lot of time. It could have been a really, really nasty, tricky problem to solve. So at the end of the day, people want to share something good, but equally, people also have had a desire to share something which didn't go so well, because they know that actually that's probably the most meaningful, valuable thing they could do for other people who are looking to start that project themselves. And finally, the other thing we heard is that supporting career progression is really important. So in sharing this information with others, or even just capturing this information in a form that people can learn from, really helps. It provides that evidence for people, whether it be an appraisal conversation with your line manager or CPD and revalidation. So those are 4 of the things that we've heard from people that would definitely motivate them to share their story, their experience of the project. And then looking at it from the other side, looking at it from a Bob perspective, writing a story on Bob also solves a problem for the author as well. So as I mentioned earlier, people move on and the ideas and the experiences can be lost. So writing a story helps to ingrain it, capture it in that moment in time, and help support local embedding within the organization. Also, within a Bob story, there's a good section there around outcomes and actually the impact of the project that you've created. What does it look like? So it's a way in which you can capture that impact that you've had in a story. The other piece is that it also supports discussion with adopters. One of the other things that we heard in the interviews we had was that people will go look for a project online, they'll Google. If they're lucky, they'll find something, and if they're even lucky, there'll be contact details. And what the behaviour tended to be was that they would go and they would speak to that person. They'd go meet up, have a coffee, and they'd have a great chat. They'd talk about the project, and then the adopter would ask the innovator, the improver, a question or several questions around the project. And what they're trying to do is to try and find the good things, the bad things, the things to watch out for, or the nuggets that really help push them on. And that will happen on numerous occasions. But what we heard is that after a while, it becomes a bit of a challenge for that innovator, for that innovator and that improver to be there always to share the information with the adopter. They just can't be there. It's not their full job. So what we heard is that if there was a place that they could point people to that did capture some of these how-to elements, these Q&As, that would be great, and that would save them time. So that's what we can do in a Bob story, capture some of those key things. And the final thing to say is there's also this piece of reflective learning for CPD. When you write a Bob story, going through that process, it's asking you to reflect back on certain things, experiences that happened throughout the project. And in doing that, it then fulfills one of the key criteria of many CPD requirements, which is about reflective learning. So actually, by just taking part in a Bob story and creating that, you're also creating yourself evidence for CPD going forward. Oops. Okay.
So our latest story that got published today is from an amazing radiologist, Dr. Anu Ibarra, and she has written a story about giving a presentation within her trust on racism. It was all sparked by the death of George Floyd, and it had an enormous impact on Anu, and she decided she wanted to give a presentation about racism and actually about being anti-racist. So this was a really high stakes thing to do. She talks in her story about what a big emotional load that was, but she actually unpacks how she went through the research, how she drew on her personal experience, and she created a really powerful presentation which has been watched quite extensively. It's mobilized action within her trust. She has the support of the chief exec, and there's been a whole big amazing ripple effect as a result. So she is sharing her research and all her findings. So it's a really amazing story, which I'd really encourage you to go and read, and then also then to watch the presentation she gave. It's unbelievably powerful, and we're really proud that we were able to help her to do that piece of reflection, and it should save her time. People are coming to her saying, Annie, how did you do that? So she can now direct people to that story as a first port of call to learn. So that's fantastic. So one of the key people in our team is Mark mentioned Nick. So Nick is our quality manager, and actually at 3:45 today, she is doing a practical demo, and there's going to be available for Q&A. So she can really show you how our self-guiding writing engine works, and the editorial support that we can offer. So on the next slide, I just want to give you a glimpse of that writing engine. So it is a self-serve model. You sign up for free, you can come in, you can create your story, and you basically work through three key sections, and it's a Q&A format. So you're asked a question and you're asked to give a nice, concise answer. So it would be, it is actually possible just to guide yourself through it, and many people do, but we can offer you that additional support if you want it. Though stories visualize, it looks something like this when you read a story. So you have a navigation on the left, you work through a story, you can read it as a full page, and then also with a click of the button mark, you can do two other key things, which is to actually ask the author a question. So you can make contact with the author. In this case, you'd be contacting Oliver about their virtual consultations that they rolled out in response to COVID. And the other bit of key functionality is to share the story with your peers. So you can send it as an email or into social media. At the moment, about a quarter of everyone who reads a story, a quarter of the people who share a reader story, share it. So we're looking to really push that figure up. If you found this story useful, what we're trying to encourage people to do is to share it, because other people are likely to, in their network, are likely to benefit from it. So the more we can share stories, the better and the bigger the impact these stories can have. So over to Mark to talk about our new sponsored offering.
Absolutely. So actually, again, another highlight for today was that we've had two sponsored stories go live on the platform, and the sponsored stories, and we'll talk about those in a moment, a bit more detail. So the kind of people, NHS suppliers that can sponsor stories on Bob really are far-ranging, anything from Medtech to non-NHS healthcare providers, non-clinical providers, pharmaceutical companies, and external consultants. And what you can see on the right-hand side are just some cards that are a summary really of the story that you then click on to read more. But you can see here, they're clearly denoted as sponsored stories in orange there, and very clearly summarize the project itself there. So, excuse me. So we've got two examples there from Concentric and also from Sky as well. And the two examples that we've got there are going to be building over the next few months. We have other suppliers, other NHS suppliers that have also got sponsor stories in creation at the moment. So keep an eye out on Bob. There's going to be a few more coming out over the next few months. And so just a little bit more detail around the sponsor stories. So Bob is a free service, as Neil's mentioned, to NHS staff. And the reason why it's free is because we're able to offer these sponsored stories. So just going through this slide, there's an animation here. So what we've described at the moment is in effect two sides here. So we've got the NHS generated impact stories, for example, Anu's story that we just saw earlier. And then we've got these NHS supplier sponsored stories that I just showed you on the previous slide.
Mark, you just muted your line accidentally.
I just muted my line. There we go. I'm back. Professional, it's fine. The key thing that unites these stories is that the creator of the story is always an NHS staff member who led the change. So that's key to remember. And as I said earlier, the revenues that we generate from these sponsored stories enable us to provide a free of charge service to NHS staff. And as it states here, all the declarations of interest are made very clear on the sponsor stories. As you could see earlier, they're denoted as sponsored, and also we state who the sponsors are very clearly. And there's extra information inside the stories about what the sponsors did and how they supported that site. So Bob will always be free to the NHS staff, to NHS staff, and that's a promise. And just the other pieces to say here is these builds that we've got here just reflect some of the additional modules that we'll have coming out. So at the moment, our free NHS module is an improvement module, and it really catches, we've designed it to catch as many possible projects in the NHS as possible. And then from the NHS supply sponsor story side, we have in effect three different types. So we have one which is about innovation, introduction and support. The second one, which is about NHS partnerships and collaborations. And the third one, which is more focused around service and pathway redesign. So it just covers off slightly different elements of the story that we might have when we've got an NHS supplier working with an NHS locality and potentially some other collaborators in the mix as well. So it's to cover all those bases. And the last thing to say here is that Bob is an advert-free zone. There will be no banner ads on the site, and the way in which what I've described to you now that NHS suppliers can sponsor story is the way in which we will have sponsorship available on the site. There will be no banner ads. So this is an example here of the Sky Medical Technology story. When you click on that card on the site, this is the way it looks. And if you recall from the previous slide we showed you, very similar. The biggest difference is that we have this section here, which is the author, sponsor, and collaborator information. If you click on there, you get further information about the company and, as I said, about what they did to support that particular NHS centre. And here on the right-hand side, you can see it's very clearly flagged that this is a sponsored story. This is, if you click into the author, sponsor, and collaborator information, this is what you see. So you get further information about the author themselves, about what they did, what challenge they were trying to tackle, as well as more information from the sponsor's perspective, talking about the innovation that they introduced, and also a little bit more information about some context around how that came about and what that was addressing. So that was a whistle-stop tour through some of the pieces that we have on Bob, but leaving you really with this last slide, which is I guess a vision really for us and a goal for us, is that we are here. We want to build a national learning platform that the NHS really deserves, and everything that we've done on Bob is really in response to everything we've heard from NHS staff members across every different role, grade, band, and type of discipline really. And we believe that by putting them all together into one platform, people can learn from each other in different disciplines and in different areas. We don't want this to be siloed. We want this to be open to all, because we believe the NHS deserves that and the ability to learn from that.
Yeah, so we're really proud that we've out there. We're here to help. We want to help people tell great, authentic stories about how hard it is to make change happen. And thank you so much for listening. Enjoy the rest of the day with us here. Enjoy the rest of the tracks, and do take a look at Bob. And if you've got a story to tell, we're here to help you do that. Get the word out. It can be a big project, a small project, but know that you can make a difference by sharing. So thank you very, very much.
You work for the NHS. You've had a great idea, you've made it happen, and it's made a big difference to how we can learn from COVID-19 and enter a new normal. Ideas like yours drive improvement, and they deserve to be shared. That's what Bob does. Amplifying good ideas like yours across the NHS, so as many people as possible can learn from, adapt, and implement your idea. The further good ideas are shared by the Bob community who learn from them, the greater improvement we can achieve. You made a change. Share your solution with others. Speak to Bob.
Okay, and we're live again. Sorry about that.
Okay, so on the basis, we just heard that the sound went down for across the whole platform. So hopefully we are back. And so I think I probably should start from the top again. Welcome, I'm Neil Crump. I'm one of the co-founders of Bob.Health. We are a startup, and we are here with a panel of five additional startups and SMEs who are here to share their story about how they are successfully navigating through the NHS. We also have a wonderful speaker, Clina, who is from the Accelerated Access Consortium, and I'll explain what her role will be, and she'll be talking to us about the innovation service. We are obviously in the age of social media, so just to run through, the hashtag for Giant is hashtag Giant2020. This track, the hashtag is hashtag unpack the how, and Bob's Twitter account is BOBDOTHEALTH, so Bob.Health with dots spelled out. So we were just going to run a poll just to get a sense of who our audience is. So there's, if you look to the right, look to the right of the screen where it says chat, there's also something that says polls. So we were just wanting to find out what type of organisation you worked for. So the options were SMEs, large commercial organisation, academia, where you also might be a student, NHS or affiliated organisation, social care organisation, a charity, or other. So if I could really encourage everybody on the who's listening in to press on that poll. We've had low participation in the polls, so it's please go across and give that a click, and we'll report back slightly later. As I said, we've got the panel of SMEs, and I'll come back and introduce them all after Clina gives her presentation. So Clina is the strategy and policy manager for who works within the Accelerated Access Collaborative. I said consortium earlier, I think, so I apologise for that error, which is part of NHS England and NHS Improvement. They are working on this really great initiative that I learnt about actually a year ago today. I think I learnt about it at Giant last year, and I wanted to invite them along because I've been to a couple of their workshops. They're a really amazing team. They've really been trying to understand the NHS and how SMEs navigate the system and connecting with the NHS. So I will hand over to her to basically give us her presentation. Now she has slides. Now she doesn't have control of the slides, so she'll be telling the tech team to advance them. So over to you.
Thanks a million, Neil, for those really kind words. So if we can move on to slide 2, that's probably the best place to begin. So just going back to the hashtag of unpack the how and why I am here today. You know, I and the rest of the team, we're in working through how we can best support innovators, be they from a clinical background, industry, academia, patients or carers with an idea themselves. We speak to them regularly, sometimes on a weekly basis. And the specific goal of the work that we're doing on the innovation service is really making that heavy lifting, which many SMEs have to go through right now, a little bit lighter. And I'm really excited to talk a bit about how we plan to do that, and maybe even have some people here who will help us work that up further. So first of all, to explain a bit about the Accelerated Access Collaborative. So it's a unique partnership between different patient groups, government bodies, industry and the NHS, with the purpose of getting the best new treatments to patients faster. So there is a team who supports the AAC, which is based at NHS England and NHS Improvement, which is kind of like the engine force behind all those great ideas and the vision. And developing a single front door to the innovation ecosystem is one of those key 6 visions, which was agreed and stated last summer and requested by the Secretary of State for Health. So what is that vision? If we could move to slide 3, please. So the vision for the innovation service is that it will be a go-to place for innovators to navigate the path to market, and also coordinate the different organizational partners who have a role in supporting innovators in accelerating the best products to patients, to staff to use, for people to benefit from. And you'll be wondering, why do we have a photograph here of a corridor with so many doors opening out from it? And we think it's actually quite a germane metaphor for a lot of what we're trying to do. So a lot of existing resources are up online, and there's also lots of different support organizations who you can access online or access through other routes. We're not planning to duplicate anything, but rather have one place where you can go to figure out what information do I as an innovator need, and then go to that right door, knock on that door, open that door, and get it easily. And equally, speaking to the right organization who is appropriate for where you are in your development journey and can give you the right support. So what does that actually mean in practice, and what is this going to look like? If we can move on to slide 4, which is how this will help innovators. So there's going to be 2 different parts to the service. The first one is providing information, and the second is the transactional part, where you speak to somebody on the other side. So a couple of key themes on the informational part, which I'll speak to, and issues that that's addressing. We hear very frequently from innovators that they want to understand what the NHS's needs are, so that they go and develop things which are genuinely in demand, which people actually will want to use and benefit from, which speaks to an issue which we've identified over the last couple of years, that we weren't making this clear enough, or as clear as should be. Understanding regulatory requirements, understanding how to build up an evidence base is also of significant importance to innovators for obvious reasons. And then another area is supporting innovators to understand more fully how to gain adoption and spread by understanding the different processes to do procurement, reimbursement, and commercialization. As things currently are quite complex, there's many different avenues, having a better grip of what's the right approach will be very useful. So that's the first side, the informational side. And then there's the transactional side, which is helping an innovator register, submit information about their innovation, and connecting them with the different support organizations so that they will benefit by only having to tell their story once in order to get support. Having that two-way interaction with one record of the conversations that were had, so that everybody's on the same page. And that as you make more progress and you say, get your regulatory sign-off, you're able to then get more support, and it's all been on that one record rather than having to go elsewhere to go and get more of that support. So if we can move on to the next slide, how this will help innovators 2 of 2. This is a bit of an outline of how the transactional side will work. So by providing one single view of the innovations registered, it will enable more joined up early stage support. And here's some of the different organizations who have a role in that. Better coordination on topic selection for health technology assessments, which are done for evaluating the cost effectiveness of different innovations. And finally, quicker spread, scale, and indeed export of proven innovations. And running parallel to all these streams for organizations like NHS Supply Chain to have a forward view of the pipeline so that they can plan getting the innovations which are most in need onto their category towers. I think it's really important to actually give a shout out to these different organizations who've been working with very closely, in many cases, on developing this project. Again, harkening back to the collaborative in the AAC. So if we can move on to the slide 6. So what will innovators get? You probably want to have some insight as to what this is going to look like. So here's a couple of screenshots of the prototype, early prototype, I must add. But then innovators will get a site which provides a trustworthy brand with a clear value proposition, so they know that they're in the right place to get information and they can trust it. That they can segment the information, get only that that's relevant to them. And if you move on to the second slide on this, that innovators will have one single view of the progress that they've made with their innovation and their correspondence with different support organizations, giving them advice, giving them support, and that they can get support that's appropriate for their stage of maturity. So whether you really are starting out with something very early or whether you're really close to finishing off, this can help you, and it can help you on all the steps in between as well. So this second last slide is timeline. If we can move to that one. You can see now that we are nearing the end of our alpha user research journey, which I guess, as you might expect for a project of this ambition, has required quite a lot of time to develop. And we are planning to go into what's called a government digital services assessment, where they basically approve whether our innovation of this service is fit for purpose and can move on or not. We're planning to then progress the build for this with further user testing in January to June next year, with a view of going live in summer next year, 2021. And for those who are interested in finding out more, if we can move to slide 9, we have provided some links here, contacts to both the team and also to the Accelerated Access Collaborative. And we're always keen to make sure that we have as wide a representation of innovators participating in user research. Like we want this to work for all people. We want to hear from all people. And we've provided a form here, which I'm sure the Bob team will send out again to all who are interested to make sure that you're able to participate should you wish.
That is fantastic. Thank you very much. So I think, as an SME, I think when I first heard about this service, I thought, oh God, wouldn't it be great if we can access that now? But obviously it takes time to build and create this. And I do think the team has done a great job of consulting across the board with all sorts of organisations that they're going to have to connect up with, also a whole load of SMEs. And actually in the chat, we have dropped the links that were on that slide. So if you are interested in beta testing and user testing and all that work, the link is there. So you can copy paste that out. Please do go and contribute. Obviously, the more we all contribute as SMEs, the better. The poll result is about 13% of our audience comes from a large organisation, and all the rest are from an SME. So we really are here talking to our fellow SMEs. So let's bear that in mind in our answers, but that's what we're passing on to the knowledge to other SMEs. So the first thing I want to do is therefore turn to our panel. So Kalina will come back later on in the discussion, and obviously because they've done so much research into the environment, that's why I think she can probably provide us with a nice roundup at the end, because she's got a huge insight into the way all of us have been navigating the system. So I'll turn now to our panel. We have a full house, I'm pleased to see. Everyone has made it through the lobby into the key team. So we have 6 SMEs with us. We have a number of them. So what I'm going to do is, rather than me introduce them, I'm going to ask them to introduce themselves, tell us what company they're from, and to give us that all-important 1-minute elevator pitch, which if you're in an SME, everyone's like, you've got to have your elevator pitch. So if I can move through the panel, just asking them to give their 1-minute elevator pitch, and then we'll come back for a round of questions. So to kick us off, Zane, would you like to introduce yourself in full? Remember to unmute your line. Introduce yourself in full and give us your elevator pitch. What's Minerva all about?
Good morning. Thank you for having us. It's a real pleasure to be here. So yes, my name is Zane. I'm a GP by background and digital health entrepreneur. I'm running Minerva, which offers fast access to therapy via live video securely, confidentially, and discreetly. And I'm here today to talk about what we're doing in the NHS and how in 2014, the UK government has said that by 2020, by now, 75% of people being referred by their GP with mental health problems, so that's depression, anxiety, low mood, would be treated within 6 weeks. Obviously, we know that's not happening. Over half have been waiting 12 weeks. And I'm glad to say that we're starting to work in Cornwall, where over 200,000 people are able to self-refer to our service and see a therapist the same day for psychological therapy, which is completely transforming the way mental health services are being delivered in the NHS across the UK. That's
amazing. Thank you very much, Zane. So now we'll turn to Dr. Raina Patel, who is from Vine Health. So what's your role at Vine Health? Remember to come off mute and Raina, and tell us all your elevator pitch.
Great, thanks, Neil. Lovely to be here. I'm Raina, I'm from Vine Health. I'm CEO and co-founder at Vine Health, but a medical also by background. And what we do at Vine Health is really combine behavioural science with AI to improve the quality of life of cancer patients. So supporting them to self-manage, to track and understand and optimise their care through really highly personalised patient support, as well as to communicate crucial information back to their care team. And through the platform, we collect really rich real world and patient reported data that represents the voice of patients in healthcare delivery and also in research and drug development.
Amazing. Thank you, Raina. Dr. Patel. So this is Raina is our third doctor. We're now turning to our third doctor. So Daph, please introduce yourself. Daph is in fact a surgeon. So Daph, please introduce yourself.
Thanks, Neil, and good morning, all. So Concentric is a digital consent and shared decision-making application which transforms the paper process of giving consent for a procedure or treatment. So I'm Dav Loughran, a surgeon by training and now Chief Exec at Concentric Health. And our mission is to transform how decisions are made about our health. Decisions informed by patient outcomes and shared by patients and clinicians. And Concentric is now used internationally, including at sites such as Imperial College Healthcare and Chelsea Westminster Hospital, NHS Trusts, and on the island of Jersey. So the traditional consent process, often using blank carbon copy forms, is a poor experience for both patient and clinician. It leads to errors, medical legal risk. It doesn't support patients to make decisions around what matters to them, and is increasingly incompatible with post-COVID healthcare. Remote consent functionality is supporting our partners to keep operating safely this winter, removing the need for risky in-person consent consultations in the run-up to surgery. Our digital consent application is the best in its class, intuitive, integrated, and trusted, and it supports patients and clinicians to make informed, shared decisions. Thanks.
That's fantastic. And I'll just flag that Concentric actually have, they're one of the first two companies to actually have a sponsored story on our Bob platform. So they have a story about the implementation of Concentric in Jersey. Jersey run a sandbox set up within their healthcare system for digital health. And he was able to deliver a really successful implementation there. So well done on that implementation, and the stories there that you can go and read about and learn about how you might implement Concentric in your local system. So our fourth doctor is Dr. Paul Ryan. I think I've pronounced that right. Correct me if I'm wrong. So if you can come off mute, Paul, and tell us all about Grippable.
Morning, thank you for having me. So yes, Dr. Paul Rinnie, but not to worry at all. CEO and co-founder of Grippable. At Grippable, we develop smart mobile objects for physical therapy. So devices such as Grippable that track and train specific movements that therapists would be working with their patients. The devices link then to mobile systems, and the apps can be downloaded then on tablets, smartphones, and then transitioned from the clinical environment to the bedside and then to home. We are early stage in our development. We launched earlier this summer, and we now have about 400 systems out in the real world across about 100 sites, about 50% NHS, 50% private, and a number of European territories as well.
Amazing, thank you, Dr. Rinnie. Sorry, I had clarified with you how to pronounce that weeks ago, so I do apologise. And then on to our fifth doctor, so Dr. Lucy McKillop. If you can unmute your line and tell us all about Sensus Health.
Thanks, Neil. So yes, my name is Lucy McKillop. I'm a practicing clinician. I'm an obstetric physician at the John Radcliffe in Oxford, but I'm also Chief Medical Officer at Sensign Health. And Sensign Health is a clinical AI healthcare company with a unique business model. So we work in true partnership with the NHS, and that is our business model. And be that with clinicians to develop software products, applications, or algorithms to improve patient care, or with our partner trusts with whom we have a strategic research agreement. And with those trusts, we analyse fully anonymised health data to provide insights for life sciences industries. So in that way, we work between life sciences companies and the NHS to drive innovation and discovery science, and to the benefit of all those involved. And indeed, the NHS has a 12% equity share in Sensign Health. So we really mean it when we say we're working in true partnership.
Amazing. Thank you very much. So last but not least is a fellow non-doctor. I'm not a doctor either. But we do have Victoria Smith here, but she is, I believe, a clinician. And she can, well, no, she's not a clinician. She's worked in procurement. So I'll pass you on to Victoria Smith to talk to you about what she does and what JAMF does.
Thank you. Yes, no, I'm not a clinician, I'm afraid. Not as clever as these guys. So my name is Victoria Smith. I've worked in the NHS for the last 14 years as a procurement manager. I moved to work for JAMF 6 months ago when JAMF decided that they wanted to focus more on healthcare. So JAMF is an organisation that is worldwide that supports organisations and helps them succeed with Apple products. JAMF helps manage them, and it also has its own solutions that help put the patient first. Amazing. Thank you so much, Victoria. There's not all of us can be clinicians. I was once a microbiologist, so that's my one that moved away quickly from that. Anyway, we won't talk about that now. We've got other things to talk about. So just also to let you know, we've dropped everyone's contact details in the chat. So if there's anyone of the panel here that you want to reach out to, then please, you've got their contact details there. Obviously, you can connect with them through the functionality of Giant, but you can directly send them an email. So if you're interested in talking, they'd love to hear from you, and we'll hear what they might need help with as they look to spread and scale in a few minutes. So we've had the elevator pitch. Thank you so much for everyone being so concise and being really clear. So hopefully our audience understands what it is that you do. So the next thing I wanted to cover, and I'm going to go around, we're going to go around in that nice same pattern. So leading with Zane, and just ask you, what's been the focus of your adoption strategy when it comes to Minerva, and have you made any adaptations along the way as you've been implementing? Has there been any changes so far? There may not have been, but so adoption strategy and any adaptations along the way.
Is that specific to the NHS?
Yes.
Yeah. So I think our strategy really has been really working closely with our partners in Cornwall and starting by understanding the need. We spent a lot of time, several months, really understanding what the need was, where we need to be, working with all the stakeholders. So that's the GPs, the commissioning board, the patients, and the therapists, of course, and really understanding, what kind of service we needed to be delivering in terms of aligning all our processes. And so, that really helped, because when we finally launched live, having been through all the hurdles and the necessary things, we were meant to launch with 3 or 4 practices referring their patients, but I think now it's almost 30 in just 2 months. And the success, my view, the critical success factor for that was working closely with the people that matter, and the people who, at the end of the day, we're trying to serve and provide a good service for. And so what was really clear to them was that we needed to be able to provide a same-day service. And if we could do that as seamlessly as possible, reducing GP time, which was, where the self-referral came in, and making it as seamless as possible using the technology that we'd already built, then that was going to be what was important. And obviously, backed by that, we're doing a proper economic evaluation as well, because, as we all know, that type of data matters. So I think, the fact that we're taking it seriously in that manner, and we're backing it with, University of Plymouth doing that economic evaluation, when people see what we're doing, they say, okay, like was mentioned by the doctor from Sensign Health, working in collaboration with the NHS, they can see, well, actually, these guys are not some scary company that are just trying to destroy what we all love, but actually led really well and trying to make things better for everybody.
Yeah, I mean, obviously, a same-day service is astonishing to access.
services which the NHS are paying for, any service other than maybe A&E that you can walk straight into. But what's the comparison in terms of what would be the average wait for someone before your service was in place?
So, I mean, obviously, I won't say specifics about Cornwall. I mean, they're very forward-thinking as a county and an organisation. But I mean, we know half of referrals into the NHS therapy services is 12 weeks. The wait time. Okay. 3 months. 1 in 10 still waiting a year, and 13% still waiting for a first assessment. And this is pre-COVID data. With COVID, obviously that has changed everything and made things a lot worse. So pre-COVID, it was bad. We know now it's worse. But hopefully, we can look to go beyond Cornwall. But I think that engagement piece is difficult, and I think all the other companies here would no doubt agree that it's something that we're all needing help in and working on.
Okay, well, I think it's a phenomenal, that's a real transformation for people, I think,
Thank you.
Important. So well done. So Dr. Patel, Raina, make sure you come off mute, and would you like to tell us about your adoption strategy and any adaptations you've made along the way?
Thanks. Yeah, of course. I would echo a lot of what's just been said around really understanding the value across stakeholders. And there's just no getting around in the NHS that you do have at least 3 very different stakeholders with very different needs. And actually, unless you cater not necessarily equally, but have them all in mind when you're developing a product, it can fail on any one of those stakeholders, whether it's service managers, whether it's clinicians, or whether it's patients. And I guess for us, one particular feature was patient engagement. We knew that clinicians had fed enough into our tool that they could get value out of it, that they were seeing value in consultations from having the kind of data that we can give them. But where the real gap is in our space in collecting patient-reported data and in delivering patient support is often just whether patients will use a tool, whether they are comfortable with using technology, whether it's applied in the right way or designed in the right way or caters to people who are sight impaired or have neuropathy. And so for us, one particular adaptation in our adoption strategy there was to really build that credibility and trust with the patient community. And for us, that meant, whilst we were also still working with NHS trusts, going really to the patient advocacy space and to charities, and working with organisations like Macmillan and Bowel Cancer UK and Sarcoma UK and CR UK to say, what do people want in these communities? What's the gap in how support is currently provided? And build up trust in a way that they are familiar with and routes that they're familiar with. And so that was a key adaptation to our strategy that we went through and really helped us understand what patient needs were in that space as well.
That's amazing, and I believe you have a sort of pared down version of your application on the App Store. Is that right?
Yeah, absolutely. It was a way for us to just get the app out, even if it's in a basic form, to as many patients as possible, get their feedback, and use that to build better features and more specific features for when we work with particular NHS services. But we've had several thousand patients use the app for going on a year now, and use it very consistently, which dispels some of those myths around the fact that patients won't use technology for the long term. If it provides a use case for them, and if it provides value day to day, I think they really will.
That's amazing. So well done. I think that's tremendous. And I also understand you have a life science strategy. So you're in the cohort of Novartis's Biome program. Is there anything you want to, I think you're the only one who's been on the program like that. Anything you want to pass on to our SME audience about getting into those sorts of programs and what you think the benefits might be for you?
Getting into the programming, I'd say it's much like any other. You just have to understand what that particular organization is looking for. And for us, it's not that different actually to what a lot of academics or clinical academics are looking for, which is better understanding of their patient cohorts around which they can organize better services, and in this case, develop better drugs. And for us, the patient-reported data that you might need to deliver a better service is actually very similar to that you might need to demonstrate quality of life outcomes associated with your drug. So, again, it's the same message, just really understanding what they need. And there's no substitute for talking to as many people as you can and trying to understand what are the daily difficulties, what are the things that prevent them doing their job, what are the things that are a pain for them. And for life science companies, that was sending out paper surveys, getting, by the end of a clinical trial, getting 5-6% back, transcribing them manually into spreadsheets, you know, those things take a huge amount of effort and resource, and are not particularly patient friendly. So, you know, replacing all of that and automating it and making it appealing to patients is really appealing to them.
That's amazing. So thank you very much. So Daph, make sure you come off mute. Just to obviously, I mentioned that you've got your implementation story on Bob around Jersey. Yeah. So any other implementation stuff that you want to share with us, and any adaptations you've made along the way?
Yeah, so I wanted to just reflect on a couple of other deployments actually. So in terms of that adoption strategy, and in particular spread within a trust, I think it's been interesting to contrast our deployments at Imperial and Chelsea Westminster. So at Imperial, clinicians across the specialties were given permission to use Concentric, initially optionally, but we manage user accounts, help get clinicians started, and all those kind of stuff internally, almost exclusively within founders. Whereas at Chelsea, the deployment has been managed by their innovation team, who've been amazing and really engaged, hundreds of WhatsApp messages, you know, almost daily chats about something or other. So at Imperial, we saw slower initial growth, which felt kind of painfully slow for a while. And with clinicians, for example, getting started after a corridor conversation with a current user, often early adopter to early adopter, but across different specialties. Then over the past few weeks and months, we've seen increasingly rapid uptake. That's around 20% week-on-week growth currently, as each of those small nucleuses grows out. So in contrast, Chelsea's been rolled out specialty by specialty. So we've seen increased use in blocks, using go-live dates, changes in expected defaults across pathways, etc. And I think we've learned different things from the two approaches, so both in terms of product market fit and in terms of deployment. So in terms of product market fit, it's been great to see organic growth at Imperial, answering the question for us, without anyone telling clinicians they needed to make a change, would they? And it also meant that we were really close to these users and heard directly from them about any niggles that they were coming up against. But there have clearly been challenges too. Initially, many of those clinicians were flying solo within their department using Concentric, without the support of others to learn together. And any of those differences in processes lead to friction in the system, most commonly in terms of theatre processes in this example. So at Chelsea, those examples, those challenges were less obvious, and it's clearly more akin to the deployments we will plan from now on, and our current corner deployment is very much mirroring the Chelsea approach. It is noticeable, though, that we've learned less from clinicians directly, contacting us, responding with feedback, probably reflecting that difference in how personally invested they were in deciding to start using Concentric. So I think flexibility of adoption strategy is important, certainly initially. And there are probably different lessons that you can learn from each approach.
That's amazing. I watched your video that you've done on the product, and I mean, when you look at how extensive and useful and user-friendly it is, and how much information you're able to transmit to a patient around consent, I don't know how you would have. I don't know how that is done on a paper basis, because when you look at how much the quality of what the patient is now receiving is phenomenal. So really well done, because I think I can really just looking at the video and the demo, you think, wow, as a patient that would be such a better experience. I mean, it's pretty great for the clinicians, but from a patient perspective, going into something really genuinely understand it I think is really so important. So well done on that. So over to our Dr. Rinny at Griffable. How about you? Adoption strategy, any adaptations you would like to share?
Yeah, absolutely. Thanks. So obviously echoing everyone before about user engagement, from the off. So we actually were founded whilst at Imperial College. So we had a lot of access early on in the sort of prototyping phase, especially because we have a physical product. And it's something you need to get into people's hands. So that, of course, is a longer lead time for us in getting that feedback and getting those products out to individuals. But that, of course, I know we've been going for sort of 7 years with user feedback, and I don't think that will ever stop. You know, it's a maturation thing, it's an iteration thing, it's a constant improvement side of it for the adoption strategy. Then in terms of sort of transitioning from, you know, getting that initial feedback and getting the product correct, the real sort of barrier we came, you know, against, and looking at the market as it stood, you know, there are plenty of other companies developing technologies for physical therapy. Yet, if you look, none have been mass adopted. You know, you've got sort of robotics, imaging sort of systems, large workstations, and of course, at Imperial, we had a lot of those in research. But as soon as you went into the real world, and you spoke to the clinicians, the therapists, actually very few of that, well, almost none, especially in the NHS, translate into that space. So for us, it was about finding a way of not going top down with, oh, here's this wonderful technology, listen, the engineers have spent years developing it, it must be adopted. Actually, it was going bottom up and going, what's the current clinical pathway? And can we build something that fits into that pathway that exists already? And counterintuitively, you know, doing startup pitches, one of my first, you know, lines is, we don't disrupt. We disrupt nothing. We come in and we go, this is the thing you're used to. Here's a better way of doing it incrementally. And it actually just fits into your day-to-day. Now, of course, then we build on top of that and go, well, now it can be left with the individual by themselves. It can be transitioned to the home, a pathway that doesn't exist. But getting that initial pathway is the critical part for us. And then in terms of now transitioning from, let's say, that sort of commercial prototype into now a full commercial product, you know, the things that we've had to adapt around are now around procurement. And again, initially, our strategy is very bottom up as opposed to top down. So we're not going into the procurement system, large CCG conversations. We are actually just approaching en masse the therapists that have, you know, a certain budget that they're able to work with, and we fit into that budget, again, fitting into their current pathway. And as a result, we're getting hundreds of units out into multiple sites, as opposed to having to target large individual chunks, if that makes sense.
Yeah, that's amazing. So you have a kind of a trial first model.
That's right, yeah.
Excellent. So I think that's a really interesting concept. I think the trial first model, I think that's really, really, really interesting. So well done on, obviously you said, you know, you launched properly in summer and you've really, you're telling me some of the numbers, you're really accelerating through and really getting your product out there. So really well done on that. So now we will turn to Lucy. So if you come off mute, and if you'd like to tell us about how you're tackling adoption and any adaptations to your implementation.
Thank you. Thanks, Neil. So our adoption strategy is to focus on the NHS first. We do have an international presence, but our focus is on the NHS and acute care trust. And in particular, our lead product, GDM Health, is for pregnant women, so maternity services. And a bit like, you know, other speakers have already talked about, you know, I can't emphasize more the importance of engaging clinicians to understand how they work and to make sure that they can see the benefit, be it in better clinical care or operational efficiency of the use of the technology. And so, you know, we said it already before, bottom-up approach really does work and is really, really important for success. I think also we have spent quite a lot of time, and it's important to us to develop a proper evidence base. So again, as other speakers have said, we've been working with the University of Oxford to develop sort of credible evidence and high quality evidence for our products, and this relentless pursuit of great UX, so that so there is a frictionless use of the technology for both clinicians and patients. And then supporting our clinicians in the implementation process to make, again, that frictionless transition towards using the product in daily practice. And I guess our sort of adaptation we've seen with obviously COVID, that's been an accelerant in terms of remote patient monitoring, which is one of our strengths. And we've had to rapidly help trusts get up and running with remote patient monitoring very quickly, and also implement that remotely. So our implementation and training strategy has had to become remote in itself. So that has been a sort of a learning process for us, but it's worked very well. And you know, GDM Health is now in just under 50% of all maternity trusts in England as of November, compared to 16 in February. So it really has been hugely adopted very, very quickly over this last 6 months.
Amazing. So, well, congratulations on the great traction you're getting, and also congratulations for that beautiful chair that you have in the background. I think we're all a little bit envious of it. It's very, very nice. So thank you very much. So Victoria at Jamf, make sure you come off mute. You have. So your adoption strategy and implementation, how's it going?
Well, we're in a kind of slightly different position. So we're a worldwide organisation, like I said earlier, and I was brought in about 6 months ago to understand healthcare in Europe. And just to echo again what everybody has said, you've all got really good points, and I think we've all adopted parts of those strategies at some point. From a procurement perspective, because that was what I did before I joined Jamf, understanding routes to market was really important. And I think, you know, in Jamf, we're really lucky. We have a number of resellers that are on framework, so the route to market is potentially easier. However, coming from the NHS, and just to touch again on what Lucy said, and it's something we always used to say, is that actually our decisions come from our clinicians. You know, our clinicians are the people that are going to use the technology. They're the people that are going to be having to do this day after day. So whatever our clinicians want is what we should be able to provide, and make it as simple and as easy as possible. Clinical time is so important, and it is so relevant to ensure that they adopt whatever solution they're going to take. So it only echoes what everybody else has already said. But as Jamf, as a company, we have a healthcare strategy that stands. But obviously with COVID, again, it was accelerated, and a new solution called virtual visits was born in response to COVID. I was really lucky. There is a story on bob.health from Oxford Health, so I was really lucky to see that play out. And again, it was the adoption of the patients and the staff that obviously made it work.
Yeah. So yes, there is a story on the platform from one of the team at Oxford Health talking about how they implemented Jamf at a ward level. So there is a story that people can go and read there. So thank you very much, Victoria. And obviously, you, with your procurement hat on, you come at this from quite a different angle to the others. So thank you for sort of bringing that to the fore and explaining that to people. That's really fab. Now, we just wanted to have a moment to I'd asked everybody in preparation for this if there were any particular organisations who'd been wonderful to them on the journey that they sort of stood out to them. So I'm going to prompt two people, and if any other of you want to bundle in, then please just raise your hand and I'll pull you into the chat. But we'll progress through this quickly as we have the bit of the full start, which is eating into our time. But Zane, Kerno Health have been amazing. So who are Kerno Health, and what do you want to say about them?
So Kerno is the Cornish word for Cornwall. And they were established by all the GPs in Cornwall, who have all grouped together as a kind of almost like, it sounds like in Jersey, a digital test bed to enable different companies or different organizations to engage with the services in Cornwall, whatever they may be, and just provide a kind of, a less of a bureaucratic place to start. Obviously, it still takes time and a lot of patience is required, as with anything in the NHS, because you've got to do things properly. But definitely, I mean, probably like most of the founders here, I've been across the country engaging with various people, but with them, with Kerno Health, especially Ollie Sleeman, who's now left, but now Gary Jennings and Tessa, who've been wonderful to work with. So a big shout out to them. Obviously, I don't think they take all projects, but yeah, they're definitely trying to bring a breath of fresh air to the way in which, innovations can be brought to the people that need it.
That's amazing. I mean, when you find with all of us here as people on this journey to sort of navigate the NHS, when you get that organisation that really gets you, understands you, when you solve a real problem for them and they embrace you, it is the best feeling. Our shout out is Professor Vincent, Charles Vincent, and Dr. Jill Bailey at Oxford Health. They have been unbelievably supportive of us, give us access. Mark and I, the co-founders, are actually honorary employees of the trust, and we go to meetings and get so much support from them. So thank you very much to the two of you. I love you both dearly. Thank you very much. And Raina, for you've mentioned Kent, Surrey, Sussex had been quite helpful on your journey. Yeah, definitely. I mean, all of the HSNs, I think, represent a huge step forward in encouraging the adoption of technology, and there's lots of different approaches that they're each using up and down the country. But particularly KSS, I think there's too many people to name, but people like Neela Foley and Rob Berry, who are just tirelessly going above and beyond to help technology scale and really understand from the inside what the precise difficulties are, what concerns a procurement manager might have, and being able to anticipate those and address them head on is something that I think a lot of people couldn't do without these organisations. So we found them brilliantly helpful. Amazing. And Rob actually spoke yesterday along with Hugh McAfee on the track. And Rob is someone who's also helped. Rob Berry at KSS is also someone who has really helped and supported Bob. So I do think great people and a great organisation. So if you can lock in with an HSN, that's going to be amazing. And Cleena may be able to tell us how we do that more effectively later on next year, because they're a key stakeholder in what she's doing with the innovation service. So Daph, do you just quickly, Jersey was an interesting one. Is it, if you come off mute, is it Health X is the name of the sandbox? Is that right?
Yeah, so HealthX. So there's the Allen Lab was kind of born out of work in VR in Jersey and the kind of role for that. There's a couple of interesting things in terms of Jersey's approach. Now, clearly they're on an island. They have a government of Jersey. They can do things a little bit differently, and there's a bit more flexibility to do that. But they also have to kind of manage interesting relationships around care across onto the mainland, as it were. So they have relationships with the South Coast, with Oxford, different places. So they've tried to be a couple of steps ahead in many ways in terms of the kind of remote journey, and in many ways they're kind of playing around with the VR stuff and to solve some of those problems quite early. But yeah, from our perspective, we've got a few examples like kind of the Chelsea and Imperial stories that we've talked about, but then Jersey felt quite different. It's quite noticeable. I went over to Jersey for a week in just before COVID. It was February or so, and we basically went from we'd be quite keen to do this to on Monday to Friday being like, yep, we're gonna actually do this. And there was kind of a meeting on the first floor with some clinicians, and then we kind of at the end of that meeting went up to the second floor and had some conversations with the manager, and then a couple of the managers went up another floor 5 minutes later and had a conversation with the Minister of Health, and it was kind of, yeah, okay, we're going to kind of do it. And it was like, oh, that's kind of weird. That's kind of a different approach. But yeah, so
amazing. Well,
sandbox stuff does work when there's the right people involved. Yeah,
that's amazing. So have a read of the story on the Bob platform, which is bob.health. And I think everyone's going to be running to Jersey now as soon as they get allowed to get on a plane to go and see if they can get an implementation secondary care. But Kerno sounds great as well, Kerno Health for primary care in Cornwall. Zane, just to let you know, someone has put a question in that says, can other regions take part? Can other people get involved?
Absolutely. Yeah, can get involved, yes.
So
contact us. Yeah, we've got a national network of therapists. Separately to the NHS, we're serving universities helping their students in the UK and actually studying in Europe because they're in lockdown away from their families. We're serving charities and other organizations. So we've got a national network of therapists that are plugged into our platform that could be deployed anywhere.
Amazing. So hopefully, let's hope that this little session at Giant maybe helped you get a whole nother region in the bag. If you're the person who asked that question, Zane's email is in the chat. So ping him an email, tell him that you listened to him on Giant, and let's get the ball rolling for a whole nother region. So Zane, a top tip that you wish you'd known. So if I can just, in a minute, a top tip that you wish you'd known before you started your adoption journey, what would you like to, so therefore imparting a gem of knowledge to our audience?
I'll be honest, I would have loved to have known about this digital test bed sandbox stuff. I had no idea, if you go back to me 18 months ago, I didn't know that existed. Obviously, investors generally don't know that kind of stuff exists. So I think I've found working with AHSNs can be very difficult. I've met lots of them, I'll be honest. I'm not saying don't work with AHSNs because everybody's product is different and their needs are different. But I think that's very important. I think also patience. You need to kiss a lot of frogs. You need to go. It's hard. NHS is not easy. You have to, as a startup, when you're starting, at the beginning, you need to have an alternative strategy unless you've got something really, really super duper focused on NHS. Otherwise, you're just going to run out of money.
Yeah.
So that's the brutal reality, and what I tell a lot of medical students who seem to be contacting me on LinkedIn every day. You're not going to get your product into the NHS tomorrow. You're going to have to travel. Me and Rachel, my co-founder, have been on a train to all kinds of places. So you need patience, you need determination, but also you need to be realistic. You need that data, like Dr. Lucy said, that proves what you do works. And 9 times out of 10, the only way you're going to go and do that is B2C. And going B2C initially means you need money.
That is a challenge. I think it's a side of what we're doing that people don't get. You kind of because you're slogging away with your end users, but you're also trying to raise money, and it's a really interesting work. It's like a whole nother element of your job.
Yeah.
Other than just trying to get your product into the market. So
and you need to show it works.
Absolutely.
You can't come up with an idea. You've got to show it works.
Wonderful. Well, thank you very much, Zane, and I hope that you get your lead via chat. So, Raina, how about you? What's the thing that you wish you'd known before you started?
All of the above. It takes time, it takes patience, it's slow. I think just to touch on one area of what we just mentioned, the evaluation and having the evidence, I think it's really cool, and you're never going to be able to scale in the NHS without that. But I think particular to that, something that we really have doubled down on the value of is getting the evaluation question right. There's all sorts of things that you can prove with any study. There are all sorts of things that you could argue have benefit to patients or to services or to clinicians, but aligning that evaluation question to what is the highest priority and not trying to prove too much, but really focusing on what is the absolute highest value add that you can prove with an evaluation study or with research. That's the thing that I think has been difficult and worth spending time on.
Amazing. Thank you for that insight. Thank you. So Daph, over to you. Remember to unmute your line so that we can hear you.
Again, kind of same as lots of the above. I just wanted to pick up a little bit more on the kind of collaboration piece. So I think, framing that adoption approach around collaboration rather than sales, doubling down on those collaborative relationships, because we know that selling in healthcare is hard, but forging collaborations often actually in the end they have the similar same commercial terms. It feels much easier, it's so much more enjoyable, it's better for everyone's mental health. So, work hard to find those that share the same passion for the problem you're tackling and solving, but they just happen to be sitting on the other side of the fence, that they're within the healthcare organization rather than you on the kind of side of industry. Double down on, invest time in those relationships and collaborations. So if there are those listening to this who feel they're in that kind of boat, get in touch. We'd love to help. we can help this winter, do get in touch.
Amazing. So yeah, I mean, it is hugely important, and a question actually has come in, and I will come on to Paul in a sec, is talking about the fact that, you know, what if you've got like an innovation which no one's even ever heard of, so it's so innovative, people don't even know there's an unmet need. I mean, that is a huge challenge, because at the end of the day, we're trying to solve a problem the NHS has with what we're doing. And obviously, if you have got something totally groundbreaking, and maybe I'll ask Cleaner how someone with that type of innovation, where there is no current demand, how that fits in. So we'll ask her that. So I'll give her some time to think about it before, as we come through with our other SMEs. So Paul, what do you wish you'd known at the start of this journey?
Top tip, yeah. So I suppose one thing that I regret is not recording a lot of the feedback information early on, and just be meticulous about recording those interactions. You know, whether it's with the patients or the therapists or anyone, and just getting that down. So I recommend doing that as a critical part of your process. Even when it's the early stages, even if it's a random conversation, make sure you get the permission even to say, do you mind if I record that as a bit of feedback, as a quote, etc., etc. Because once you build that base, as well as building this is how it works and the evidence base, the two together are exceptionally powerful. And I think that's led us to now really building our, for example, clinical advisory boards, really driving a term we have called grippable therapists. So these are people that are sort of advocating or trained on the system. And actually, once you have that base of those individuals, it's less about talking to you. It's more about people networking and talking to each other. And that's how we're spreading the word. People are coming to us because they've spoken to someone who's interacted with it, because we've brought down certain barriers to adoption, as you said, trial first and those sort of things. But so yeah, those are my two things. Record everything, because it really eventually does build a huge case, and then it allows for that sort of spreading of the word, as well as you build your sort of clinical advisory boards and a much wider network.
Amazing advice. I would just add to that as an SME, just to say, is when you do interview people and try to understand the customer needs, is just be super objective. I'm a comms man by training. I was a microbiologist, then a comms man. I'm really good at selling things to someone, as opposed to being objective and actually listening to them. So I've had to learn that skill as an SME, is to really understand what the customer needs is, but not to push what you've got onto them, but really listen to what it is they need in that process. And I think recording it is really key. Thankfully, my co-founder Mark is really good at that kind of discipline, because that wouldn't be my style, but he is very good at it. Thank you, Mark. So Lucy, what's your top tip?
So I guess, I mean, our challenge has been rapidly trying to deploy some software products into a number of trusts over the last 6 months. I mean, there is a huge variance in clinical practice and business practice, actually, between the trusts, and one size does not fit all. And so I think it really pays to understand the clinical landscape, and also to ensure what it is that the trust is trying to get out of, using your technology. And so I think it's really trying to help the trust to understand that change management processes need to be put in place and thought about before the technology goes in. And then, as other speakers have said, then really picking out the core purpose of what that technology is hoping that trust is hoping it's going to do, and measure it. And it might be different for different trusts, because the clinical landscape and the way that they deliver care is different in different trusts. And so it really pays to spend a bit of time, or to encourage the trust to resource that change management, so that we can really maximize the benefits of digital technology.
Amazing. Thank you, Lucy. And then Victoria, what do you wish you'd known? Obviously, you've come from the NHS world into the commercial world, so probably there's lots of learnings for you, but what do you want to pass on?
So I think from my NHS experience, so I've talked to a lot of people about the fact that I was that procurement manager that wouldn't entertain people who would phone up with sales inquiries. I was the person that didn't have time to understand what people were trying to sell me. From being on that side to now being on this side, I think you're absolutely right, Neil. And it's something that I learned being on the other side is listening. And it is about understanding. And when people are looking at technology, whilst they may have an ideal of how they want it to be, they don't necessarily understand how to get to that point. So just by listening to them and understanding, and again, like what you said, you know, not promoting what you're doing, but understanding what they want to do and actually map it out with them so that you're working in an alignment rather than against each other, I think is probably the biggest thing to take away.
Amazing. Thank you for that, Victoria. That's fantastic. So just to say, we're heading to the end of our session. Jocelyn Aloma has submitted some good questions. She's saying SMEs are delivering brilliant solutions. So thank you, Jocelyn. Yes, we are. And I just wanted to, apparently she's flagged something, she's flagged to Zane and Raina that they've got something that she could talk to you about. It's called Nuva. So anyway, I'm going to ask her to email you. So Jocelyn, please email Zane and Raina if you think that will be useful for them. And then there is a question, someone has commented around around AHSNs that they might not be the perfect solution, but the fact is the HSNs is just one of many stakeholders to enter the system. So HSNs aren't the be all and end all. They are hugely useful. And my reflection on HSNs is that they're all very different. So they're not all, they're called HSNs. There are 15 of them, but they're all structured and run in slightly different ways. So it might not just be based on geography. Some of them have different programs which might be more relevant. So don't take HSN's experience with one where you don't get through. It might not, there could be other ones to go through, but the innovation service might help solve all that. So I'm going to bring Cleona back in. So we've got about 4 or 5 minutes to your reflections on having heard this. You know, you've understood the landscape. Any reflections?
Well, I guess, first of all, I'm going to apologize because I think I'm going to bore a lot of you because all the innovators have spoken quite a lot of truth, and I'm going to actually have to just echo them and a lot of what they've been sharing. I think that, you know, you also asked me to speak about a bit the truly groundbreaking innovations and what to do with them. I think I also want to respond to the comment about the HSNs, and I think Etar Al-Ali's comment was about, you know, procurement actually route often being the thing that kills things off in the long run. And I mean, I don't feel like we have enough time to go into the detail, but there's definitely work as part of the innovation service about building that long view of what's coming down the innovation pipeline so that that forward planning for procurement can occur, so that they don't fall off a cliff edge at the end when they are now ready for entering supplier route. So I think that's one thing which we want to respond to quickly there. I think, you know, your question earlier about, you know, the truly groundbreaking innovations, and I think how they can best get into the NHS. I think, again, there's a lot of insight played back for the different SMEs about the best way to approach this. And I think my advice would be, you know, if you think you have something that's truly different and that's solving a need in a way that nothing else is, start testing that assumption as quickly as possible. Start testing that idea absolutely as fast as you can. With any support organization, with clinicians, with as many people who will listen to you, because there are lots there of people on the ground who will be able to tell you, is this a genuine problem that needs to be solved? Like, they mightn't be able to say, you know, a digital or something or the other solution is what's needed, but they'll tell you if it actually needs to be solved or not, if it's a genuine problem. And they also have a sense of the appetite on the ground for such disruptive change or not for disruptive change and what that should be. And, you know, I think one of the most important things to keep in mind with innovation is that what's key is not just the innovation, the product or the service itself, but it's fit with everything else that goes around it. And what's really important to do is to build that strategy then about, you know, tweaking it to be a little bit more a better fit for existing services. You know, we are not going to disrupt much, or actually going all the way to, yeah, we are going to disrupt a lot of things because there's appetite for that, because now is the right time for change. And work through that and present those options with your stakeholders in a collaborative way, rather than presenting to them, you need disruption and I have the solution, because that really will get a better fit for people's needs, and it really will enable much more effective working. And yes, I would agree with David about it's better for everybody's mental health and working relationships as well. And there are a number of different support organizations you will have seen in the slides earlier who can help you with a lot of that. But I think, you know, I want to just share, I think, 3 other reflections. The first is like the trickier, potentially more controversial one, which is about evidence, which everybody gets nervous about. But, you know, as everyone here has said on the call, it's absolutely critical. You know, you need to prove that it actually works. And I think my advice to most SMEs would be just to try and get to grips as quickly as possible with what evidence means, both for your innovation and also what types of evidence are looked for. Like, it will generally not just be it worked in a trial. It will also be something about, does this deliver the same benefits when it's actually used in practice, with all of the messy, complicated things that happen in the NHS and at scale? And I think, you know, that's one of the real critical reasons we're developing the innovation service, to provide better clarity on this. And to really work through the detail about it. What is the key research question for your innovation? As Raina said earlier. I think the second thing, which I'd really agree with, is collaboration mindset is key. You know, just pivoting away from that sales mindset into collaboration, and it'll open so many doors for you. You'll get so much more honest advice, and you'll also get so much such better social capital, to be honest. And I think it's great to hear about collaboration mindset, both with the NHS, but also I see innovators doing that really effectively with each other. And that's one thing that really impresses me about the health tech innovation community, about how willing they are to help each other, which is, I guess, linked to the intrinsic motivation, like, of why somebody goes into health tech innovation rather than innovation in a different sector. I think just the final point, which is again linked to that intrinsic motivation, you know, I think the whole rest of the team gets so much energy from speaking to innovators, because we see people who have intrinsic motivation, who don't care about doing something, but want to do something well for the benefit of patients, for the benefit of the NHS, and who have that real willingness to change, and willingness to change what they're doing to make sure, you know, it's going to help the doctors, the nurses, the ward clerks, everybody who's going to be using it, the GPs, the secretaries. And I think I'm always so impressed to hear just how holistic they are in thinking about stakeholders and how much they value the input of every stakeholder. And I would say also, who you listen to is absolutely critical. Listening to as wide a range of people, and in particular when there is then trade-offs between, you know, people with different power and status within a given service. And I'm really glad to hear so many people role modeling this appropriately on this call as well. And I think, yeah, for me, I think the future looks bright within health innovation when I hear people speaking in these ways, and it gets me very excited. You're on mute, Neil.
Well done. I did a little cough on mute earlier. So thank you so much, everybody, for listening in. Thank you to Zane, Raina, Daph, Paul, Lucy, Victoria, and Kleena for their amazing contributions. Everyone is doing amazing work, and we really do wish them all really well. So please reach out to them. Jocelyn, who I assigned the wrong gender. Jocelyn is in fact a gentleman, so you may well hear from Jocelyn, Zane, and Raina. And so, yeah, thank you so much. I mean, being an SME, being a startup and scale up is hard work. We kind of have to lean into it. You have to push and be patient, and that's something that Raina said. You've got to realize that things are going to take time, so you've got to be patient and push through, but keep the faith, and we will deliver great things and solutions to patients. So thank you so much, everybody, for listening in, and thank you to our panel. So take care and enjoy the rest of the conference. think we're done. So thank you very much, those of you who were left. Thank you so much. I hope that was useful, and yeah, good luck. So I'll follow up on email, but good luck with everything you're doing, and maybe we'll all be able to meet up in the summer for a drink. We'll have a little Bob speakers gathering and get all together and actually meet each other in person. So thank you very much.
That's great. Thank you.
Thank you.
Bye. Bye.
Bye-bye.
You work for the NHS. You've had a great idea, you've made it happen, and it's made a big difference to how we can learn from COVID-19 and enter a new normal. Ideas like yours drive improvement and they deserve to be shared. That's what Bob does. Amplifying good ideas like yours across the NHS so as many people as possible can learn from, adapt and implement your idea. The further good ideas are shared by the Bob community who learn from them, the greater improvement we can achieve. You made a change. Share your solution with others. Speak to Bob.
Good morning, everybody. I'm here today talking to you from Bob Health. I'm Nick Voke and I'm the quality manager. Until recently, I worked in the NHS and I can just really see the worth for needing somewhere for people to share their good practice and the how-to. So thank you for joining us this morning. This session is all about building confidence and sharing all the good ideas that you can then share with your NHS colleagues. And we've got a great range of speakers, so I'd just like to hand over straight to them so that they can introduce themselves to you. We'll start with Anu.
Good morning, everyone. My name's Anu Obaro. I'm a radiologist at St Mark's Hospital in London, and I'm really excited to be here with you today to share an impact story about an anti-racism presentation that I gave earlier this year.
Hi everybody, my name's Nikki. I'm an exercise physiologist with the cardiac rehab team at University Hospital North Midlands. And myself and my colleague Sonia, we're sharing our story today about how our teams adapted during the COVID pandemic and how it's impacting on us and our patients.
Hello everyone, I'm Sonia Lockett and I'm the service lead for cardiac rehabilitation at the University Hospitals of North Midlands NHS Trust, and we're looking very much at how we've developed a virtual mode of delivery for our rehabilitation programme that was particularly important during the pandemic. So that was making use of video consultations and using our YouTube channel and social media platform to be able to provide that virtual programme for patients.
Morning, my name's Scarlett. I'm a final year medical student and I'm an intern for a project called CarbMedic, which was founded by an NHS anaesthetist, Dr. Rachel Grimaldi. And CarbMedic's a digital communication tool with an A to Z list of flashcards all related to patient care and management.
Hi, good morning, everybody. My name is Sami Noor. I worked in the NHS for about 15 years or so in various roles, from commissioning, program management, working at various provider level organizations to commissioning level services like STPs, ICSs, as well as national bodies like Department of Health, Public Health England. I am currently a digital health specialist, and I'm also Director of Strategic Development and Partnership at a company called Fibris.
Amazing. So, as you can see, there's so many people talking from different kinds of projects, but what I'd really look at is the nuances between and why we all decided to share what we shared. So the first question that I'd like to put to you all is, what's your main call to action from your project?
Thanks, Nick. So I think for my particular project, I wanted to share some personal experience about racism and the way that that impacts the experience of people of colour, and also how that impacts healthcare outcomes for our patients. And the precipitant was George Floyd's death in May, and followed, or kind of in the middle of the pandemic exploding, and the realization that certain communities were being more affected than others. I think what I wanted out of sharing my experience and some research that I did was to really encourage people to think more broadly about what it means to be Black or Asian or from an ethnic minority in our society, and how that affects our professional relationship with our medical colleagues, and also how we deliver healthcare. And so hopefully people will feel empowered and motivated to address some of those inequalities.
Amazing.
So for our project, we were a predominantly community-based cardiac rehab service, running clinics and exercise sessions from a variety of different places. So we operated from 2 hospital sites and largely community leisure centres, gyms, swimming pools and so on. So at the beginning of the pandemic, obviously these were ceased very quickly, and the ceasing of the face-to-face services at the hospital happened very quickly, and the same with the gyms and the closure of the leisure centres. So very quickly we had to adapt the way that we delivered our service in order to meet the needs of the patients. So quickly we sort of changed to a virtual model. We delivered sort of video clinics via Attend Anywhere with telephone clinics, and in the first few weeks and months of the pandemic we produced exercise videos, different series, podcasts and educational videos for our patients to try and deliver that service to them. Obviously our patient group were a high risk group, and they were the sort of group of patients that were really had a lot of questions at the beginning of the pandemic, and there was a lot of uncertainty. So for us the initial sort of call to action was the need of the patient, to be able to provide a service to them, especially when a lot of the other community services and GP services were sort of more difficult to access at that point. So we quickly partnered with a charity, Pumping Marvellous, a heart failure charity, to deliver live exercise sessions as well to their heart failure community, most of which were shielding at that time. And so it was really through the partnership with Pumping Marvellous that led us on to getting in touch with yourselves at Bob. I think I spoke to Chloe, and we shared our story of how our service had adapted during the pandemic, so that others could hopefully either learn or take some sort of notes from what we've done.
Perfect.
Yeah, and just to add on really from what Nikki has said there, I think definitely the driving force for the call to action for us was that sort of patient focus and the need to be able to support very vulnerable groups, especially considering some of their other appointments and routine follow-ups may not be happening in the same way. And I think as well alongside that was the fact that the commissioners very quickly came out in support of rehabilitation services for cardiovascular patient groups, knowing the effect that could have on readmission rates and the appropriate use of healthcare services. So I think that also helped to spur us on in terms of making sure that we had a delivery and a way to access patients, and making sure that our service was very visible to the trust and our wider community, and that we were still accepting referrals and delivering a service. And I think from my point of view, looking at it from a staff perspective as well, obviously this year has meant that we've needed to work very differently, and we've needed to work remotely, and a lot of our staff have been picking up new roles and responsibilities, particularly within their clinical caseload, and obviously it's more challenging then to offer that staff training and that clinical supervision and support that's needed when people are picking up those new roles. And I think platforms like Attend Anywhere and for our trust Microsoft Teams have been really useful to enable us to keep on with that MDT contact and that relevant level of support for our staff as well.
Definitely.
So Rachel, Dr. Gamaldi, had the idea of CardMedic after reading about a patient who described feeling very frightened on the intensive care unit when he wasn't able to understand what healthcare staff were trying to say to him through the PPE. And as a lot of us know, and many of us know, that wearing PPE removes people's ability to lip read. It takes away facial expressions and reduces clarity of the voice. So what's already a very scary experience for patients was being intensified due to this communication barrier. And what CardMedic provides is a free, very easily accessible platform with the range of flashcards that healthcare professionals can use to communicate more effectively with their patients. From being like a medical student, I've kind of had a step back and realised how the pandemic has exacerbated inequalities in healthcare. So in respect to communication, where the PPE barrier has intensified challenges already faced in some groups, such as those with language barriers or communication difficulties. So CardMedic aims to improve patient care and experience, and also patient safety too.
I mean, from my side, excuse me, my main call to action for all my NHS colleagues and suppliers into the NHS is two things really: simplify and break the silos. So unfortunately, within the NHS, we're by design, we've had to kind of work within the various departments and organizations that we're affiliated with, but more often than not, there's so much crossover and cross-pollination that occurs, but sometimes we do unfortunately kind of get stuck into our little bubble and kind of view our work with blinkers on. My main call to action, and has been for a while now, has just been, work across the aisle, work along with all providers, commissioners, whether it's urgent care, primary care, mental health, work with the different suppliers and organizations that are delivering work in the NHS, and try and think about services from the perspective of a patient, which I'll talk about a little bit later. But it's our job, speaking from an NHS perspective, and anyone delivering services into the NHS, has to be the patient, and putting the patient's needs first and thinking about how they're receiving the information that you're sharing. And we can talk about that a little bit later.
Perfect. Thank you ever so much, guys. And like we're saying, it's that commonality of we want to make things better for our patients, and the best way that we can do that is by just aligning our work and making sure that we're sharing what we know. So really, on the back of that, what I'd like to put forward is ask you, what's your best experience of sharing?
Thanks, Nick. I think my project or my topic is one that's so emotive and contentious, and can be really awkward or difficult or uncomfortable to talk about. And so when I decided to present, I wasn't really sure what the reception was going to be. I didn't really know what people would think. I was speaking, I guess, from a place of pain and vulnerability about what was happening around me, and really didn't have any idea of how that would be received by anyone of any race. And so so there was this kind of anticipation or concern, and then once the talk was delivered and done, the feedback has been overwhelming. And I think for me, the best thing that has come out of that is hearing people say that they have a different kind of understanding or a different type of appreciation for some of the challenges that we're facing, and on a really personal level, people feeling motivated or convicted to be proactive about being anti-racist, and to speak out and to challenge structures within their departments or within their kids' schools, or not just kind of limited to within the NHS sphere, but recognizing that we can have influence in all of the areas of our lives, and that's far greater a response or impact than I could have ever imagined. So I think for me that's kind of made the pain of sharing and stepping out worth it.
Absolutely.
So for myself, it's really just recognition of the work that we've done from other teams, from other departments, alongside patients as well. So it's kind of reassuring to know that the work that we've put in and all the hard work that we've done has not gone unnoticed, really. And I think sometimes within the NHS and within cardiac rehab, there are barriers to sharing information. And I think that can come from, your sort of information governance side of things, your trust side of things, but also I think sometimes people can be quite protective of their own ideas and not necessarily want to always sort of put that out there. And I think often with a lot of the sort of big conferences and talks and things, people, if you're in the sort of the right group, your stories get shared. Whereas often, you know, if you're not necessarily within that group, your stories can sort of get missed. And so I think for ourselves, sharing our story and sharing what we'd done during the pandemic, the fact that we had so many other teams come to us to ask how we'd done things and how we'd initiated and set up certain things made it really sort of worthwhile to know that actually we have helped not only the patients, but other staff and people from a broader background as well. And I think for myself, really, for me, it's just sort of day-to-day run-of-the-mill kind of things, really. You know, it was needed at the time for us to create this virtual service to provide that for the patient, but actually in me thinking that it's just a sort of everyday kind of simple story, and it sort of brought home to me that actually sometimes that's not so simple to them, and they needed just that little bit of extra help to work out how to go about and do things. We had teams contact us from Canada, from Malaysia, from various places in the UK to ask how we'd set our services up. So that was really reassuring, and also the fact that we partnered with Pumping Marvellous meant that we could reach out to a whole range of the heart failure community. You know, they have tens of thousands of followers in their community, so that was really good that we could get that recognition from them as well. So it's been really useful, like I say, to share with other members of our cardiac rehab community as well, and get that sort of recognition and reassurance from them.
Great stuff. Now,
yeah, I totally agree with Nikki's points there in terms of that visibility and that transparency that we've had, especially with sharing our content on public channels like YouTube and with our social media pages. It's given a place for other services to be able to see the work that we're doing and be able to contact us and be able to use our resources, which I think has been really important, that sharing element, particularly during a pandemic where people were really just finding their feet and trying to deliver those essential services in the best way that they could, and the challenges that came with that, and the fact that we needed to use that digital model, certainly during lockdown. So I think for us as well, realising that a lot of that content doesn't just benefit the cardiac rehabilitation communities, and that actually some of that contact has been from those wider rehabilitation services, things like respiratory and elderly care, and also our musculoskeletal outpatients and therapies departments that may not have been in a position to be able to produce that material, but it's actually really beneficial for their patient groups. So I think that's been a really good experience for us of sharing our resources and content. And I think the COVID pandemic in general has made the NHS more willing to share and look broader and look at how we can support other specialities. And I think probably for me that visibility on the social media platforms also allows the trust in the commissioners to see the work that we're doing. And I think it shows that we're very willing to work in new ways and adopt new ways of practice. And I think that then gives you more opportunities, and you find that more good opportunities come your way. So for us, what started out as a digital platform and making use of video clinics and the YouTube channel and social media, quickly with the commissioners realising the work we were doing, then give us the opportunity to make use of an online patient platform, so a patient library, which is Recap Health, which has helped to improve that service delivery, and also for our face-to-face work, being able to have funding for fitness tracker watches, so that we're able to provide that remote monitoring for patients. And I think all those other opportunities and funding pots have come from the fact that people could see the service that we were delivering, and that we were still very much operational for our patients.
Thanks, Sonia.
So I think my best experience of sharing was right at the beginning of the pandemic, where I was able to help as part of a pilot evaluation of CardMedic. And this was the best experience because it gave us a good initial idea of how it was helping patients. So we asked for 10 volunteers, and we, wearing level 3 PPE, asked these volunteers the same questions with the CardMedic flashcards and without the flashcards, just to see if it improved their patient, the understanding they had, which it did. And as a medical student, this was quite a new, exciting experience, and I learned a lot doing it. It's also taught me how it's important about how you use any innovation to get the best out of it. For example, like basic things, like we laminated the flashcards and the light was shining on the flashcard, which limited the patient's ability to actually read the words. So just small things like that that actually make a really huge difference to how it's best put into practice. And when appropriate, also share CardMedic with other students and other healthcare professionals on placement. And I think it's also, for students, it's really beneficial from an educational perspective as well, in that the flashcards are written in language that is appropriate and easily understandable, avoiding that medical jargon, and therefore improving communication skills for students.
So one of my fondest experiences of sharing was probably maybe tail end of 2017, beginning of 2018, when we were embarking on the online consultations program of work, which is essentially the ability to kind of enter the primary care or your GP practice through a digital entry point initially. I was leading on that work in Southwest London STP, and we were off, writing procurement specifications, and looked over, and my urgent care colleagues were leading on something called 111 online, which again was an online entry point into the urgent care pathway. I sat down with our teams collectively and said, look, we're basically doing the same thing, one from a primary care perspective, one from urgent care. It shouldn't really be for the patient to decide whether or not their service is urgent or primary care, but it should be for us as the NHS to navigate that and to push them through whatever services and system we determine they need to go through. So we set up a joint working panel along primary and urgent care, and we wrote a specification that met the needs of both, and we went off and started the procurement process for a single entry point into from a digital perspective into the NHS in our patch. I delivered that procurement and that program of work, and then following that specification procurement that we did, that was then shared by the procurement hub, to give props where it's due, the DPS procurement hub across the country, as what they deemed the gold standard of procuring digital services, and it became like the embryonic template for what is now Digital First, which is a national program of work, but essentially kind of working across colleagues that sometimes might be sitting 2 tables away from you in the NHS, pre-pandemic obviously, when we're all working from home, kind of making sure that our work is aligned and simplifying the message for patients, because I think a lot of the time it's quite easy to work in our silos and not really think about how the message is being received out there in the real world. So yeah, I think that's one of the things that I'm quite fond of.
That's great, Sammy. And it's the running theme throughout is it's just about making things simplified for our patients, but also for accessibility for patients as well. It's so key. So I just wanted to ask from that, what do you feel that enabled you to share well? And I'd really like to just really focus in on who or what gave you the confidence to do so.
Thanks. I think I didn't know how I was going to share. I didn't know who I was going to talk to, and I took an opportunity to ask the dean of our academic institute, which is part of our hospital, if I could speak at a grand round. And our grand rounds are usually reserved for clinical discussions. We have internal and external speakers that come and speak on a Friday morning, and I essentially volunteered to say, can I use that forum to share some stuff? And she was really instrumental in providing me giving me permission to talk to our professional audience, and also creating a safe space really where I felt comfortable to share honestly and openly, and I think without her support and the wider support of the chief exec of our hospital, which is part of a much bigger trust, and also them really publicizing the talk and highlighting that yes, this is a departure from our normal content, but it's really important that as many of you attend. I certainly wouldn't have had the confidence to go through with it, and I think both of them together created a forum that allowed me to communicate with my colleagues, and then for us to also have open up some dialogue and have great Q&A, and out of that have spun many other conversations, and the ripple effect has been huge. So my gratitude goes to both of them for allowing me that access and then for supporting me through that process.
Amazing.
So for our project, predominantly being the sort of video side of things, video production for exercise videos, education videos and podcasts and so on, there's a few people really, I would say obviously Sonia, she sort of enabled me to take that upon myself to get those videos and things produced. We'd always had the idea that we would go into more of a virtual cardiac rehab model. There'd always been talk about that pre-pandemic, but obviously COVID sort of hurried that along somewhat, and so we, in the first few weeks, like I say, we were really busy at producing all of this sort of virtual content for our patients. So definitely the fact that Sonia and the trust, the people above her, the directorate, that they had the trust in us to produce these and to do this for our patients, that really enabled us to do it. But also the rest of the team as well. They all helped in producing these videos, all got involved. People who perhaps initially wouldn't be their first idea of fun really, but actually everybody's got involved and really helped out with that. So various different people really, and in terms of sharing the story and sharing what we've done and how we've done it, I would say again, yourselves at Bob, you've really helped out with that in sort of spreading that to a wider audience, and the same with the Pumping Marvellous charity as well, in sort of allowing our story to be told to a whole broader range of people that it wouldn't have been beforehand. So yeah, various different people, and I think it's all really helped, like I say, in spreading that information for us that actually has helped then other teams as well.
Cool.
Yeah, I think there's probably lots of small enablers along the way that then add up into a big effect in terms of that sharing and the project delivery. I think definitely the team and the ability and the skill set within the team to be able to deliver on those targets. And I think as well, COVID-19 in a way, I think acted like an enabler in that it did sort of temporarily put that pause button on the service and allow us to think in a slightly different way and consider new ways of working that we might not have done before. And I think it also acted as an enabler for our patient group as well. I think in general for rehabilitation and long-term conditions and certainly elderly patient groups, there is a feeling in healthcare that they may not be people that would engage with technology and digital platforms, which has caused a hesitancy and the adoption of that, I think, in healthcare for some groups. And I think what COVID did was enable everybody to get more comfortable with using technology and using the devices, and if they were using that to interact with family and friends, then actually it wasn't too much of a stretch to then use that in terms of healthcare appointments and delivery as well, which I think really enabled our service delivery. And definitely platforms as such as yourself to provide a place for people to see the work that's been done and have that how-to in terms of the approach that people can take. But yeah, I think there's definitely lots of small enablers that I think then add up to a big effect for you along the way.
That's a really interesting point.
I think as a student, it can be quite daunting to speak up when you have a suggestion or idea, and tricky to gain the confidence to do that. I think prior to working with Rachel on Carb Medic, I don't think I've had the confidence to suggest Carb Medic as I have on placement. Where I've seen patients where communication's been difficult, I felt able to share Carb Medic with the clinical team, and having used it myself in clinical practice, have had some really helpful feedback from patients, emphasising how much it's improved their understanding about their care. A group that's definitely had a large part in me feeling able to share Carb Medic is a group of speech and language therapists and learning disability nurses who have been working with since May time to create accessible versions of all the flashcards using simple English and symbols. And I've learned a lot about communication from this group, all of which I'll definitely take with me throughout my career. I think the person who's definitely given me the most confidence, though, is Rachel herself, who founded Carb Medic. I've been very lucky to have this opportunity, and she's given me the confidence to learn lots of new, albeit initially very scary, new skills and use Carb Medic on placement too.
Amazing.
So I think in my career, there's probably been a few individuals that have definitely encouraged sharing and empowered, those around them to be a bit more kind of free thinking and thinking outside the box in their approach. The entities that have probably really kind of accelerated this for me have been some of those organizations that are outside of your specific area of work. So mainly things like academic health science networks. Some of the Royal Colleges have been incredibly helpful in just kind of understanding what it is that you're doing in your local area or nationally or wherever, and then taking that and putting it into something that's quite accessible to anybody and everyone to kind of view. I think that's been a really, really useful kind of resource. I think across the NHS we have so many incredible organizations and individuals that it's quite easy to kind of get lost amongst the 1.8 million employees of the NHS or the various different trusts and practices and you name it. But there are wonderful things and services out there. Just kind of finding them is sometimes the difficulty, and getting a platform that has, or having a platform or a space that you can go to just to kind of get ideas or find people that maybe are doing something similar to what you're doing or thinking about doing is probably the challenge.
Absolutely. Thank you so much, guys. And it just leads on really well to the next question, which is sort of like you've all got some great projects that you've been working on, and that you're saying you've got lots of questions that you've been asked and so forth. And just wanted to ask you, do you feel that having a how-to guide offers a real benefit for yourselves and also for your audience to be able to use as reference points to look into what projects you've been doing and potentially try to replicate where they work?
So the short answer is yes, absolutely, 100%. I think whenever you embark on something new or innovative or different, often you can kind of just be muddling your way through and kind of pulling things together. And it's only when you look back on your process that you can really kind of understand with clarity what you did and why. And I think for the individual or for the team, that retrospective reflection is so valuable because in the moment it can be really difficult to kind of take stock of that. But looking back, I think it provides invaluable insights. And I think what I've really benefited from writing my process or impact story for Bob is being able to capture all of those kind of different thoughts, different intentions, all the different resources, the decisions that I kind of made that I didn't even really consider how I was making, and kind of refining that into like a piece of reflective work or an impact story has meant that for all the people that said, how did you do it? Where did you do it? Where did you read this? What did you do? How did you pull together? Where was the data from? You know, now there's something that I can kind of point to be like, look, all the answers are here. If you want to do something similar, this was my process. These are the things that maybe I shouldn't have done, that I wish that I didn't do, or that I would do differently. And I think that's so valuable for the team or for the individual. It has been for me, but also it means that the positive impact that the project has had can be replicated elsewhere by other people that want to do it. And what's really nice about Bob is that that applies to something like the project I did, which is so different from everybody else, but those principles still apply and still can be used, and you get the advantage of that.
Amazing.
Yeah, I completely agree with everything that Anu said there, really. I think looking back, when you've written particularly an impact story, looking back on your own work is really good for sort of self-assurance, to realise actually that, you know, you've perhaps done more than you think you've done. You know, quite agree that when you're in the midst of doing something or changing a process, you know, you just go along with it, and actually sometimes you don't always give yourself the credit that you deserve for those sort of things. So I think in that respect, from a personal point of view, definitely, and from our our point of view for sort of sharing and disseminating information to other teams, absolutely. You know, we've had, like I say, we've had so many teams contact us from the UK, from different countries, to just ask how we've rolled out our virtual service. And like I sort of said, for me, it was really a sort of just, you know, a day-to-day kind of run-of-the-mill, you know, this is what we had to do. And although it was something that I thought was potentially, you know, quite straightforward, it soon became apparent that other teams were having difficulties in setting these things up. So, you know, we've had a really good social media following for many years now, and a really active Facebook page and sort of closed groups and things. And so that's something I suppose that we sort of take for granted a little bit. And actually our trust have been really supportive in allowing us to set these things up. The trust itself are very active over social media. And so that's given us obviously the support and confidence to do it ourselves. Whereas other trusts don't always have that. And so, you know, over the space of the lockdown, we've set up video conferences, video calls, telephone calls with various different teams just to chat them through these things. And I think, yeah, if it's sort of written down as a bit of a guide or as an impact story, it gives other people and other teams, you know, somewhere that they can go to find out that information quite quickly, and just helps them out with things that may be big or small, that ultimately, again, as we've all said, are going to lead to helping the patient.
Great stuff. Thanks, Nick.
Yeah, and I think in healthcare, we tend to look at our practice guidelines and information for innovation from conferences. And I think what tends to happen with that is they tend to give you what you should be doing and why you should be doing it, and what are the outcomes you can expect through that. But they don't necessarily drill down into that how-to. And I think that then can make some of those things feel quite idealistic and unachievable sometimes, whereas having that more practical guide and the real how-to written by a clinician who's actually introduced that pathway, I think can make those targets feel a lot more realistic then, which I think is really important in healthcare as well. And I think what's happened this year is that a lot of practice has been happening in advance of the guidelines, because everybody has been adapting to provide those essential services in very different ways. All of that innovative practice has meant that it's actually working in advance of those guidelines, so some of that data isn't yet available, and again, I think that's where the how-to guide and having that central point and that central hub for clinicians to be able to access that content and to see how people have been able to run those services throughout this is really beneficial as well.
Perfect.
I think definitely I agree with Anu, Nicola and Sonia. I think there's lots of aspects to CardMedic that people can use dependent on their own and their patients' needs, such as using the flashcards themselves, the different languages available, the ability to write your own words, to change the font, a read aloud function, all of which try to capture in the Bob impact story. And I think it's such a great platform to be able to demonstrate that and to help people to use it. I think one of the most important aspects of the how-to for CardMedic is the importance of assessing your patient's communication needs prior to using the CardMedic, or even not using CardMedic, which is something I've learned and I try and do now. Even, for example, do they normally wear glasses, and are these within reach? Hearing aids, do they have any difficulty communicating with aphasia? And I think that's even more important to recognise when using CardMedic to get the best out of the tool. I think it's also, I'd just like to say at this point, it's really helpful that we're really open to hearing any feedback for improvement or anything that worked well or didn't work well. So if anyone does have anywhere they've used CardMedic where they work, we'd love to hear anything.
Yeah, so in short, yes. I completely agree with everything everybody said. Probably I'm far more articulate than I am. But from a commissioning perspective, I think, you know, just putting things into perspective, like when you're embarking on, especially from a transformational perspective and transformational programs perspective in commissioning, when embarking on a new program of work, it's, you know, the amount of effort that's required to do research and kind of get an understanding of the lay of the land and understanding how to go about kind of getting the funding from national, and then writing the specification and getting it out there and getting all the stakeholders on board. is very like laborious and it takes a lot of time. And I think having that how-to guide would have been so helpful for me in my career and probably saved not just a lot of time, but a lot of resource that we could have then used elsewhere and delivered that transformational change in a much more efficient and fast way that would have ultimately benefited the patients and the local health economy. So yeah, absolutely. And I think a lot of people are kind of doing this like out of their own, you know, goodwill and like wanting to share with their colleagues, but it's not, from my perspective, it's not consistent enough, and it's not embedded within the way that we work in the NHS to the point that it should be the how-to do anything. You go to a how-to guide. If someone else has done it before, you know, don't recreate the wheel, kind of take what they've done, improve on it if you need to, tweak it and tailor it to your own personal needs, but don't recreate the wheel if it's been done before. And I think that's something that we spend a lot of time, unfortunately, doing, because we don't have those platforms readily available. I mean, now we do, thanks to Bob, but we don't have enough of that out there to make it kind of standard practice within the NHS.
This is it, isn't it? It's all bringing everything back around to our same ultimate goals. We want to be able to help our colleagues, help our patients, and make everything just much more succinct. And it's, you know, it helps the patient benefit, time, our own reflective personal growth, and so many different reasons. So the last question that we've got for the session is there anything that you would do differently now that you'd recommend your audience takes into consideration?
I think with regards to my presentation specifically, there is a couple of questions that I asked in the kind of pre-presentation survey that I would adjust, which I talk about in my Bob Impact story, so you should go read that. But I think in general, I think I probably would have written up my impact story earlier if I had known about Bob. And so I think really what we can all do is try and amplify the message of Bob, because I think it's so useful. And I think when you just launch a new thing, that kind of increased appetite in that moment is kind of fertile ground for you sharing the impact story, so that you can amplify the message as, you know, as close to your point of impact as possible.
Thank you, Annie.
So for our virtual work and our the way we adapted the service, at the risk of probably sounding a little bit arrogant, I would say I wouldn't initially change anything that we did. I think we did really well at the time to work with the resources that we had to produce a service that was necessary for the patients, and a service that the patients found incredibly beneficial at the time. Of course, you know, I could be critical of the smaller points for the videos that I produced. You know, I may have said something slightly differently, or I may have produced it slightly differently. But on the whole, I think as a team, we came together really well, very quickly, in order to produce that service that was necessary. I think, you know, we rolled out the virtual clinics and the videos and the podcasts. We rolled them out very quickly, and actually much quicker than some teams had done, and actually much quicker than the guidelines that came out afterwards. So I think, yes, we did really well with that. And I think, you know, now obviously we're hoping to get back to more face-to-face appointments and sessions and so on, but that doesn't mean that all of the work that we've done is going to fall by the wayside. It just means that this is now going to be an adjunct to the other sort of services that we offer to our patients. And I think that's a really positive thing to take from, you know, the changes that everybody's made during the pandemic, that actually, you know, it's perhaps pushed people to do things that they may not have done beforehand, and things that have benefited certain patients that may not have done beforehand. And I think it's important to take all of those sort of positives and add them on as well. I think, you know, like I say, looking back, there's perhaps different smaller things that we could have changed, you know, producing sort of more of the audit data and the safety information, which is what really a lot of teams sort of ask about. But that was quite difficult at the time when we were changing the service. So I think generally on the whole, you know, it worked well for what was needed, and it's going to continue to work well alongside all of the other work that we provide as well.
Perfect.
Yeah, I agree with Nikki in that we've got an awful lot right in terms of the delivery for cardiac rehab during the pandemic. I think COVID has has given us the ability to mobilise very rapidly and to try different things, and almost give us permission that it doesn't have to be the finished article straight away in terms of having that urgent service delivery. I guess if you were looking to roll it out now, I would probably say to invest some time in terms of staff training, because as much as technology can be new to our patient groups, some of the platforms that we've been using can also be very new to our staff groups. And with the situation that we were in, staff had to adapt very quickly and use those platforms directly for patient benefit and for patient consultations. And it may be a better approach to be able to use that within your team and for staff to get more confident with it, with MDT meetings and training before having that more pressured situation of patient care. And I think from my point of view, as Nikki was saying there, in terms of wanting to stick with these approaches, and I think a lot of that comes from that business continuity planning, and I think that is something that you need to factor in when you're making changes to your service delivery. And I guess I'm quite conscious that a lot of what we've implemented here are off the back of pilot projects and small pots of commissioning money, in terms of some of the devices that we've been able to use, some of the equipment we've been able to give to patients. And I think actually looking at the model for business continuity is something that definitely we will be looking at in coming months, to ensure that all the huge amount of work that's gone into making these changes can actually result in lasting changes for our patients as well.
Thank you, Sonia.
I think I'm going to focus my answer mostly, I think, from a student perspective. And the first is what I haven't mentioned. So I've initially got involved with CardMedic as part of an elective module through university, which was a 6-week placement, that's developed into the internship. I think most medical students tend to go abroad for their electives, which of course can be a really exciting, great learning and life experience. And I was initially meant to be going to Barbados pre-COVID, and that would have been great, but I wouldn't change this for the world. I've learned so many new skills from kind of being involved in such an innovative project. I've done a lot of things outside of my comfort zone, which were all, as I've mentioned, a bit frightening at first, but my confidence has improved a lot, which is a nice feeling, with a nice kind of bag of new skills to be qualifying this year with. And I think my second point would be just aimed at all students, which is I wish I'd kind of known in my earlier years, which is just to be confident in approaching seniors about their projects and your interests. Like, we're young and enthusiastic, and most people are kind of keen to have students help them out and to get involved. And being at university is just the perfect time to gain that confidence in areas where you're lacking. And there's lots of opportunities out there to do that.
Brilliant. Thank you, Scarlett.
Yeah, so I would probably have gone back and done a bit more of just approaching random people that I'm interested in working with, and just telling them about all the things that I want to do, and then getting them on board and co-developing, co-designing new services together, or just getting their input. And I think one thing that is becoming very apparent, more so as I get older, is that a lot of people like to talk and talk about themselves. And you know, if you give people the opportunity, or ask people to kind of help you based on their experience, people are generally quite decent and they'll do it. So I think I wish I am doing it now, but I think if I could go back and tell myself, whether it's for career development or kind of the projects and programs that I'm trying to deliver, or just advice and guidance in general, I would probably be a lot more outgoing and reach out to a whole bunch of different partners, and those would be individuals, organizations. And the other thing that I would probably emphasize is, you know, for everybody, kind of just like reach out to some of the national bodies that we've got in the NHS, and you know, tell them about some things that you're doing and that you'd like to do, and sometimes they might be better placed to point you in the direction of someone that's done something that you're about to embark on. And if they don't have that information to hand, they might want to co-design something with you. So always a worthwhile endeavor.
That's wonderful. So that's the end of this section's questions, actually, and I think it's just been so worthwhile to have this conversation and have it out there for people to listen to and understand the experiences of what it takes to share, and that have the confidence in yourself to do it is really the remit, and know that what you're doing is worthwhile. as we've said, we've got some links that's gone into the chat. So we've got Anu's story, we've got Scarlett's from Carb Medic, and we've got Nicholas from the cardiac rehab team. And I'd just like you to go and have a little look at those and see the worth really from them. But I just want to thank all our speakers today for their time. It's been so worthwhile for me, and I hope it has for our audience.
You work for the NHS. You've had a great idea, you've made it happen, and it's made a big difference to how we can learn from COVID-19 and enter a new normal. Ideas like yours drive improvement and they deserve to be shared. That's what Bob does. Amplifying good ideas like yours across the NHS so as many people as possible can learn from, adapt and implement your idea. The further good ideas are shared by the Bob community who learn from them, the greater improvement we can achieve. You made a change. Share your solution with others. Speak to Bob.
Very excited for this session, and it builds off the last one perfectly, because we're talking today about the theory behind spread and scale, and in particular, what are those human behaviours or those human factors that the system can learn from. I'm joined today by a very experienced, esteemed panel to discuss this. I'm going to let everyone introduce themselves in a moment, but just to say we have Siri Steinmo on the line, who's Health Intervention Design Quality Improvement at the Inform Health Informatics Project at UCLH. We have Christina Jackson, who's partner at Sprouts Behaviour Change. Dr. Catherine Cresswell, who's Senior Lecturer at the Usher Institute, University of Edinburgh. And Lisa Talia Moretti, who's a digital sociologist from Goldsmiths, University of London. And me, if you have seen me already today, I'm Mark Southern, one of the co-founders of Bob Health. What we're going to do today, first thing we're going to do is there will be a poll that will appear. If it's not there already, it should be there shortly. And the poll itself is just to get a bit of an understanding from your organisation, whether you work in the NHS or in any other organisation. What we'd love to understand is, in your organisation, what are the most important human factors that you think affect the spread of information, projects, or ideas? And so that is now in the polls. You should be able to see that if you click on the poll button. Add your details, and we'll come back to that later on in the session. So before we go any further, I'm going to turn it over to our speakers for them to tell them a little bit more about themselves. So if I may, Siri, if I may come to you first, if you could just tell everyone a little bit more about yourself, please.
Sure. Hi, everyone. I'm Siri Steinmo. I am a quality improvement professional and have a background in behavioral science and health psychology. I work for UCLH Inform Health Informatics Project, which is an intensive care. I'm currently working there. I've worked in a lot of different sort of hospital areas, and my main work centers around designing behavior change interventions or quality improvement projects for the NHS.
Thanks, Siri. And if we can come to you next, Lisa.
Hi, everyone. My name is Lisa Talia Moretti. I'm a digital sociologist and an associate lecturer at Goldsmiths. I do a lot of work within the private sector, but currently I'm doing a lot of work at the moment within government. So I'm at the Ministry of Justice working on lasting powers of attorney.
Thank you. And then Christina, over to you, please.
Hi, everybody. I'm Christina Jackson. I'm a psychologist and I specialise in behaviour change of clinicians and people with long-term conditions. I've previously worked for King's Health Partners, setting up the Centre for Adherence Research and Education, which had a remit of training healthcare professionals and disseminating adherence research. But mostly I've worked in industry for pharmaceutical companies, mostly on the development of patient support programs globally and locally. And I'm a founder of Sprout Behaviour Change, or Sprout Health Solutions, as we are since Monday. So it's only 2 days. So there we go.
Thank you, Christina. And yes, yeah, I remember that. Sorry, my bad. I should have done that. And last but not least, if we can come to you, Catherine.
Yeah, hi. Thanks for inviting me. I'm Catherine Creswell. I work at the University of Edinburgh as a social scientist, and I evaluate large-scale, complex health systems changes driven by digital technologies. And I look at technological, social, organizational dimensions associated with that change. So I look at unintended consequences and organizational strategies, impact on work practices and relationships with vendors and policymakers. And I also teach technology strategy at the NHS Digital Academy.
Fantastic, thank you. So really looking forward to getting into today's session. There's one quick bit I just wanted to cover off first. People listening in and want to interact on social media. There's a couple of hashtags. We've got the giant hashtag, giant 2020, and there's also a hashtag specifically for this track, which is unpack the how. And if you want to mention us, we're at bob.health, which is bob.dot health. Great. So without further ado, I'm just going to go straight into the session. And I think this is a really fascinating session. And for us at Bob, I've kind of found a new understanding around psychology and certainly behavior change since starting with Bob. And the reason behind that was because the very first thing we did before we built our platform was to really go and have many conversations with actually people in the NHS that they're experiencing challenges around finding information relating to other people's projects that they want to learn from before they start their own, or they've done their own project and they want to share that information out with others and they just either not sure how to do it, best way to do it, or there's some other challenges there. So when we were having those conversations, and we had about 100 of these conversations in the first year or so, we realized there was something going on here that was a human factor. There was definitely the behavioral human factor that was at play. And so we commissioned some work actually with Siri on this panel to look into that in more detail. So we conducted interviews with various folk across the NHS, and from there we realized there were a number of different themes that were coming out loud and clear. And for us, it was really quite interesting to delve into those in a little bit more detail and work on how do we make sure we address those within our platform, Bob. So there were about 15 themes. So what we thought would be interesting today was to look at some of these themes in a bit more detail, because we believe that these themes really have an impact upon how people might be seeking information, searching for information about projects they might be embarking upon, but also how people share and disseminate projects and why things happen and why other things don't happen. So what we'll do is we'll cover off each of these things, and we'll go around each member of the panel and let them give their view on some of these areas, maybe what they've seen from their experience and what they think might change going forward in some of these areas and what might need to be addressed. So the first thing, the first theme that we saw that I'd like you to react to is this belief that belief about consequences. And what I mean by that is what we heard when we were talking with various folk across the NHS was that if you've done your project and maybe you're looking to share it out there to the world, there was almost a spectrum, if you will, of responses you got. On one end, you got, what's the point? It's futile. There's no point in doing this. What difference does it make to the system? And then on the other side, you had, I guess you could call it, being overwhelmed. And that was where someone might have shared information about their project. They put it out there, it's online, their email address was on there, and maybe they are actually inundated with requests for information. And they kind of became this poster boy, poster girl for that change. And as a result of that, they were so overwhelmed that actually, so they regretted putting it up there, but there was certainly, it was a new challenge they had. They were being overwhelmed. So it's quite broad ranging. And it certainly was a big theme that came out in the research we did. And I'm just putting it out to the panel there in terms of what or whether you've experienced any of those, whether you've experienced that particular theme in any work you've done, and maybe you could elaborate more on that. And maybe if I may start with Siri, actually, because I know Siri, you were you were involved in that initial research, and maybe you could share the initial points. Thank you.
Sure. So yeah, so this was about kind of what people believed was going to happen if they shared some of their work, specifically about the sharing behavior rather than the sort of seeking behavior I think we're talking about now. So yes, this obviously, if you think that something good is going to happen from your sharing, you're going to be more likely to share and spread and scale. If you think something bad is going to happen, you're going to be less likely to share. So that's sort of very simply kind of what we were exploring there. And yes, Mark's right that on one side of the kind of spectrum, one end of the spectrum, we had people saying, when I share, or when I share at a conference, or when I maybe even publish a paper, nothing ever comes of it. No good is ever done by it, and it's so much effort, and it's a bit of a futile exercise. And on the other side, well, when I share, perhaps everybody's now going to come to me and ask me about my experience of working on this project, and I don't have the time for that. There's also another piece which I think's really interesting, and this sort of idea that we're sort of airing our dirty laundry. So once I share and once I put my work out to the world, will it be scrutinized? What would the unintended consequences of that be that maybe I'm not quite ready for? So those are just a couple of thoughts on that. What do I really believe is going to happen if I share?
That's it. And maybe, can I go to you, Catherine, next?
Yes, of course. Yeah, actually, this resonates with the work we've done. So we're evaluating the Global Digital Exemplar program at the moment, which is about to finish. And actually, we looked at how that program has helped to set up a sharing economy across the NHS. And so we found that people will share, quite simply, if the benefits of sharing outweigh the costs of sharing. Now, obviously, that's influenced by what Siri mentioned, the kind of beliefs of what the benefits and costs are. But the problem is that they're very hard to anticipate in advance what you will get in return, and people can't manage what people will get out in return. So it's kind of an organic development that is difficult to manage from the top. And yes, we found exactly what you've just said, that certain types of knowledge and certain locations are actually were in higher demand than others, namely the digitized hospitals that had already implemented a technology, and loads of other hospitals wanted to learn from them. Now, and that created a kind of unevenness between efforts and returns, and where we had a lot of knowledge givers and a few knowledge givers and a lot of knowledge receivers. So and that's still a problem going forward, because we still have only few GDEs, global digital exemplars, and many hospitals that want to learn from them and need to learn from them, and that we're looking at how that kind of digital divide can be addressed. So yeah, have a look at our publications, but I'm very happy to share any more insights.
Excellent. And if I can go to you, Christina, to give your view.
Sure, thanks. Yeah, it's a really interesting topic, thinking about how our perceptions influence our behavior, whether or not those perceptions are anchored in facts. And certainly Siri's research is backed up by, a lot of research that's happened in health psychology. There's a systematic review that shows that clinicians' perceptions of, their attitudes towards a behavior, how far they think they can control, performing that behavior, what they think other people think about behavior, is a good predictor of how people behave. So this is certainly not an uncommon finding. And I think, moving into that idea of sharing the dirty details, I think that's the kind of thing that it's, depending on your organizational culture, it's easier to share internally So, for example, for us as a company, through a whole project, we'll share how it's going, what could be improved, and it means you've got a constant opportunity to improve your processes and communicate that across the business. I think sharing externally when you have, when there have been setbacks or hurdles, I think that is very challenging for people. I mean, as we all know, it's hard to talk about times when you have failed. And I think, there's a really interesting field of research. If you look up Carol Dweck's research around mindset, looking at whether people have kind of a fixed mindset or a growth mindset and how that might impact your behavior. So if you've got a fixed kind of mindset, then you would think that attributes like intelligence or success are kind of fixed. And so therefore, when you fail, it's a personal reflection of you not being good enough. People with a growth mindset are more likely to think that those are, attributes that are developed over time. So when you fail, it just shows you're not there yet, and it's an opportunity to improve and grow. And organizations also have these kind of, like an organizational culture has that kind of mindset too. So if you work in an organization with a really fixed mindset, it's very difficult to share failures because you're going to get shot down for that. And then I think, you're talking about the positive aspects of sharing. I mean, certainly I've found in the work that we do that our customers are most keen to share when they see a benefit for themselves. Frequently in career terms, if it makes them look good to share. But as Catherine alluded to, there's a lot in having the bandwidth to share, and there may be fewer people who have the knowledge that they can share than there are within an organization or externally who want to access the knowledge. And I think, so one of the things that we've done in projects is we've provided that extra bandwidth for people. We support people to do that. And I think having that as a work stream in a project is a really helpful way to go.
That's really interesting. I'm going to come back on that positive reinforcement piece in a moment, but you mentioned culture a lot, and actually it's a lovely segue into Lisa, because I know, Lisa, we've spoken in the past about culture and how important it is to some of these things. So maybe, I don't know if you could pick up specifically on that point relating to what we were saying about beliefs about consequences and how culture is important in that. Thank you.
Yeah, absolutely. So so such a lovely kind of talking point around these dirty details and how, in innovation, one of the things that we have to really remember is that in order to innovate, we need to know what's gone right, but also what's gone wrong. And we need people to share what's gone wrong. And so Ken Robinson has talked so wonderfully about creativity in the workplace and creativity in schools. And he talks a lot about like how as a society, we've come to actually stigmatize failure. And so people don't want to come forward and to talk about their failures because, as Catherine mentioned, as Christina mentioned, it looks like it's on them, right? So there is, when you're talking about failure, there is also a negotiation that you're having to make with yourself about protecting your own reputation and protecting your own identity. And, in terms of a culture, how do we change this? Well, we need a new narrative around failure. How do we change this to talk about about celebrating somebody being courageous enough to take a step into the unknown? How do we celebrate somebody experimenting in a really creative way, as opposed to highlighting potentially what went wrong? We celebrate the kind of courage and bravery that it takes to do something new and to be a game changer. And that is how we can maybe within our organizations change this negative perception around failure and turn it into a learning opportunity. And therefore you change the kind of the environment, the atmosphere in which somebody is going to be stepping forward and sharing something that may not essentially have been what they had hoped would have been the outcome.
That's interesting. Catherine, I think that's you wanting to make a point. Go ahead.
Yeah, sorry, I feel like I'm in school. Absolutely agree. Maybe just to add on to that, so there's this kind of hindsight learning, and there's a proactive type of learning that we might want to distinguish. And our work has mainly been, you can do your own evaluations, and those evaluations of initiatives can actually identify what kind of risks you might anticipate and mitigate them actually early. So you need to evaluate whilst you are implementing a system, so you don't crash into a wall that might be right in front of you that you just can't see because you're concentrating so much on the evaluation and actually on the implementation. And actually, there are frameworks out there that can take organizations through that process. And I would encourage anyone to do, rather do a quick and dirty evaluation than no evaluation. And you can actually make a massive difference and not just learn in hindsight, but proactively.
Yeah, that's very interesting, actually, and certainly is something that we certainly considered when we were building Bob as a way to ensure that you could build on a project over time. So it's never static one moment in time. You can add to it, you can continue adding to it. I want to go back actually to the earlier point Christina touched upon, which was the positive reinforcement piece we were talking about and how important that is. And it was also mentioned earlier about career progression and some other elements there that are positive in nature as a consequence of sharing that could be quite helpful to support people to actually share their information with others and ultimately leading to spread of these ideas. Does anyone else have any other experiences or thoughts around that they want to add?
There's a really interesting social theory which we talk about social proof. And that's when somebody's in a new situation, they look to the group around them to understand what are the kind of norms or behaviors that somebody is enacting. And then they follow those kinds of behaviors and to be able to engage in this new situation. And I think there is something about this, there's something about us, a group of influencers who establish a set of norms or behaviors, and that then go on to influence how others behave. And so you kind of are able to create this kind of positive reinforcement. The tricky thing is that first bit about trying to find this early group of influencers. And, Catherine kind of mentioned it earlier, you often find this 80-20 split where 20% of the people are creating 80% of the informational content. And so, and you find this everywhere. You find this on social media platforms. You find this, in a lot of forums on Wikipedia, etc. So for me, this kind of starts, I think, with when you're in a new situation. Who is going to set those early on norms, those early on behaviors, and then how do you seed that through within your community so that others can pick up on those behavioral cues and find them easy enough to adopt and therefore enact and manifest their own kinds of behavior, their own kinds of positive enforcement.
That's interesting. In our report, some of the things that people cited as kind of reasons, motivators, powerful motivators they felt that would help them share were things, it was reward and praise, and specifically around it might gain them or their team kind of personal organizational kudos, or it could be linked directly to an award, or it could be linked directly to some kind of career progression, whether that be, it's evidence for my appraisal, or it's CPD points, or it's something like that. Then if anyone else has got any thoughts on that, or what might work, what they've seen work elsewhere. Catherine, please go ahead.
Sorry.
You're not at school.
So I think we need to look into motivations, and in that we need to look at barriers and facilitators for networking. So actually in our work, what we found looking at interorganizational networking in the NHS, I know it's very simplistic, but it's a bit of a roadmap to successful networking or relatively successful networking. So if hospitals, for example, were located next to each other geographically, knowledge flows work better. If they had a shared culture and context, knowledge flowed better. If they were talking about similar technological functionality, knowledge flowed better. For example, if they had an underlying similar electronic health record system. If they were both talking Cerner, then knowledge flowed more quickly and more smoothly. If there were regional and strategic alignments, for example, if they were located in the same integrated care system, it would work better. If professional agendas were driving a certain networking activity, for example, pharmacists have been hugely successful in sharing knowledge around the implementation of electronic prescribing systems. So these are the kind of like pointers that can help you set up relatively successful knowledge flows. Barriers, so competition around prestige and resources, history of deployments and concerns of what Christina has already alluded to, concerns of failure and repeated failure and damage to reputation, variations in technological systems, which means that it sometimes wasn't applicable, a certain type of change, and different cultures and patient populations and needs. So yeah.
Yeah, it's interesting. Does anyone else have any other points to add to that?
Yeah. Oh.
Go ahead. Yeah, go ahead, Christina.
Yeah, no, I was wondering, Catherine, do you think like part of the reason for that, that it's easier to share, for knowledge to flow through some environments than others, is that partly about having sort of like a shared language that people already have to understand things, that, as you go further afield in terms of like disciplines, not just geographically, that it gets harder and harder? Because it's certainly something that I have experienced in my career working in multidisciplinary teams, is that the further away you are in terms of your background understanding, the longer it takes to get to a point where everybody actually gets what the other person is saying, because we have just totally different frameworks for understanding things, I think.
Yeah, yeah, definitely. I absolutely agree. I mean, that's the whole problem in health technology change, that there's still a bit of a disconnect. I was just in a session from the Digital Academy this morning. There's a disconnect between IT and clinicians, and they often, people were telling me they went out for dinner and they couldn't actually have a conversation because they were that different. But if a chief information officer knows another chief information officer, even if it's in Edinburgh and London, they exchange experiences. They speak the same language. It's much easier. Yeah.
Siri, go ahead.
I just a little note on that. I work in an informatics team as sort of the only non-informatics person, and I often feel like people are speaking another language in a meeting that I'm sitting in, and actually we're all working toward the same aim, but finding a common language is very difficult sometimes between not only myself as a sort of QI psychology person, but doctors and software engineers and people like me all speaking the same language, even though we're all working toward the same outcomes. Very difficult. But I wanted to say something about Catherine, what you were saying about the simple fact that hospitals that were in close proximity toward each other had more of a sharing culture going on between one another. I've seen this this week in the intensive care unit that I work in. I saw a great presentation yesterday of some junior doctors who'd done some work around sedation of COVID patients and what our sedation practices were like in the first wave of COVID. And I sat in this meeting yesterday going, have they talked to the nurses? Because the senior nurses are doing a sedation project on the same unit, on the same intensive care unit. And it occurred to me that there aren't opportunities now with social distancing for the senior nurses and this group of doctors to ever be in the same room. And they're not invited to the same meetings anymore because we actually can't be in meeting rooms with one another. And where there would have, I think that this is actually a real factor in why they hadn't shared with one another or known about each other's work, that they actually physically hadn't seen each other since the beginning of the pandemic. There are, of course, other reasons. I mean, the nurses and the doctors do tend to work independently anyway in intensive care, and they really do have very different roles with critically ill patients. But I thought that was what you said about the sort of proximity really made me think of that, and how, wow, just something as simple as having the opportunity to physically speak to one another had affected that. And I had to bring those two groups together and say, I think you guys have some data for each other and some information for each other. So
that's really interesting. I wondered, because the other thing that came out was around professional role and identity. I think we're touching upon that now there, and there was this perceived hierarchy of also who had permission to share. And it was thought that, you know, for some bands and roles, it was not for them to do, even though actually they were heavily involved in the project. Or others thought just it wasn't acceptable for them to be doing it at all. And so, and then the final thing was, I think we've touched on this, is actually this competition piece as well, competition between different trusts, different teams, different individuals. And I wonder if anyone else has got any other thoughts around that. Lisa, go ahead.
I don't have so not so much around the competition piece, but around this when it comes to working in multidisciplinary teams. I think one of the struggles that we really have found is that there are often very few people who work at the edge of both disciplines, and so as a result, you never have this person, which, you know, for lack of a better word, a bridge person that is able to bridge the gap between two different teams, to be able to say, when they say this, what they mean in your language is this. And it's a bit of a translator role. And I think this lack of, you know, we just haven't professionalized these kind of bridge people yet within multidisciplinary teams. But I do think that it is such a key role, this professional facilitator, this professional translator who's able to bridge these two gaps, in order to get more sharing to take place, and more sharing to be communicated both within the team itself, but actually as well as externally. You know, that person can also be a bridge between the team and an external type of audience. But I think that lack of professionalization around a networker role or a facilitator role is actually hindering a lot of sharing from actually taking place.
That's interesting. Catherine, go ahead.
Yes, I agree. We call them intermediaries in social science, or like you say, Lisa, translators and connectors. So people who help to translate and build relationships. And we found actually that the problem is that these people are not in the place they are in because they've been put there, but because of the people they are, if that makes sense, because of their attitudes, because of their interpersonal skills, because they're just placed in a way that helps them connect others. So, for example, we found that vendors, actually, software vendors played quite a big role in user groups, and, you know, putting users of different organizations together to discuss a specific software problem. Or, like I mentioned, the pharmacists, they didn't want to be there. Nobody's put them there, but actually they had a common aim, a common purpose, and common benefits out of getting together and translating between IT and pharmacist as a profession. Now, the problem is, how do we then establish these roles? I think we probably need to identify these people and enable them in a way as strategic decision makers. How? I have no idea.
It's interesting. I just want to say that we just got a comment through from one of our participants, and they were saying, great points. How about providing better guidance for entrepreneurs on connecting with individual innovators within the NHS? Those with great ideas and insights. We also need more of a heads up about upcoming core NHS innovations and emerging standards. So again, from the other side, that bridge piece as well, from an entrepreneur SME perspective into the NHS, you know, more understanding there about what's happening and what's coming online as well. So that is definitely interesting. Just following up some of those points there around that intermediary, the professional role, there was another theme as well, which is, again, a slight build on what you've already said, which is the role of facilitators of networks. how do you actually sustain a network, whether it be informal or formal over time? Because I guess that's what we're talking about here, really, is we're talking about these groups of people that surround each of these challenges, each of these problems, and ideally that they're all sharing and they're all talking. But how are these sustained? Has anyone got any thoughts on that?
I think.
Go ahead. Oh, Christina, if we can come to you. Thank you.
And I was just going to say that in my experience in, working with pharmaceutical companies, the networks that I have seen that, really work well at sharing knowledge and are sustained over time, there's an intermediary, using Catherine's terminology. The intermediary is a person who absolutely needs that network to function in order for them to do their job. So we find, it might be an individual working for the global team in a pharmaceutical company who needs to involve local markets to roll out strategies or materials or whatever, and they need to share knowledge. They need to understand what's going on in those local markets, and they need to get their buy-in in order that any of the work that they do at a global level ever gets rolled out. And so I think, in terms of being an intermediary, I think having that job exist is recognizing that it's a thing and that it's a job that exists is a really important step. But there's also there's got to be the motivation for the intermediary to care about about performing in that role. And yes, as I say, usually it's because there's something very much at stake for the individual that makes them a very effective intermediary.
Yeah, that makes a lot of sense. And I don't know if anyone else has got any other views on that. Lisa, go ahead.
Christina just took the words straight out of my mouth. I think the most important thing, if you want to sustain a network, sustain a community, you have to make it somebody's job. You have to say you are accountable for doing this. You have to recognize this as an actual role. And, I think what tends to sometimes happen in teams is that there's a few people who are expected to fulfill multiple different roles and responsibilities, and it's just not possible when you are doing the job then to be able to say, oh, now you also have to be a facilitator, and you have to be a sharer, and you have to go to these conferences. It's a huge amount. He doesn't maybe want to be able to put themselves forward for all of those different reasons we've already spoken about and do that. But also it's a whole person's job thinking about who is the audience? How do I tailor the story? What is the communication style? What is the tone? There's a whole communication professionals have been working in this area for a long time, thinking about some of the nuance around narrative and storytelling, and how do you kind of share at the right level to the right audience. So for me, it's definitely about seeing this as an actual job of value, creating this position within the organization, and then empowering that person to be able to actually create the narratives and make those connections, and making it easy for them, not to put loads of barriers and say, oh, you can't talk to this person, you can't talk to this person. You have to facilitate their role so that they can move through an organization and through the world to be able to share.
Mm-hmm. And there's something actually that I know Siri and I have had a discussion about this in the past, around regret for not sharing your work. And I think we mentioned it right up top here, that the consequences, you don't always know the consequences when you're doing the project. They're in the future, so you can't see them. But certainly regret was something that we had heard. And I know there are some examples from across the system where people have said they wish they had shared something in the past, because 2-3 years down the line, they wish they had, because, it could have really helped in X situation. And I don't know if anyone can talk there. I don't know, Sarah, if you're able to, maybe not the exact stories, but maybe you can talk a little bit about regret, and then I'd love to hear everyone else's views on regret and what part that might have to play in some of these things. Go ahead, Sarah.
Specifically, I've been involved in a project that I think everyone that was involved now regrets that it wasn't shared, and that it sort of the how-to of the project hadn't been disseminated, because actually the results of the project were very good and really meaningful. It was in neonatal intensive care, so it's sort of this this area of medicine that is quite evocative and incredibly important. And people worked extremely hard on this project, and we saw admissions to the neonatal intensive care reduce significantly. And that work never went anywhere, and nothing was ever published. And it's not really about, I think the regret isn't really about kind of kudos or notoriety. The regret is more about those how-tos and the interventions and what was actually done and not being passed on. So yeah, I can personally say that I've been part of a project that didn't get shared that absolutely should have. And I think the main reason, coming back to Lisa's point and Catherine's point before that, or sorry, I think it was Christina's point before that, was that it was nobody's job. Nobody had the time. Nobody who was working in that team of midwives and neonatologists had the time to think outside of this organization right now and the impact that we're making, or this unit, actually, this neonatal unit right now and the impact that we're making, and the doing of the intervention and the planning and the doing of the intervention. And that is because in the NHS, we have a major problem with sort of seeing innovation and sharing as an aside to normal business, and everybody is going to just stick it into their normal day job, which is already incredibly taxing, and you already have more things to do in your day than you actually have time for. And then to sort of tack that on as a like, oh, in your own time, why don't you just, come up with some amazing ideas, design and implement an intervention, and then disseminate it to the wider world. It just doesn't happen. We've got a major problem with that in the NHS, that those roles don't exist in the main, and that the sort of world of innovation and sharing is woefully under-resourced.
Thanks for that, Siri. Thanks for sharing your personal story. Does anyone else have any other thoughts around regrets? And Catherine, yeah, go ahead.
Yes, I agree. It takes time to share knowledge, and it takes time and resources to share knowledge, and it takes time and resources to curate knowledge. And I think because we are so busy, which makes absolute sense. We're so busy providing care. It's always an afterthought, this kind of thing. But it must not be, because it's too dangerous for it to be. It's quite difficult to say how dangerous it actually is, because in hindsight we don't know, what would have happened if we wouldn't have done it. But it's a duty that we have to share and curate knowledge. And the problem is also, we found in our work that clinicians take that role for a while, but then they will always revert back to being a clinician. So there's, like people, like everybody has said here, I suppose there's the need to establish clear kind of career pathways for these kind of people, and allow them to take time away from their clinical work, because clinicians can be very effective in doing that kind of thing, actually. But it's hard work.
Yeah, that's interesting. Very interesting. I just quickly want to go back through just the poll results we've had back there. So the most important human factors that people mentioned, there were three actually. It was a three-way tie, and not surprising because we've kind of had these conversations between ourselves here. So geographical proximity was one. It was a kind of three-way tie. So geographical proximity, informal networks, and having a similar professional background seem to be the top three. The top three factors that people believe are most important there in terms of sharing and spreading information and ideas. So maybe no surprise there. I don't know if any reflections there from the panel on that at all.
Go ahead, Sarah. I wonder if kind of this new more digital, more virtual world that we're living in. I mean, we're all sitting here on a virtual conference rather than a conference in real life, is an opportunity to kind of break down some of those barriers about proximity. We've certainly seen in quality improvement, we've seen an uptake in people accessing courses and getting involved in projects virtually in many organizations now versus before, when you actually had to kind of rock up to a away day in real life and do a quality improvement day course. You're actually seeing the organizations I've been in contact with about this, seeing more people kind of accessing that because it is virtual. So I wonder if that can help.
Just to say, by the way, we are coming up to the end of the session. We can actually overrun a little bit. So I don't know if all the panelists are okay for a few more minutes. We can stay on the line. Super. I just want to go back. We had a couple of audience questions. One of them was about just to all of you, if you the question was, what's the bravest share that each of you have undertaken yourselves or for an organization? Who wants to take that one? Lots of pondering and thinking there. You're going to go. Okay, go ahead.
I worked on a project in 2019 on oxygenation practices in the intensive care unit. And the first time that I presented to the board, I won't go into the details, but I presented the data. I had completely messed up the data analysis. And I presented this like completely wrong graph to the senior staff of the ICU. And as I was presenting it, realized as well. So I kind of had to actually bravely, I guess, share that, sorry, this is actually incorrect. And what I'm saying to you right now is incorrect. Can I come back to you? And I had to come back to the senior staff meeting a month later and say, and here's the real analysis. So there you go.
Brilliant. Well, thanks for your honesty. Christina.
Yeah, I have a tendency to probably overshare my failings. My business partner would say. And I think, you know, as Siri's just alluded to, it's painful because it makes you wonder whether you are now diminished in the eyes of the person that you've just shared with. So I was telling somebody new that I'm working with the other day about they were proposing to use this particular process to do something, and I was like, oh, brilliant, that's really good, because I've found that if we do it this way, if you make a small error, then it can have really big ramifications, because I've done that before and I've made a small error and then it's been really bad, whereas this way we can see more what we're doing. So it was useful because I've learned that through experience, and so I know that this way of doing it is a good way to do it. But it does make you wonder, is that person that I'm working with now, have I undermined their confidence in me because I have admitted that in the past I am a human being and I have made mistakes, you know, and I've learned from those mistakes. So yeah, I think sharing can be a bit painful. Yeah, it takes both.
Thank you again. Thank you for your honesty there. And over to Lisa, and then we'll come to you, Catherine, after. Thank you.
I think my most painful share was when I was doing some consumer research for a very big fashion retailer, and they had spent a lot of money on a global campaign, and they were asking me to do some research about what people thought about the campaign. And essentially what I found was that the campaign was a total failure and people hated it, and that they didn't trust it. It made them really suspicious of the brand. It made them really concerned about what the brand was the messaging and some of the values that the brand was communicating. And I had to present the findings to the executive board and the CEO. And I was so afraid to tell them what I'd found, because I just thought, I am really concerned. I was a freelancer researcher. I'm not going to lose my job, but I feel like I'm going to get somebody else into trouble. And I feel like I really hope that no one gets fired over this. And yeah, and that was a very, very scary thing to do. And they took it very well. But that was my bravest share, or the time when I was sharing and I was most terrified of the consequences.
Thanks, Lisa. And over to you, Catherine.
Actually, I mean, at work you always try not to, but my kids, yeah, I have learned, and it's been very hard, that you can apologize to your children if you've made a mistake. But you know, if we still live in a society where we believe, and I believe this, and I think a lot of people do, where people believe they shouldn't be apologizing to their kids if they've done something wrong because they look like a bad parent, or you know, somebody that you can't look up to, then you know, we need to think about it. Yeah. If we can't do it in the home, how are we expected to do it in the work? So I've learned that the hard way. I do apologize to my kids now, and I've shouted at them again. So.
I do the same. Thank you so much, everyone. That's been really interesting. And then we're going to have to draw a line on the session in a moment because we've overrun a little bit. But I just want to say thank you ever so much to each of you for your contributions today. It's been really interesting. Again, as I said yesterday on the session I was running, we could have done this for an hour and a half and still continue talking about these areas. It's really fascinating. And as I said right up front, at the beginning of Bob, for me, I didn't know anything really about behavioural change, and I'm learning every day, and it's fascinating. It really is, and it really is such an important aspect. The human being is such an important aspect of any kind of adoption, whether it be technology or anything. It really is super important. It should not be overlooked. And I think just to summarise some of the interesting things we've had today is that culture is really important in this. Don't overlook it. Failure is okay. It's okay to share, as scary as it might be. It's okay to be brave, or it's good to be brave, but I know that might be scary for some people. And the final piece is around, you know, professional roles and responsibilities as well. It's okay for people to share if they're not the most senior person on the project. I mean, there are other things there, but those are certainly the things that resonated with me. So just leaves me to say thank you again for all your time, and yeah, speak to you all soon.
Thank you so much. Bye-bye.
Bye-bye.
Bye.
Neil will be sort of managing things, comments and things, and fielding
You work for the NHS. You've had a great idea, you've made it happen, and it's made a big difference to how we can learn from COVID-19 and enter a new normal. Ideas like yours drive improvement and they deserve to be shared. That's what Bob does. Amplifying good ideas like yours across the NHS so as many people as possible can learn from, adapt and implement your idea. The further good ideas are shared by the Bob community who learn from them, the greater improvement we can achieve. You made a change. Share your solution with others. Speak to Bob.
Hello and welcome everyone to one of our last sessions of the Bob programme at this year's Giant Festival, but hopefully just as engaging. So in this session, you might be wondering why it's called Cinderella and where does Cinderella come into it, the Cinderella spreading scale. Well, to explain that, we often hear a lot in the media about access to medicines or lack of, postcode lotteries and the like, particularly around oncology. But we're actually starting to see a sea change in the way that Medtech is conveyed in the media in the spread and scale story. Previously, we've not actually heard that much about Medtech adoption and access to Medtech, hence the Cinderella. But we are getting a bit of a change and brought about by the pandemic. So all of a sudden, we're hearing about PCR tests and lateral flow tests and other things that average person on the street would never have heard of previously. So we're starting to see Medtech come out of the shadows, which is great. So today we want to focus on the positives of how we can keep this shift going and explore this topic further. So we've got 4 fantastic speakers with us today, 2 with a very much a helicopter view, and then 2 from a sort of on the ground individual perspective from in a company. So we're just about to find out who our speakers are, but we also would like to know who you are. So there should be a poll that's going live in the next minute or so on screen. So please do tell us where you're from, and if it's not covered by one of the options, then you can put in the chat. Please also do make use of the chat to share your thoughts, comments, or ask any questions, and we'll be covering off questions and answers towards the end of the session. So while we're finding out who you all are, I'd like to introduce our speakers. So first off, Sally, would you like to kick us off?
Yes, thank you very much. Good afternoon, everybody. So my name is Sally Chisholm. I'm hoping that there'll be a few people on here that know me, but for those of you that don't, my background is that I spent over 30 years working in the NHS, starting as a frontline health professional delivering care and working my way throughout my career to a point where I was involved in some really interesting roles around helping NHS organisations and clinical teams to improve services and ultimately to adopt innovation. I suppose the 2 main roles that were involved was firstly that I was the chief executive of the NHS Technology Adoption Centre, which was an organisation entirely focused on helping to support NHS organisations to take new innovative technologies and to bring them into clinical practice. And that's where I had my first exposure really to working with industry and trying to understand their frustrations and the difficulties that they often had in navigating the NHS. And I finished my NHS career working at NICE in a role that was entirely focused on supporting the uptake and the use of medical diagnostics and technologies and digital products, actually helping that guidance to be brought into use in NHS organisations. So I then left the NHS and I brought all of that knowledge and the learning that I had into my own organisation, HTAS, which is where I obviously work today and why I've been asked to join this. So thank you very much.
Great, thank you. Go to Nick next, please.
Hi there, my name is Nick Lansman. I've been for 25 years advising companies in tech and healthcare of how to engage with the system and to understand policy and those developments and how it impacts on their businesses. About 4 years ago, I was involved in setting up and founding the Health Tech Alliance, which is a coalition of health tech companies, but also importantly, bringing together key stakeholders from the NHS and wider bodies. And that grouping really helps to look at issues surrounding barriers to adoption of medtech and alleviating them. Sally is involved, so we have all the Sally's involvement and experience involved in the Health Tech Alliance as well. The chair of the Health Tech Alliance is Dame Barbara Haken, who was the former deputy CEO of the NHS. So we have some great expertise. Equally important is the involvement of the members themselves, who have expertise from both big companies and small companies and drive the agenda of the organisation.
Thank you. I go to Andrew.
Good afternoon, everyone. My name's Andrew Thelwell. I'm Chief Commercial Officer for a company called Sky Medical Technology, which is a UK-based medtech company, innovative company. My background is over 30 years experience in medtech. I've worked for a large American corporation, a large British corporation, and then a couple of SMEs. So I've seen everything in terms of innovation from the industry side, from large budgets, large clinicals, etc., down to trying to work out how to spend investors' money in the best possible way because we're not generating our own. So I think that gives me an interesting perspective on the whole spread of companies within the industry, medtech industry, and the different challenges for the smaller companies vis-a-vis the larger companies. We've got in Sky, we've got a wearable bioelectronic device. We're trying to bring it into DVT prevention, orthopedic, post-op recovery, and also wound care. And each of those three different pathways have different needs and different behaviors as well. So hopefully as this session goes on, I'll be able to bring in some examples, real life examples of what it's like when you're working with clinicians and patients and trying to bring innovations into practice.
Thank you, Andrew. And finally, I go to Giovanna.
Hello. Thank you for having me on the session. I'm Giovanna Forte. I'm CEO of Forte Medical, a company that was set up to realise an NHS GP's innovation. And that NHS GP is my brother, Dr. Vincent Forte, who's also a medical author. He identified an overlooked area of diagnostic medicine, which is urine specimen collection, which although urine has diagnostic parity with blood, there is no protocol, which results in 1 in 4 specimens being contaminated, leading to repeat testing, unreliable diagnosis, and the overprescribing of antibiotics. So I've been introducing PZ Midstream to the NHS for 16 years. We now have NHS support for scale up. We're on the framework, and we are about to go digital with a home urine testing pack. We know the device reduces primary care lab spend by 66%. It ticks all the NHS diagnostic ambitions, and we're also now looking at first stream urine for early stage cancer testing, sports dope collection, it takes 2 specimens from the same stream, and more. So we have PZ Midstream and we have the specimen collection on the way. That's what we're doing.
Thanks very much, Giovanna. So to kick off our discussions now, firstly, I'm going to turn to Nick. As you've mentioned, from the Health Tech Alliance, it's highly relevant to our discussion today. And I know that you've just launched a report just a couple of weeks back titled Transforming the Medtech Landscape, COVID and Beyond, which the link should be appearing in the chat in a moment. So could you just tell us a little bit more, share some of the highlights from your report? And I know there are 15 recommendations in there, so it'd be good to hear a little bit more about those.
Yeah, of course. So just to say, the report, as you say, was published 2 weeks ago, and we've been having, as I hear, some good feedback from it, partly because it's quite short and sweet and doesn't ramble on too long. I think one of the key objectives of the report was to bring the knowledge of the members into it. So we had a lot of consultations with the members to get those insights from them, particularly looking at the first peak of COVID and what learnings we could get from that. And the ideas of how we could use the NHS to pull innovation into the NHS rather than having to, I suppose, drag innovation to the NHS. So we looked at it in two forms. First part of it was looking at the challenges and barriers. And the second part, as you say, identified 15 recommendations. I'm not going to go into detail on everything, but I'll come up with some highlights. I think one of the first problems was an area of definition. Of course, Medtech is a blanket term that doesn't help itself. It's everything from single-use consumables to complex hospital equipment, diagnostics, etc., and everything in between. And that, in a sense, is part of the issue. I think defining what we do is very difficult. Innovation might mean a product that is tried and tested and the standard of care in certain markets with lots of evidence. And the same word innovation implies something that is yet to acquire a suitable amount of evidence. There's a well-known statistic published that it takes 17 years from getting a product from clinical introduction to right up to adoption. Actually, was way too long. And some of the reasons for that is the fragmented system. If NICE at the centre says this is a product that should be used, then the bureaucracy at the local level can stop that implementation. And what it means is that medtech companies have to go trust to get adoption, which is quite frustrating. I've mentioned about the evidence problem. Another issue is short-termism, looking at the focus on affordability, this going down to the lowest level of unit price for a product, rather than looking at this long-term benefit to the patient and those patient outcomes. Then there's the issue of signposting, this lack of signposting where there's a number of bodies that have perhaps an overlapping remit, and it's confusing for companies. Do they go to Health Tech Connect? Do they go to the AAC? Do they go to the academic health science networks or to NHSX? And that confusion is also one of the key barriers. Then there's incentivization. We have legislation, the 2012 Health and Social Care Act, which split the payer-provider and introduced competition into the situation. But that focus on competition means that you can have these disincentives. So hospitals get paid to perform a certain procedure or insert a medical device. And of course, if new technology comes in that's cheaper, there's a disincentive for that hospital to take up the new cheaper medicines or cheaper products, because obviously they get less money. So that's just a few of the barriers. What were some of the solutions? One of them was adopting best practice, not just in the UK, but also looking at best practice abroad. One of the discussions looked at how the German system of reimbursement could be considered. Then in terms of COVID, there was a number of issues with looking at the real priority of the patient backlog that we have, looking at postcode lotteries and really looking at where focus should be in the system. What should we focus on? And that looking at the official figures and the real figures was felt to be one of the issues that should be considered. Then as we move to ICSs, these integrated care systems, away from CCGs and what we have now, there was felt a recommendation to make sure those bodies have the necessary tools and leadership to drive innovation, because innovation doesn't just happen on its own. It requires it to be adopted and take up and be supported along the way. What else was there? Fast tracking the work of the AAC, the Accelerated Access Collaborative, looking at the rapid uptake products. Well, obviously there's very few rapid uptake products, and we could have more of those. So that the work of bodies like the AAC and indeed the ICSs, and this move away from competition to collaboration and partnership was a key recommendation. And then there's others. I mentioned long-term funding was another recommendation, where we have to give sufficient stability to bodies such as the academic health science network, so that companies who are looking to introduce their new technologies have places to go that know they'll be around for the foreseeable future. So that's just a snapshot of some of the barriers and recommendations, but I'm sure we'll discuss more later on.
Thanks very much, Nick. And yeah, we look forward to spreading the report more widely, because it's a great piece. Sally, I'd like to turn to you now, also from sort of that helicopter viewpoint. I'm sure a lot of what Nick's just talked about really resonates with you, and across your sort of broad brush of clients and working with multiple organisations, both large and small, it'd be good to just hear a little bit more about what the broad challenges to adoption are that you've been seeing across the medtech industry. Oh, you're on mute there, Sally.
That's right. I thought I'd pressed it, but obviously I hadn't. Right. Yeah, interesting question, and I could probably wax lyrical for hours, but you'll be reassured to know that I'm not going to. I think when I first work with companies who are starting to try, and actually sometimes have had many years of trying to engage with the NHS, one of the things that people find quite overwhelming is simply its complexity as an organisation. All the different elements of it, everything, of course, there is NHS England and NHS Improvement that are increasingly coming together. You have obviously the Department of Health and Social Care based down in London. You have NAHR, you have NICE, you now have entities, very valuable and useful entities like the Accelerated Access Collaborative, whose membership is multifactorial. And people struggle to try and understand how these all interrelate to each other. So, for example, if you think about some of the initiatives that you see as well around that are all within the NHS and trying to drive improvement in services, which of course so often can be supported by the use of medtech and diagnostics, etc. You have initiatives like Getting It Right First Time, which is driven from NHS organisations visiting each other and generating information and data and ideas about how individual organisations could improve their care delivery. But then you also have organisations like NHS Right Care that is collecting data and helping organisations to benchmark themselves against comparators. And then you have NHS Digital, which uses data which is collected from hospitals, etc., like the health, the HES data. And then you have organisations like NHS Digital that is trying to transform care through the use of digital technologies. And actually that trying to unravel who is responsible for which bits of the system is often something that is overwhelming for people. And I will confess that it's now sort of 4.5 years since I left NICE, and I find it hard, even though I've spent 30 years in the NHS, to keep up with all the changes. So that is certainly, I think, a very tricky aspect that people are frequently challenged with and sort of head scratching. Layered over the top of that, of course, is NHS strategy, and we have the NHS long-term plan. But underneath that, there's then lots of elements that make that up. So even if you think about something like cancer care, there's a whole raft of infrastructure to support improvements in cancer care, and that then gets broken down into different types of cancer. And once again, sometimes companies really struggle to know who they should be looking to and who they should be talking to try and understand, when they've got innovative products, how they might actually best be able to bring that to the NHS and help to improve outcomes. And then, of course, there are multiple NHS organisations, and as many of the people who perhaps are on this call are aware, if you want to bring a product to the NHS, you frequently, unless you're lucky enough to be included in any of their national initiatives, you frequently have to literally go to individual organisations once, one at a time. And that is a huge resource impact that often, certainly SMEs, when they're first starting out, they really, really struggle to be able to do that. But every NHS organisation also has slightly different ways of doing things, different processes in terms of how you produce a business case or what their procurement systems are, etc. And so it's a complete minefield. So that's a sort of an overarching element. One of the things, of course, people are most interested about is how they convince the NHS that their product actually works and that it's going to bring benefits to the NHS, both from a clinical perspective in terms of evidence, but also from a cost-effective basis, because especially with the NHS being under such financial constraint, it has to be very careful, of course, about what it spends its money on. Now, certainly, no NHS organisation in this era of governance and on the back of some spectacularly sad failures of care that we've seen over the years should be or will be wanting to introduce products where it's not clear that they are safe and efficacious. And of course, in the arena of clinical evidence, randomised control trials are always viewed as being the gold standard, and it's certainly something that NICE elects to focus on whenever it possibly can for all the right reasons. But of course, when you and that's maybe relatively easy, I say in inverted commas, when you're looking at pharmaceutical products, because if you are asking a patient to take a tablet, it's very easy to give them a placebo, and they don't know, and the people that are running the research don't know what the patient's actually got. So in terms of measuring the benefits and the outcomes, it's not easy, but it's relatively simple. By the time you're looking at medical technologies and diagnostics, it's quite hard to hide from the clinician and sometimes the patient what the actual piece of equipment is that you're using or what diagnostic test is being applied. And therefore, being able to generate randomized data is particularly tricky, and that is a challenge when it is so highly valued by the people that are evaluating products. Real world evidence is fortunately increasingly being given an awful lot more of emphasis, and this is something that NICE has been talking about for a long time. But I find that often organizations struggle to be able to work out what the real world evidence should be and how they should be collecting it. And it's really good news that the academic health science networks have been given a role in helping to develop that. And I know that many of them are working with industry partners to help them to collect that data. We're still not quite there yet, I think, in terms of how that is interpreted and valued, but we are heading in the right direction. Of course, the other aspects of data collection in the form of clinical trials is whether or not data is prospective or retrospective. And again, that they have different values, and companies sometimes are really never quite sure which is the best route for them to go. So in an overarching way, I'm just trying to explain that in my experience, this is an area where companies really do need often some support. And the other aspect of that is that so often I sadly see when research has been sponsored by companies who are really trying to demonstrate how effective their products are, the very fact that they have sponsored the research is somehow viewed as being tainted. And that's actually a real, I'll call it an oxymoron, because it's a very difficult problem to solve. I suppose the other element, of course, is about cost effectiveness, and that goes hand in hand with the clinical effectiveness in the modern NHS. And often people just simply don't know where to start with that. And in fairness, one of the problems that I find a lot of the time when I am helping companies to review evidence that they have already has been published for their product is that because the focus of the evidence is primarily on demonstrating clinical effectiveness, the data that actually helps to prove cost effectiveness, so for example, reductions in the length of time that people need treatment for, the numbers of treatments that people might need, even in terms of something like dressing, wound care, how frequently dressings get changed, and all of those sorts of things that combine, or how long is spent in the operating theatre, who are the actual professionals that deliver the care? Can this be something that's delivered by staff that their salaries are not the highest, should I say? that data is often not collected in trials, and so companies often need support to work out how they're going to collect that information, and that needs usually a good relationship with clinical teams in NHS organisations that they can engage with, who are willing to collect that data for them. And finding those people to have those relationships is actually not often that easy. So I think the other element of that of this, just to sort of wrap up in relation to medical technologies and devices, is that often there are relatively long time frames that are needed to show that the outcomes are going to be continued. So just to think of an example, I'm just thinking about things that I wrote down earlier. Well, I suppose, if for example somebody has spinal surgery and the particular piece of equipment is used, you need a number of years to know that, one, any benefits that are delivered immediately continue, and two, there are not complications over time. You might need 5, 6, 7 years to be really confident that that technology has achieved those long-term benefits and to demonstrate that long-term cost effectiveness. But in terms of what that means for SMEs in particular, but even sometimes some of the very large global companies I work with, that is a big ask to be able to make that demonstration. Whereas, of course, again, from a pharmaceutical perspective, that length of time is frequently not needed in the same way. So I think probably those are the main points that I would say are some, if not all, certainly not all of the complexities that companies face from a helicopter view.
Thanks so much, Sally. I think, as you've rightly said, it is a minefield, and there's so many different factors that impact on adoption, some of which we'll unpack today. But I think it's a conversation that could carry on for hours and hours. It feels like the right moment actually to just mention, and Neil has dropped the information in the chat, but we had a speaker from the Accelerated Access Collaborative earlier on today, and she was talking about the new innovation service, which is going to be coming in late summer 2021, and this is all about helping to tackle this problem and bringing forward innovation into the NHS. So we would employ you to go and check that out, and there is a call for user testers, so do check out the link and find out more about how you can get involved in that. So now we've heard from the sort of helicopter view, I'd now like to drill down to how medtech companies are experiencing it on the ground. So first off, I'd like to come to you, Andrew, and just find out a little bit more around some of the challenges and how you've been navigating sort of providing evidence provision for the Gecko device.
Sure. I'll just touch a little bit on linking back to the helicopter picture, and then I'd like to just move forward. And this is just our example. It's our product. It's our technology. It's our company. So I think it's just useful getting that specificity. So I think the first thing I'd want to say from a helicopter perspective briefly is that I have lots of colleagues even inside our company who've got a pharmaceutical background, and the comment they always make is that Medtech's very fortunate because we can come to market off the back of phase 2 studies. We don't need the big randomized controlled trial to come to market. And that's true, but it's very much a double-edged sword, because although we can come to the market with a relatively small phase 2 study, and that gives us a CE mark, what it means is we do not start on day one with definitive randomized evidence that our product is better than another product. Neither do we automatically get reimbursement. So if you look at wound care, for example, there's a positive list, the drug tariff for prescription, and you do not automatically go on the drug tariff. You get a CE mark and then you begin the process. So I think what's important to understand is that, yes, Medtech can access the market early, but having said that, we cannot get immediate reimbursement. So what we did was we got the CE mark, regulatory approval. We then engaged all of the elements that have been mentioned. We've engaged SBRI, we've engaged AHSNs, we've engaged NICE. We've actually got NICE guidance Medicines Technology Guidance, MTG19, for our Gecko device. And we went and talked to everyone that we felt we needed to talk to. I'd absolutely echo the comments that Sally made, which is it's not necessarily the easiest thing to do. And we probably didn't do it in the right order or at the right time. And I think the signposting, as both Nick and Sally have mentioned, could definitely be improved. But we did engage all those organisations, and we've had help from all of them. And in fact, our NICE guidance came off the back of scientific data. So this is all wonderful so far. But then when you actually get to the hospitals and the clinicians running the departments, then they say, okay, you've got NICE guidance. I think the wording says they have to take account of it if it's medical technologies guidance. So it's not mandatory. So they say, okay, interesting. Where's your clinical evidence? Where's your economic evidence? So we then have to start to build. And really the two options are exactly the ones that Sally referred to. You have a part of the market, the academic teaching hospitals, etc., that will say to you, you've got to start off with a large randomized control trial, placebo controlled, multiple arms, etc., etc. As an SME, that is beyond daunting. And in fact, you know, this is our device. It produces an electrical pulse. So we cannot create an effective placebo. It would be obvious as to whether it's working or not. So we can't make a pure protocol in the pharmaceutical sense of a randomized controlled trial. Our other option is real world data. But again, Sally's absolutely right. What do you include? What don't you include? How do you gather it? Is it credible? And with how many people? And will you end up having to repeat the exercise with every hospital and trust that you go to? The answer is yes, initially. So interestingly, on the wound care side, we've gone down the randomized controlled trial route because that's what the drug tariff said that they needed. On the DVT prevention side, we've gone down the real world data gathering. So I take the real world data gathering. So we approached the major academic hospitals. They all wanted us to go from scientific laboratory-based data directly to large-scale randomized controlled trials. That simply wasn't feasible for us financially, amongst anything else. So what we did was actually go out and talk to hospitals up and down the country who had a record of publishing in the field of DVT prevention, who'd maybe been involved in other studies. And they were, you know, large volume centres, not necessarily the most academically pure centres, if you like. That's no insult to them, but they will understand what I mean if they see this comment. So we were very fortunate to find at the University Hospital of North Midlands, the Royal Stoke Hospital. We were very fortunate to find a team, a professor, lead consultant, some band 7, 6, 5 nurses who were very passionate about stroke care. And they were excited by our scientific work. They were excited by the NICE guidance, and they really wanted to engage. And so they asked us whether or not we would be willing to engage in a real world data gathering exercise. So the idea was theirs. And that was, I remember the meeting. It was a Tuesday afternoon in Stoke, as it were, literally. And from there, we went through a long journey. So in the event, we worked up a suggested protocol. We worked up some forms. All of the internal permissions were obtained. So there were 3 levels of governance within the trust that had to be negotiated by the team there. You know, copious amounts of education and training and permissions, sign-offs, procurement department, pharmacy, finance department, compliance in terms of, as I said, governance and so on. So it probably took us a year to get into a position from the idea when we could enroll patients. And I'm delighted to say from the beginning to now, over 1,300 patients have been enrolled in that real world data analysis. And all they did was say, we will follow the existing stroke guidance for the UK. And where patients can tolerate and take and are appropriate for the current technologies that have been validated by randomized controlled trials, the patients will get those. But where 30% or 20% of all admitted patients cannot use the existing therapies, we will use this new therapy, because rather use the new therapy than not protect the patients at all. And this over 12 months, over the first 12 months, over 1,000 patients were engaged, and the study was written up. It's been published and presented in the UK. It's been presented internationally, and it has it impacted our ability to get an FDA approval for DVT prevention. We still haven't necessarily got national rollout in the UK, but it certainly encouraged the Luton and Dunstable Hospital to do their own audit and repeat what's happened in a mini way. Swindon was the same, Kingston was the same. We had to do a level of audit for them too. But we're now getting to hospitals 6, 7, 8, 9, and we're beginning to get people saying, okay, if you've got a number of NHS hospitals that have all audited and found that they've all got this same problem, maybe we don't need to audit to find the problem. Maybe we just evaluate your technology. So we are beginning to see a rollout, but it's, you know, a huge amount of time. And definitely it's trust by trust, hospital by hospital in the early days. And you have to repeat the exercise hospital by hospital. People are not willing to take one set of data and apply it. So on the a key point I would make is that without the leadership and the passion and the commitment of the clinical team in the Royal Stoke stroke unit, we could not have got there. So, you know, despite all of the organizations at the helicopter level, if you like, that we've engaged with, who are excellent in doing a good job and all with the right intentions, when you're getting down to that hospital level, a number of the things that Nick talked about come into play. You know, are you going to make a saving within the financial year, the actual year? Who signs that off? Who takes on board the training costs and the education costs? We had to have pharmacy forms, prescription forms reprinted. I think we lost about a month and a half debating within the hospital who should sign that off, because there was a several £100 cost of reprinting those forms to add our Gecko device before we could start our evaluation. So we certainly had to stay very close to it and offer support all the way down the line. But, you know, there was a huge amount of effort from the clinicians in the NHS doing the bedside role. And bearing in mind they have busy roles and they're full-time employees doing that role, to ask them to do an extra 20 or 25% of time to manage an innovation through the process seems difficult to me. And as I say, without their passion for improving patient care, we would have never have made it. So I think from my experience, you know, it's great that there's so much political will, if you like, with a small p, within the health system to bring innovation in. But we've got to remember, it always ends up with a doctor or a nurse or someone on a ward having to fill in the forms, apply the devices and do whatever it is. And I think we can do a lot more, not only from a health system side, but from an industry side in helping that whole process. So particularly with real world data, there's a phrase from a play I like, and it's depending on the kindness of strangers. And I guess my summary of real world gathering in particular is, to some extent, both the NHS and industry are depending on the kindness of strangers at the bedside level. And we're depending on them working into the evenings and working weekends to fill in forms, to complete clinical data, to get innovations into the NHS. I'd love to think we could all do more to support them.
Thank you, Andrew. Some really interesting insights. And I'd just like to flag as well that there's a brilliant story from the team directly in the Royal Stoke University Hospital, Dr. Indira Natarajan, who's done a fantastic piece about exactly how Gecko was implemented. So the link should be appearing in the chat shortly.
Yes, that's on the Bob Health stream, and as you rightly say, Chloe, it's from the horse's mouth, as it were. It's from Dr. Nasarajan and the team, and if anyone reads that piece, they will see all of the practicalities and all of the very, very many complex things that had to be done inside the hospital to get this project from idea to delivery.
Thanks, Andrew. So, Giovanna, I'd like to turn to you now and unpack a little bit more about what your experiences have been around sort of gathering that evidence provision to get PESI adopted.
Well, thank you very much for inviting me on. Our evidence gathering has been a little up and down. One of the first studies we had with PESI midstream, which captures the midstream part of the urine specimen, that is accurate, because we found from our research that 1 in 4 urine specimens are inaccurate. There is no protocol for collecting urine, and despite midstream being the recommended part of the stream, there is no guaranteed way to achieve that. So where you have blood and urine that have diagnostic parity, you have very strict protocols around blood and none around urine. So when my GP brother, Dr. Vincent Forte, invented PESI, it was to actually tackle this problem of women coming back for repeat urinary tract infection that he thought he treated. I suppose one of the problems we've had is that we're highlighting a hitherto completely overlooked area of diagnostic medicine. Because urine is a waste product, it hasn't commanded the respect that it deserves from a diagnostic point of view. One of the first trials we had at the Royal Free compared PESI collection with ordinary collection straight into a tube. And the protocol said that all PESI samples would be dipped and cultured along with everything else. Now, when we got the results, they said PESI doesn't work. It took me a while because I don't come from this background, but I studied the paper that was published. And actually, when they dipped the PESI samples, if there was no result on the dipstick, they discarded the sample and they didn't culture it. So in effect, they threw away every single piece of positive evidence that we had, because the dipstick will respond to contamination in the sample. If there is no contamination, it won't respond. So that study actually causes an awful lot of problems of people saying, look, it doesn't work. But the people that look at these papers don't actually always check that the protocol has been followed. In that case, it wasn't. A, in that respect, and B, in the respect it didn't use the number of patients it said it would. So that was one hiccup. We have had since a lot of very good evidence. Public Health Wales trial PESI in primary care, and they have said, from a clinical perspective, we have seen the number of prescriptions for antibiotics reduce, as well as the number of mixed growth culture results. We were able to get the best outcomes for our patients in the quickest and safest manner. Now, for the most common diagnostic liquid to achieve that result is fantastic. We also know that Public Health Wales estimated a 66% saving on lab spend, which brings me to another hurdle that we've encountered, where I have approached some of the labs that are commissioned by the NHS to provide lab services. I have been told there is no way we would use or recommend use of your device, because we are paid per specimen, and if you reduce those specimens to the extent you say you do, you will knock £500,000 off our bottom line. So unless those providers to the NHS who are providing those services are incentivized to save money, they're not going to do it. So something like PESI that will improve diagnostics, it'll improve the accuracy of results, it'll improve right first time diagnostic and prescribing. If it's actually being resisted by the very people who are processing those results, you know, we've really had to struggle to overcome those sorts of situations. Another hurdle, sorry, I'm doing the hurdles first, is that somehow where pharma, when there is a new drug released or a vaccine, as we know, the people who've made that and the name of it are widely written about. They're widely acknowledged, you know, isn't this great? When you have a device, it's slightly different, because 3 years ago, I think the person responsible for this has since retired, but one of the Get It Right First Time leads said to me, we're not here to promote a device. Well, but this device gets things right first time. So how does that work? More recently, I approached the RCGP to sponsor an e-learning module on urine collection, just generically urine collection. And they came back to me and said, our concern is that the method to collect urine safely can only be done utilising your device. Therefore, we feel it made point to promoting your product. So the answer to that was no. So you have a professional body that is there to help their members do no harm, but it won't actually tell them how and allow them to make their own decision about whether or not they take up that device. I don't know about you, but I'm quite shocked by that. So devices and prevention seem to me to be the Cinderella of any kind of adoption in the NHS and in the private sector. You know, that operate very much on the same levels. The more people they have going into the hospitals, the more money they get paid. Now, I might be cynical and maybe be shot down for that, but if someone can point out to me how that doesn't work, I'd be very grateful. We have something that was overlooked that we've highlighted. We have got our message across. We are getting take-up. We're being used increasingly in antenatal clinics because obviously if you're pregnant, you don't want antibiotics you don't need, that you are prescribed as a result of a false positive or a contaminated urine sample. So we have take-up there. We are being rolled out across Wales from this month. And the Eastern AHSN have looked at everything we've done and said, this makes absolute sense. Yes, we will support you for national scale up. So really, it's been the latest iteration of PEASY came out 5 years ago, and it's taken that long to get the right evidence and the right support ready for scale up. One thing that COVID has done for us is helped us kind of pivot, because obviously when people weren't going to their GP surgery, sales fell off a cliff, and we all sat there scratching our heads saying, oh, what do we do now? Oh, let's make a home test. So Test Card and we are getting together, and we're creating a digital home testing kit, which we are hoping that we can collaborate with the NHS diagnostic leadership and have that sent to patients when they present with UTI or antenatal screening. The result can then go straight to the patient record. And because that kit will test from midstream, it will be the most accurate home urine test on the market. Because we do have, I'm happy to say, the only midstream urine collection kit in the world. So that's my summary. It's not been easy, but it's possible. But there are vested interests that get in the way, and those really have to be tackled head on by NHS leadership, so that devices are given parity with pharma, because, you know, prevention is much safer and cheaper than cure.
Thanks, Giovanna. We've actually just got a comment in the chat there about, is there any reflection from the panel, like put this to the whole panel, on when you've got, like Giovanna, you've got a device that people don't see that unmet need at face value. Any reflections there from the others on how to tackle that?
If I might add, one of the issues is the silo budget thinking, which is gradually being broken down within the NHS, which is the budget that will buy something like PEASY at you know, around 90p, 99p, isn't the budget that will save, which is the lab budget. So that silo thinking will also becomes a barrier to purchase. So those things need to be joined up by leadership, which is what they've done in Wales. They've looked at the overall saving and said, right, this works.
So it's Sally here. I think my view on that would be that it's finding the person that actually is dealing with the problem, because I recognise what Giovanna says about disincentives for organisations, etc. But somebody will be dealing with the consequences of not having the access to a technology or a device or whatever that actually could be solving a problem. And you can do that on many levels. You can do it on a clinical level, because as Andrew said, at the end of the day, you talked about it in the context of data collection, but at the end of the day, of course, it's the frontline staff that end up using these products, and it has to be making a difference to their care delivery and the outcomes for it to get any traction whatsoever. Yeah. But sometimes I think it's very easy to miss I'll call it miss the trick of what it is the challenges are that an organisation is struggling with and how your product can actually make a contribution. So just at a very, very high level, if you have a product that means that whereas a patient may have had to have come to hospital 4 times a year to have a checkup, but your product will mean that either that can happen remotely or actually they only need to come once a year. If that organisation has got a significantly long waiting list for patients to have either initial appointments or a follow-up appointment, and you can take out of the system the need for multiple visits by people, you've potentially seriously contributed to that organisation resolving a waiting list problem.
Yeah, if I might comment there, I mean, something like Peasy, one of my more naive mistakes is to go around talking about urine collection, which I realise I've done again today. But actually, it impacts AMR, it impacts patient safety, it impacts infection control, and it impacts unplanned hospital admissions. So just on some stats, 50% of the global rise of AMR has a urinary source. So that must be because people are being prescribed antibiotics they don't need because their specimens are unreliable. The last Unplanned Admissions Committee data on this shows that 184,000 people unplanned hospital admissions were because of untreated UTI, and that cost the NHS 434 million to treat. So those messages to all those different people, getting that across simultaneously is quite difficult. If we go to the admissions people and say, you could have saved 434 million by collecting urine specimens properly, they'll look at us and go, you're nuts. Communicating that is something that I would love help with, because we have so many different strands of information that boil down to one very simple thing. And I agree with you, it makes the frontline staff life a lot easier. Watford Antenatal Clinic, they've said they save over 40% of nurse time not calling people back in for repeat tests. But they didn't realise that until they started using it.
I think it's a really good question, actually. And I think, again, there's 2 aspects to it. I think it speaks back to what I said before about people at the bedside are busy. They've got full-time jobs. So they're too busy to put together the story of the unmet need. So the emphasis really is on the company, the company bringing the solution has got more responsibility to put that story together. And also it can be very difficult for the reasons Giovanna just said there. If you work in a particular department, but the downstream effects of something going wrong are in a different department, or you're in the hospital and the downstream effects are out in the community, then you wouldn't have any visibility on those anyway. For us, getting people out after knee surgery very quickly from the hospital is something that everyone says is a good idea. Well, if you track the number of emergency room visits and you track the number of readmissions and revisions, then maybe it's not always such a good idea. But it's very difficult for individual people in individual parts of that value chain, if you like, to get that data together. So I do think as an industry, again, we've got to be really clear, and I think Sally made the point well, we've got to be really clear on an unmet need for who, and what difference does it make? What happens now? What will happen after your innovation has been brought in, and who does it impact, and how does it impact them? And just saying there's an unmet need isn't enough for the reasons that I just mentioned. I think you've got to be able to paint the whole picture, and then you've got to be able to work out how that impacts the system in a way that it genuinely is a benefit.
Yeah, thanks, Andrew. It actually ties in really nicely with this. We held a session yesterday, which was actually bringing together pharma and medtech to compare and contrast around this whole topic of spread and scale and adoption in the NHS. And actually, you probably end up disagreeing, but there was actually quite a lot of similarity between the two. Exactly as we've just discussed around this need to take a bigger picture look at the whole system and sort of seeing where it fits in within the system and how, as an organisation, you can support around that. That really came across as a key theme, and everyone, agreed on that. So I'd just like to turn to Nick actually and just pick up on your thoughts on this topic as well, and just if you've got anything to add to what we've just been discussing there.
Yeah, I mean, I think there's a number of things. This is, I mean, you mentioned the difference there between health tech and pharma. I think there's big differences. You mentioned them earlier. The key one is that once you get guidance or approval from NICE for medicines, you get the money, and you don't get it with health tech. And this is why it's very important. This new Medtech funding mandate that has been delayed because of COVID. It hopefully will be out in spring of next year, which will mean there will be this contractual obligation that if your product, your device, your diagnostic is approved by NICE and it has cost savings, then you will get funding for it, and you won't have to go hospital to hospital. It will automatically happen. So that's what is on the horizon, which is very positive. I suppose the sticking point there is that there's still the need to make cost savings in a single year, and that's the bit that we hope will be removed, because it's just simply not sensible to leave that in, because the savings that are there. The second point I make is, I think once you have integrated care systems properly in place and people can see the big picture, so you're not having this sort of artificial competition between payer and provider where, oh, it's not my saving, I don't want to pay for it. That will be hopefully removed once we move to these ICSs, where the people who are seeing the whole picture have the money and then can pay appropriately for what is required to achieve better patient outcomes. So on the horizon are really important changes that are going to happen. And what I would say is that the industry needs to become more effective at lobbying for those changes to happen, so that we support the AAC, the Accelerated Access Collaborative, we support the academic health science networks, and lobby harder. I remember one of the very first meetings of the Health Tech Alliance, and we had a very senior person from the NHS, and I asked the question, what is it the difference? Why does pharma get a bigger slice of the action? Why do they get the Cancer Drugs Fund, where for effectively drugs that NICE said they wouldn't approve? And the answer, as he said, is because they get in our face, because they push hard and make sure they make their arguments effective for why the change must happen. And I think, it was quite a blunt answer, but it's a message back to industry that we need to become better at advocating for our new products, our new innovations, and making people understand that the savings might be down the line, but the real benefits are to patient outcomes, which might only happen in year 2 and 3 and so on. But we need to keep pushing hard.
Thanks, Nick. I'm just going to, we're running short on time now, and I want to make sure that we have some time to take the questions from the audience. So I'm going to ask you to be quite quick fire in your response, and I'm going to come to you first, Sally, and ask you, what would be your one key piece of advice for any health tech companies as they look to roll out their innovations? Oh, you're on mute there, Sally.
There's always one, isn't there? Right, one, that's tricky. I think because it's about being able to get traction in the NHS. So I think it is my point about really understand that bigger picture in terms of the pressures that NHS organisations are under, and how you can support the organisational objectives and strategies and performance targets, etc., as well as, of course, helping them to deliver improvements in care.
Thanks, Sally. Nice and short and concise, but great advice. Giovanna, quick fire. What's your one key piece of advice, and maybe some of the learnings that you had? What would be the one piece of advice that you would?
Evidence, and make sure you belong to the ABHI.
Thank you. And that actually, before, although I will come to it at the end, but we also should mention about being part of the Health Tech Alliance. And I should have asked Nick, how can people join the Health Tech Alliance? And what's your one recommendation?
So thank you for the plug. It'd be great if they join. Go to healthtechalliance.uk. All the information is there, and my colleagues and I will receive an email from you, and we can take you through all the benefits. So that's how joining Health Tech Alliance, and thank you for the plug, Chloe. I think there is it's been alluded to today. I think the last 18 months, maybe 2 years, we've seen enormous change that impacts on the health tech and on the digital space. We have seen literally new body after new organisation, new programs, new initiatives, new strategic reviews, new test beds, new pilots. Literally every other month, something new has come out. Whether that's AI awards that was announced by the Secretary of State at our first event 9 months ago, whether it's the changes of the AAC, Health Tech Connect, PCNs, that's primary care networks, end of tariff, moving to blended rates, new data collaboration center at NHSX, literally numerous changes. So my one thing would be keep up to date, because there's things that keep being announced, new monies, new pots, new test beds that I think companies can apply for and should be applying for.
Thanks, Nick. And finally coming to you, Andrew, what's your key recommendation? One recommendation.
Okay, I think in a nutshell, it's keep it real. What do I mean by that? Tell your investors that your technology is disruptive. Don't lead with that in your NHS messaging, because disruptive to investors is attractive. Disruptive to the NHS who are busy is not as attractive a message. And so remember, it's not just about your product or your technology. It's how your product interacts with the protocol and the pathway. So if you look at Stoke, it's the clinicians are very clear. The pathway change involving our technology, but not being the only factor, that's what halved the rate of DVTs in that hospital. So always be modest, if you like. Understand that your product is just a piece of the jigsaw, and it's about making the whole jigsaw work.
Lovely, thank you very much. Yeah, and obviously we do hear about disruptors, and that word is bandied around quite a lot, and it's okay in the right context, but as you say, maybe not. Think about your audience.
Yes.
So we're coming up to the last sort of 15 minutes or so here. So I'd just like to go into some questions that we're getting through from the audience. So one of them was obviously about AHSNs, and Giovanna, you helpfully mentioned that Eastern AHSN have been really fantastic support to you. Just like to ask the rest of the panel, are there any other particularly helpful AHSNs that you would like to just give a shout out to?
We've worked with the one in the Northwest, and that's been very good for introducing us into Liverpool and Lancashire area. The Manchester Innovation Group has been good, introducing us to Manchester Royal Infirmary, amongst others. So they've been very proactive.
Thanks, Andrew.
Can I chip in there and just to say that at many of the meetings we have representatives from all the academic health science networks who attend and join in. So it's might be a good way of meeting others we haven't met.
Thank you. Thanks, Nick. Oh, Sally, you're on mute.
Well, obviously, the button on my computer is not working. I think I would just say is that they are all different, and although that then makes it potentially tricky to think who's best to work with, they do actually have a collaborative where they all come together as well, and that's always with an office, etc. And that's a good place to start, because they've all got different expertise and different experience in different areas, and that's the benefit of having the number of AHSNs that there are. So if you come across one and doesn't quite deliver what you thought you needed, that doesn't mean that another one isn't going to be a better place to help you. So don't give up. They're a great idea.
Great point.
I've got a question for Nick here. From the recommendations that are in your report, which one is the most challenging?
I think the ones that are most challenging are the ones that are out of our hands. I mean, I think the key one is actually getting legislative change. So the amendment to the 2012 Health and Social Care Act and getting government to find the parliamentary time to change legislation. The NHS wants it to happen. Getting that parliamentary time, I think, is the challenge, but that will be the fundamental change, a decoupling of the payer provider, allowing ICSs, these new integrated care systems, to have their own funds and to act locally to address the problems locally. that is the biggest issue, that because it's just out of our control, we need to lobby to make that happen.
Thanks, Nick. There's a question for perhaps each of you might like to chip in with an example of what's the best example of significant spread and scale that you've had or perhaps have been involved in, Sally and Nick? Don't know who would like to take it first.
We've been a couple of members of the Health Tech Alliance. The latest one, iRhythm, which is a cardiac arrhythmia patch. That's literally just been approved by NICE. The challenges there were sort of educating NICE in a sense. The evaluation was the tough part there. I think a lot of the problem with new technologies, particularly AI, is that the evaluation's not quite there yet. Having the people with the right skill sets and the right knowledge to make the evaluation, particularly if like NICE has been very geared up for pharma for many years. I think building the skill set to evaluate new technologies and innovations is the big challenge. But iRhythm has managed to achieve that, and this week got guidance, and that's looked to get huge take up.
I'm off mute. So I think for understandable reasons, I actually sadly can't talk about most of the things I've been doing as part of my business because of client confidentiality. So I'm going to have to go back to earlier. I think on a national scale, I was very much involved with the rollout of interoperative fluid management. We're going back about 8 years ago now, which was, interesting enough, was a national initiative in the precursor to the Accelerated Access Collaborative. And what was important about that, and it plays into what Andrew was saying, is that was a technology that needed to be introduced into a care pathway and into a bundle of care to actually have its impact. So that was something, although it was complicated, the evidence was that it was definitely going to have very good outcomes for patients. And of course, I'm also going to say that both when I was at NTAC and at NICE, I had a role in working around the gecko. Right from a very early meeting when I met with members of the company to talk to them about the evidence they needed to generate. So there we go. It's a small world.
We're getting there. Thank you for your guidance, Sally.
Yeah, it was over a decade ago now, I have to say.
Yes, it's taken a while.
Yeah.
What was I should have added to that, what was the sort of magic for getting that spread and scale there, but both of you and Nick?
Like chip in first. What was the magic? I think it was doing for iRhythm, doing lots of things, getting on the new AI award, building their profile, doing what Andrew was saying, and what Giovanna was saying is in building those relationships with clinicians in hospitals, building that evidence. It's classic. There's no one thing. There's no silver bullet. It's actually doing all of it consistently, making sure your messaging is right. And I think that's what has happened with iRhythm, just getting it right and doing all the things possible and jumping on new programs and new initiatives that are out there.
If I just go next to talk about the fluid management, that's a really interesting question, because there were two levels to this. On a national basis, every trust was expected to do this, and they were given an incentivization, a financial incentivization through a sequin payment. So that worked for the NHS, and it undoubtedly helped to drive it out. However, the reality was that lots of clinicians felt that they were being forced to use a technology when they weren't always convinced from their patient's point of view it was the right thing. And that's another really important thing to recognise about the way that the NHS functions and how these decisions are made, and whether or not they're necessarily sometimes the finance can drive organisational behaviours for understandable reasons.
Thanks, Sally and Nick. Andrew, I'll come to you, and I just wondered if you've got any particular examples, maybe from sort of your previous career, previous roles even, or perhaps examples that you look up to out there in medtech world of, where you've seen that spread and scale that's been done really impressively?
I was actually thinking about it because we're, you know, at Sky with Gecko, we're still in the earlier stages of that, so I can't use that as an example. Certainly in previous roles, I've got a background in wound care, and so it just helps when you've got enough of the right things together. I don't think there is a single secret sauce. I think if I think of the things that did really well, wound care purists would know the Aquacel, Alevin, etc. You know, it was a combination of, actually in both cases, there was an understanding of the market need. You know, for exudate, for Alevin, infection, for Aquacel AG, silver. And so you need the market need to be widely understood. Then you need to show that you are a solution to that need, and ideally the best one. And then really at that time, I was working for companies who could scale. So there's definitely a financial element, but we certainly still came across disincentives, things in the system that actually work against innovation and adoption. And we also came across, as Sally was just saying there, clinicians making individual decisions about whether they like, you know, silver or iodine or some other type of antimicrobial as a personal preference. So it's multifactorial, it really is. But yeah, I think the comment about you've just got to do quite a lot of things well in parallel to really make it work is the right answer.
Thanks, Andrew. And Giovanna, are there any particular examples of spread and scale that you've seen that you really look up to?
Do you know, I can't really think of any, because all the smaller pieces of medtech like ours have struggled like we have to get spread and scale. And I think Sally said earlier, you know, you have to get the people at the front line to like what you're doing. That's fine, and that's actually more easily done than one would think, but it's getting the buyers, the procurement people, to actually buy into what you're doing, because unless they agree to buying it, people at the front line can't use it. So it's I don't know one single thing that has succeeded with rapidity. I wish I could say ours has, but it's taken an awfully long time. I think we're on a par with Gecko there. So I just think, I think the NHS is getting much better, and I think the HSNs are helping. I think, you know, the health tech bodies are helping, and I think things are improving. But thus far, it's not been easy, and we've been hindered rather than helped. And I'm very happy that that's changing now.
Chloe, if I can just make one additional comment, there's a saying that banks will always lend you money the moment you don't need them to lend you money. And in many ways, if a company can generate a randomized controlled trial perfectly structured with a stat significant result, there's plenty of help from that point onwards. But I think probably more could be done to say, okay, you know, medtech, unlike pharma, has a long tail of quite small companies. And those small companies may have hit on the most incredible device, you know, to bring benefit to patients in multiple pathways, etc. But you're unlikely to be able to start with 1,000 patient, you know, several arm comparative study. So I wonder if there is a way, and I think some of the programs and initiatives Nick talked about earlier, I think what I'd be hopeful for is, you know, a more realistic path. So if you have a device and you are not a company that can go out and pay multi-millions for a randomized controlled trial on day one, is there a way of doing sensible evaluations or real world evaluations to build the information to then design your randomized controlled trial? You know, I think more can be done in the development of evidence phase. By the time you get absolutely perfect evidence, you don't need as much help, actually.
Thanks, Andrew. And we're literally coming to the very, very end now. So I just wanted to sort of iterate some of the themes, and Nick touched on at the beginning, actually, around the importance of collaboration. and best practice sharing as well. So I just wanted to iterate that obviously we at Bob, we're also a startup and we're trying to spread and scale as well. So we totally understand and hear your challenges, but we are sort of all in it together and we're here to help each other. And I think that collaboration piece comes through loud and clear, and that's something that's really key to us at Bob as well. So we are here to help if anyone wants to help sharing their story and telling stories of how they've got implementation within the UK. Do get in touch and take a look as well at the work that Andrew's team have done in Stoke. Is a great example. So yeah, just wanted to summarise, and we are literally at the end, we're on the last minute, so I just wanted to say a massive thank you to all our speakers, Sally, Nick, Andrew and Giovanna. And yeah, it's a conversation that could keep going for hours, and I think there's lots to be done, but please do check out all the links that Neil has shared, and share your thoughts as well using the hashtag unpack the how on social media, and we'll keep the conversation going. But for now, thank you very much, everybody.
Thank you.
You work for the NHS. You've had a great idea, you've made it happen, and it's made a big difference to how we can learn from COVID-19 and enter a new normal. Ideas like yours drive improvement and they deserve to be shared. That's what Bob does. Amplifying good ideas like yours across the NHS so as many people as possible can learn from, adapt and implement your idea. The further good ideas are shared by the Bob community who learn from them, the greater improvement we can achieve. You made a change. Share your solution with others. Speak to Bob.
Hi there, I'm Nick. Hi there, I'm Nick Voke and I'm Bob's Quality Manager. I'm here today to talk to you about all things Bob. I thought it'd be nice to give you a bit of a background on me. Until quite recently, I worked in the NHS. I was working in the pharmacy department and had done for around 8 years. My last job was to work under the brackets of QUIP, which was an NHS England pilot, and we brought in a lot of high-cost drugs into departments across the hospital, and what we wanted to do was make sure that they were being brought into practice in a way that's suitable for our staff, supports them, supports our patients on the changes, and makes things run as smoothly as is possible. And that was really where I gained my experience of wanting to have somewhere that I could share my learnings. I knew I was in a very, very fortunate position. I was able to have time dedicated to making packs of information that would be useful to be disseminated to other people. And I wanted to share that with other hospitals, and I wanted to be able to do it really easily and just have a place where people could go and click, and then that would be that. Prevent that reinvention of the wheel, prevent wasting time, and make sure that people are aligned where they can be and know that they're supported. That for me was really, really important. And a chance LinkedIn message from Mark, one of the co-founders of Bob, got through to myself, and we had a conversation about what was going on with Bob, what the thoughts were before. This was probably back in August 2019, and it was a great conversation to be able to have, and we just clicked. Basically, we had very similar interests. We had very similar moral backgrounds, principles. Our moral compasses were all aligned to the same similar things. So I went to meet them, and we had a production session where we made post-it sets of what we thought Bob might look like, and I was very excited. So I came back to work in my job. I was very, very happy, and then I was asked by Mark and Neil if I would consider coming and joining Bob, and I couldn't miss the opportunity. The timing was a little bit tricky for me personally because I was joining Bob in March, and that's when coronavirus hit, and I felt a sense of guilt to be leaving a hospital at first, but I also knew that deep down this is much more important than what my brain at that time gave me the ability to think it was. And it's key for people to have somewhere that they can come and share all that experience, especially now. So much stuff has been done, so much red tape's been removed, and it's brilliant to be able to say that we've got a platform where all that can be shared, and it can be shared well, and it can be shared easily. We've got brilliant platforms that exist for sharing case studies and scientific journals and all these things that are so important to be able to make practice great. But what we don't have, and what I feel desperately need as NHS staff, is a how-to practical hub where people can share their project nuances, the intricacies, the things that make things tick, just who you need to maybe consider job role wise to be able to get the ball rolling on a project. How do you approach writing a business case? And all those kinds of things that you just don't know from the background. So it's nice to be able to have somewhere that we can do that, and we can do it well, and we can do it safe and securely for staff. Now, this should always be free. That's a mantra for Bob. That's a mantra for myself. Like, people need this, and I'm very, very privileged to be able to be part of it. So off the back of that, I joined Bob, like we say, and we did a little bit of user testing and some research with psychologists, and we came to the promise that there was probably about 4 things that really motivated people to share. Number one, it's part of their job role. So
Part of my job role, I felt, was to disseminate that information to people that probably just did not have the time to. Altruism. People in the NHS are naturally altruistic. It's an incredible characteristic. 3, recognition for team having done a good job. I couldn't have done the projects that I did under the quick bracket without the team. It wasn't just me. It was nurses, the support workers, the receptionists, the pharmacists, the consultants, everybody that made that project work, and everybody that should be given that sense of achievement. And that's something that I feel that Bob really does address. And number 4 is career progression. So people want to progress. They want to be able to learn more and do more things. And that's great. And I feel that this platform really does support it. I'll come back to these slides at the end of this session, and we'll look at the things that really what Bob can do to address and support staff on looking at these. But for now, let's delve in.
What I'd love to start by is showing you an actually finished and live impact story. To do this, we simply log in, click onto the tab that says Read Impact Stories, and here we can either search or click onto an impact story that interests us. I'd like to view the story called Rapid Rollout of Digital Consultations. As you can see, we have a video summary to the middle, and next, which walks you through to each question. To the left, there is Impact Story Overview. This is where we can skip to any given section of the impact story, or choose the icon to the top right to view a story as a single page. Under this, there is an icon where you can ask the author a question. And finally, there are also social media icons where you can share this story with your peers at the click of a button. So, this is a fully functioning write-up on Bob. Now we'll break it down and show you how the process actually works. So, let's get started and click on My Dashboard, located to the top right of your screen. Once on your dashboard, you'll come to see this screen showing all the stories that you've got live, ones that you're working on, and where you can start from scratch. You'll then see this screen, which is dedicated to your title and has a few tips on how best to approach this. I'll now click Next, and you'll come to see a set of questions. These are aimed to tell the Bob team a little bit about yourself, why you're writing your story, and what you want to gain from the write-up. We then come to a screen briefly explaining senior staff approval. There's no actions at this point on the website. You simply need to start thinking about who you would like to ask. Having approval from a senior staff member you either completed your project with or your line manager is really important to us. It acts as a proof for you from someone close to the project to capture any extra nuggets and considerations before it comes over to me for a final review. Compliance is super important to us, so we need to make sure there's none of the stated points mentioned on this screen in your project write-up. We are approved as working in line with national NHS digital standards, so we work to the same standards that you're used to already with data. Now we can see a pre-recorded screen. Let's watch it.
Hi there, I'm Nick Voke and I'm Bob's Quality Manager. I'm here today to run you through an introduction of what you can expect from writing up a story on Bob, and also I'm the person that reviews your story at the other end and helps you once you've hit submit. Bob's split into 3 sections. The first section is called the narrative. This aims at giving your reader a snapshot of all the things that will make them want to read more. Part 1 is designed for projects that are both live and completed. This unpacks the real how-to questions of redesigning your project. We have a section that's called Part 2. This is mostly designed for people that have completed projects. It contains things about outputs and outcomes and questions about sustainability and embedding in the future. We actively encourage you to complete as much of it as possible, and we also really want you to be putting in all the information you can while your project is still live. This is often where really important reflective nuggets get missed, because we can't remember everything in hindsight. If you get stuck along the way, we have a dedicated help page. It's got lots of really useful information and tips. If you'd like a really direct response, we have buttons at the bottom of every single web page called Get Help. Somebody will get in touch with you really quickly. We're really chuffed that you want to write up your project on Bob. We've designed it to make sharing easy and to make it embed good processes within the NHS without having to reinvent the wheel. So just thank you so much for your time, and if you've got anything that you need, you can always ping me a message along the way. Now's the time for you. Now's the time to grab a brew, get in your comfort zone and write up Bob in a way that works for you.
and that's most important. Thank you for your time. What I'd like to do now is to switch to show you a nearly completed impact story through to it being ready to submit. I've now come back to my dashboard. As you can see, I already have a story well in progress. I'll just click on this to continue. Now I'm onto the stories chapter guide. As you can see here, there are 3 sections you complete if your project's been completed, or just the first 2 sections if your project is still a live work in progress. Bob is designed to capture projects when they are live works in progress and when they've been completed. The reason for this is people capture the intricacies and project nuances in a much richer way in the moment than they do reflectively. It also offers you the chance to put your methods into practice. We now come to the last question set to be completed. As you can see, Bob has a word count. This is true for all questions on Bob. Our word count limit has been developed alongside behavioural psychologists and aims to focus you to help you give a concise answer. I'm just adding a few words to each bit now to demonstrate the sections. If you are anything like me, you'll probably want to dump your thoughts and musings somewhere before putting your concise answer onto the site. For now, I recommend a Word document that you can chop around and move around at your will. Remember, the purpose of your write-up is to develop a handy, rich in detail and easy to use how-to guide. So it's all about drawing out those quality and concise answers. What I would love to do now is to show you how you can add a document to a question. You can add a document to any of our questions. What I would do is to click the attachment icon at the bottom of the question set. From here, I would upload the document. We love being able to offer you this functionality and think others will really benefit from having documents to view as supportive pieces. Right now, attachments don't show up as being visible until your project becomes live. Please rest assured that it will come through to me for review, and I will add it at the right point to your story. Now I'm going to hit save and continue. This will take me back to the write-ups chapter page, where I will scroll to the bottom of the screen to write my summary. As you can see, all sections are now completed. This is shown by having ticks in each part, and I am now able to hit the submit button. Your story is now visible for me to review and to the Bob team. It will come directly to me and I will start the review process. So, you've had your whistle-top story of Bob, and I'm sure there's lots of things that you'd like to know a little bit more about. My recommendation to find out a little bit more is to just delve in and sign up and get using Bob. Like, look at the stories, look at how you're writing, look at stories for inspiration for how you can write. Get in touch with us to ask us questions and so forth. I just want to wrap this session up basically with looking at and considering how people actually write and how different people have different ways of writing and interacting with the experience of that. So Bob is a self-guided platform, and we've made Bob so that people can just work through it in their own way. Each question leads on sensibly from one another, and they're grouped to be sensibly too. We've got nudges that we can guide you along with on the way, and we've got sentence starters that make the process even easier to get started writing on those questions. However, we know that there are ways that people work, and we've done the user testing and worked with some psychologists to look at the intricacies of that. So some people will just want to go solo and they will just crack on with it. Some people will want full editorial support from a Bob team member along the way, so they'll want maybe a video call to talk through the questions and a bit of help to get started with the writing. Some people, me included, like to sound things out with somebody who wasn't part of a project, so we offer that as well. And some people just want to dip in and dip out when they've got time, so, you know, in between shifts, in between ward rounds and so forth. So Bob obviously offers the ability to do this. It's continuously saving in the background, and you can save and exit when you want to. So here at Bob, we are fully flexible. We're currently offering all levels of editorial support to match people's needs with getting used to the writing experience, because it is something new to people. And we're there to guide you along the way. So we'll make meetings available in timeframes that suit you. They can be long, they can be short, they can be on weekends, they can be on evenings. We're just really excited to have you as part of this journey with us. So we're just going to bring things back round now, and what I'd like to do is just bring us round to that slide that I discussed earlier with what motivates someone to share. So if you remember, we said it's part of their job role, they're altruistic, they like the recognition for their team having done a good job, and they want career progression. And what I'd like to do is suggest what Bob can offer to solve these problems. And the first thing I'd like to touch on is that Bob can support local embedding. As we all know too well, it can take years to do service redesign and run projects, and in that time people can move and chop jobs and all sorts of things along the way. So Bob is a place where people can embed their projects, whether they're in live state or whether they've completed them, in the now. So that means that whoever takes up that project in the future has a reference point, and there's also a reference point that people can change, because once a story is live on Bob, you can edit it, you can go onto your profile, you can add new details, and that's important because often projects have things that develop from them, so it's really important to keep your projects up to date. The second thing is Bob can help with the impact reporting for your project, so it can demonstrate to at board level and to your team the relevance and the need for why you did the project in the first place. Bob will also support your discussion with potential adopters, so you can use the piece that you do on Bob to use as a reference point for people that are asking you lots of questions about the great work that you've done with your project. So it has that initial conversation for you in a way that has everything in a succinct manner, which means that by the time somebody does get in touch with you, they want to know about the real nuances and they're really excited to hear from you. And the last thing is that we believe Bob is really useful for reflective learning and for CPD needs. So here at Bob, we know, as I said before, that our ambition is bold, and we're proud of that. We want to create a forever free shared learning ecosystem for NHS staff to use as a hub, where it's somewhere they can go to share insights and somewhere they can come to advice along the way. We're at the beginning of this journey, and we just can't wait to share the creation process with you. I'd like to say thank you so much for watching, and now we'll open the floor to questions. Bob's Quality Manager, I just thank you for watching our presentation that we've just ran through, the how-to video. I just want to cover that was covering basically the free side for the NHS staff. So we obviously have our sponsored section, and I just wanted to give a few bits of information about that. So what you can expect from that module is essentially the same. It will always be led by the NHS staff member that led on that project alongside the sponsor. There are a few additional bits of information though as well. So we also have sections where it tells you how the project was supported by the sponsor, and also bits on how you can contact the sponsor as well. We are now going to run into a questions and answer session, I do believe. We're able to finish in a little bit early, but it's no problem if we go over if anyone's got questions.
That's great. Hello, everyone. Hi, Nick. I'm going to be the question master, I guess, here. So I've got a few questions to start with. So the first one is about sign-off. Do you offer further support around getting sign-off? Is that question? Okay, so I'd suppose that's probably aimed at the the NHS section. So I'll run through it from that sort of perspective. We offer a bit of extra support on that. So what we've devised is we've got an email that will be sent out to your line manager or person who's acting as the senior person to sign off, and we can liaise with them for you. So that makes that process really easy. We've actually had a story go live that's used it. It works really well functionally, and it's very simple for people to use. If they do want any extra information from us, they can contact me directly anyway. It says all that on the email that they'd be sent as the person signing off. So any questions can be answered alongside that as well. Excellent. Okay. Another question here is if my project is part completed. That's helpful. Absolutely. So the next question is, my project is part completed. How can I add more information as it becomes available on my project? Okay, so our modules are aimed at being able to be taken into out of information that you'll gain from data sets will evolve as well as for a long time and be actively engaged on. So that's something that you can do if you've completed a project and you get updates. But as well as that, like we stated in the videos, we can also complete projects when they're in live states, which is very, very helpful often for writing down your intricacies, your nuances that you have popped down that maybe reflectively you wouldn't consider
So there's two ways of doing it, but both of them are very simple steps. So you can take your story out of live and then resubmit it. It will go through the approval process again, and then it will go live on the same link that it was already published on.
That's great. Thanks, Nick. I'm just noticing your internet seems to be a bit jittery, so I don't know if you want to turn your video off. Maybe we might improve the. Give that a try. Perfect. And I just realised I completely jumped in without saying who I am. I'm Mark Southern, one of the other co-founders at Bob Health. So apologies. So the next question is, do you have to type your responses into the writing engine that you showed us earlier, Nick?
That's a very good question. Can I just check with you, Mark, that you can hear me quite all right now?
I can perfectly.
Wonderful.
Thank you.
There is actually functionality on mobile phones where you can use the dictate function. There's quite a lot of YouTube videos on how this can be used, and we've got some helpful hacks. We did release a blog on it, so if it's something people would be interested in, we can certainly give you information. And you can basically put the platform live, questions up, and then you can dictate your answer into it. You could use this as just like a sounding hub to use it as a draft, or you could even use it just to complete your story with. So it's quite a useful functionality.
Excellent, thank you, Nick. So another question: if someone is quite busy, how can we or you help them create a story?
Another good question, and we spoke about it briefly on the video in our editorial support, so it's maybe worth me explaining that a little bit further. So this is something that we will do for our commercial sponsored stories, but we also offer it for our NHS staff. We know how busy everybody is normally, let alone right now. So depending on how people like to write and the process that they like to go through, we can offer full editorial support where we'll jump on a call with them and we'll create a draft that can then be sent back to them to add to Bob and write in their own manner and add all the details that they need to. Or we can be on the end of WhatsApp calls. We can basically be as amenable as possible. We can also do this. Is a good question that somebody asked me about a week or so ago was, can I give you a ring in an evening? And they felt a little bit guilty about it. It's not something anybody needs to feel guilty about. Completely understand the pressures that people are under. So more than happy to have calls arranged for early mornings and evenings.
Super. So another one that I've got here is, Bob is great, thank you, but I'm really busy right now. I can read stories, but is there anything else I can do to get the word out there about the stories that you have on the platform?
Yes, there is. There's really good functionality that we have on the website where you can just click onto what social media chains that you use, or just email into colleagues that you use. So basically, if you see a story that you really love, please do share it. We're all about spreading and scaling the good ideas and getting the messages across.
Brilliant, absolutely. And then a similar question actually is saying, I'd love to get involved. My time is limited. What can I do? So similar to the previous one, but slightly different. Okay,
so outside of doing the sharing and talking to your peers and just getting the word out about what we're up to out there, we are loving and welcome and need user testers. Bob is developed for NHS staff to use, and it'd be really daft of us to not include NHS staff in its development. As well as that, we've got our collaborative and sponsored side, and we do the same on that as well. So we want to develop things that are functional for our users and our demographic, and for them to be able to engage with each other in an intuitive way. So if people had time to do user testing, we could definitely get sessions going that suit their timetables, and it's so useful and helpful for us.
That's great. I've just got another one in now. I can see there are some sponsored stories on the site. How do they differ from the others? I know you covered sponsored stuff initially, but maybe you could just highlight the main differences again of how they do differ on the site. Yeah. Thank you.
Of course. Sponsored stories go into the exact same space that our NHS stories go into. However, they have a banner that clearly shows that they are sponsored stories. This is for transparency reasons, and it's also to celebrate the fact that we are working with responsible suppliers. That's a wonderful thing to be able to do. It's something I'm certainly proud of, and I think the NHS needs more of.
That's great. And actually, no more questions for anyone else, but I've got a question for you as well. Maybe you could talk us a little bit through what happens, what do you do when a story comes in? I know you briefly touched on it in the video, but I don't know if you might be able to elaborate on the kind of things that what you're looking for in a story, what makes a good story.
Okay, so as the final proof, so I will obviously liaise with people and do editorial support as ongoing when things are in draft. But when things come to me, they've already had the line manager proof and senior staff approval, and as we touched on in the video, that's important because I'm not a walking encyclopedia, and it would be really unprofessional of me to comment on things that people that are cardiovascular surgeons stating as policies and nuances and things that are really relevant for their projects. So we need that involvement. So what I'm there for is to give that final proof and go, is there any extra information that might be useful for people? And making sure that everything is correct with spelling, punctuation, grammar. So we do that thorough check. We also make sure that links are working, and you can now add documents to Bob. And I will also give them a thorough review to make sure there's no grammatical, spelling, punctuation errors, that everything is up to date, and that the links work and so forth. So outside of that, that's what we do from the Bob proof.
Brilliant, absolutely. And just going back again, sorry, this isn't a question. This is just going back on what you were saying earlier around the sponsored stories. Looking at those differences between, you mentioned it earlier, and I guess and the key thing that unites them really is the fact that it's always from the place of an NHS person sharing their experience. And within the sponsor stories, it's not just the individual, it's also other members of the team that could be involved. I don't know if you want to elaborate on that at all, Nick, in terms of co-authors and things like that.
That's something that is just, it's key. We don't often work as lone wolves when we're doing projects, and it's so important to mention co-authors where we can. So we have that functionality to be able to add co-authors to the Bob platform, and that's not just for kudos for them, but it's crucial really to celebrate the work of the team, because there's so much effort that goes into projects. Something that you think is going to take a month will take 2 years. There's often staff changes, so it's nice to be able to give that championing of the co-author.
Absolutely, and that's something we're offering in the sponsored modules at the moment. And in addition, I know that if there are external organisations, other collaboration partners that existed, they can also be cited as well, and they could be referenced within sponsored stories too. So it really does encapsulate all the various parties that were involved and make sure each of them has an equal voice and is allowed to give their view.
Yeah, it's key.
Absolutely. I'm just looking through. It looks like I've exhausted the questions there. I'm just going to see if there's any others coming through, but I think those were all the questions we had. Let's see, I think that's it.
That's it.
Yeah, I mean, sorry, go ahead, Nick.
I would like to just go back to our commercial stories and just state that obviously if we do have commercial stories on the site, then we do ask for them to be sponsored. It is what keeps this platform free and usable for our NHS staff, and it's what makes it a platform that can be a responsible place for us all to share and collaborate.
Absolutely, valid point completely. And actually this morning, Neil, my co-founder, and I had a presentation which describes in some detail around what Bob's about, but also we unpick a little bit more around the sponsored stories as well and give a bit more detail about our model and how we can remain free for the NHS. So I realise that's probably no good right now, you're on this stream, but I know the videos will be shared afterwards. So if you're interested, keep an eye out for that one, where we go through a little bit more detail about the origin story of Bob and also what we cover on there as well.
Amazing.
So
Could I make one last point, Mark? Would that be okay?
Of course, absolutely, yeah. We're still within time.
Amazing. So it's just going back to the write-ups run in regards to NHS staff and for projects in general, really, whether it's commercial or not. Anyone can learn from anything is I hope what people can gain from listening to the Bob tracks. Whether or not I'm a cardiosurgeon and I work in supply chains, or whether I work in the pharmaceutical industry, there is benefits and learnings to be had that should be shared and celebrated, because we can transfer that. You can't transfer the clinical skills, but you can transfer a lot of the background nuances, and it's crucial for us to develop.
Absolutely, that's a great point to end on. We've had no more questions, so I think we're going to be ending our giant festival after this session. Well, the Bob track anyway is going to be ending right now. So I just wanted to say thank you to everyone that's participated, that's contributed to any one of our sessions, that's asked questions, that's interacted with us. We've really enjoyed this as a Bob team. It's been a fantastic experience. We've loved talking about not only Bob, but also learning about what other people are doing in the system, and how we can all support each other. And also another shout out to the Giant team themselves, and specifically Harris, who's been working as a technical support on our track. Thank you ever so much for doing that. We really appreciate it. So yeah, thanks.
Yeah, thank you ever so much, guys.
We're going to leave it there. Bye, everyone.
Take care.
to the Thrive Wearables track at this year's Giant Health Show. Delighted to have you here for this session today. This is one of 5 sessions that we're running at this year's show, and we're really happy to be back yet again running these sessions at Giant. We've been here for the last couple of years, and of course it's slightly different this year, but we're all mucking in and working with this new system, and we're delighted to have brought together a fantastic panel for this session. So just a bit about Thrive. We are a design and development consultancy based in the UK, and we have a mission to create wearable products and product services that have significant health and wellness impact. We really judge ourselves on that impact rating, and we work very closely with a range of stakeholders across startup companies all the way through to corporate organizations to create those wearable products. You can find out about us and about the speakers at this session today at thrivewearables.com/giant2020. And I'm sure you'll be able to find out all sorts of other interesting stuff about the speakers today by looking on LinkedIn and connecting. There will be live sessions after this first part of the day, and we will be hosting those through the digital systems that are available at Giant. And I'm going to introduce now Steve Parr, the Medtech growth consultant that is running this session. Delighted to have you here, Steve, talking today about digital biomarkers and how do we get the quality real-world data sets we need for effective clinical trials. Bit of a mouthful, but I'm sure it's going to be very exciting. I'm really looking forward to hearing the panel today. So thank you very much, Steve, and welcome.
Well, good afternoon, evening, morning, everyone. It's my great pleasure to facilitate this session, and I'm delighted to be joined by 3 experts in the field. First of all, I'll do some personal introductions, let everybody know who's on the panel today, and then we'll get right on into the discussion. So I'm Steve Parr, as Jacob mentioned. I'm a growth consultant working with innovative healthcare and medtech companies, and that tends to revolve around sales, funding, go-to-market, business development, and market access. I also sit as commercial expert on SBRI Healthcare Innovation Panel for the Wessex AHSN and a number of other hats. Bill, would you like to introduce yourself?
Yeah, thanks, Steve. I'm a VP of product positioning at Signant Health. I've been working in e-clinical product development for around 20 years, but I'm also a scientist, and my area is clinical outcome assessments. So I've done recent scientific work, so leading cross-industry research groups through the Critical Path Institute and also through the DIA on the use of wearables and sensors around clinical trials and clinical trial endpoints. So yeah, great to be here. Thank you, Steve.
Okay.
Yeah, hello everyone. Thank you first to Steve and Thrive Wearables for putting together this panel. I'm excited to participate. My name is Kate Lydon. I am the Chief Science Officer at VivoSense, which for those of you who don't know, VivoSense is a data analytics and consulting company that specializes in real-world data from wearable sensors. We primarily work in the clinical trial space, but also venture into healthcare delivery at times as well. I joined VivoSense about 1.5 years ago now. And prior to that position, I spent most of my time in academia, but I've also worked for a couple of device manufacturers as well. So I've been kind of all over the board there. In academia, my research primarily focused on developing methods to process data from wearable sensors and also validating those methods. And then using those tools in high-risk patient populations to investigate how real-world behavior impacts risk for chronic disease. So super excited to be here today.
Thank you, Kate. And Miles.
Thanks very much, Steve, and thanks for the invitation to the panel for this very interesting and relevant topic at the moment. So hello, everyone. My name is Miles Furness. I am the Global Digital Health Partnerships Lead at Ipsen Pharmaceuticals. I'm a physician by training. I was qualified in the UK and worked in the NHS for about 4 years, finishing up in oncology before shifting into industry where I've held commercial, medical and digital roles. Passion very much is digital health and trying to bring in the right forms of technology, particularly into industry, to help improve patient outcomes and accelerate healthcare.
Thank you very much. So we talked about, Jacob reminded us what the title of the session is, and I'd really like to kick things off with the panel by asking you, what, from your experience of decentralized trials, what's really worked? For example, where clinical trial effectiveness has been greatly improved, or where real-world evidence and wearables have actually transformed the data quality and volume, or where new biomarkers have enabled different clinical endpoints, or anything else that struck you directly from your experience of clinical trials. Anybody?
Well, let me kick it off then, Steve. I think in terms of effectiveness for decentralized trials, I've probably got a couple of just small examples. And I think at Signant Health, our technology solutions that we provide for clinical trials have applicability in decentralized trials as well as traditional studies. And so things like direct-to-patient medication supply, eCOA can be used obviously at site or at home, remote assessments via video. So a couple of examples, one being the integration of home courier providers around a very large study which required stool sample collection alongside patient-reported outcomes. So a patient could use our app. They can complete their patient-reported outcomes diaries every day. And if they required a sample to be picked up to be analysed, they could then trigger that courier interaction through the same app that they were collecting their patient-reported outcomes data. And at the same time as the collection occurring, of course, the new sample kit for the next sample was also provided to the patient. So this was a 15,000 patient study. So it would have been impractical to do this sort of thing, to ask patients to go somewhere, or to, it would have been hugely burdensome, I think, to operate in a way, that we, aside from this particular example. I think another example, a pediatric study needing daily IV injections for a period of time. They started out doing those injections at clinic, but getting the patient into clinic every day was obviously, again, burdensome both for the child and for the caregiver. And so after 3 days, they would then receive the injection packs delivered direct to their homes. A home nurse would arrive, they'd check the medication, they would administer the injection, and they do the drug accountability piece as well. So again, huge reduction again in burden for the patient and the caregiver. And I think just a final example, as we hit the COVID pandemic, earlier this year, and obviously still dealing with that now, many of our clinical trials in which we were collecting clinician-reported outcomes, or perhaps psychiatric ratings, where you might have a 20-minute interview with a psychiatrist face-to-face, and they would be assessing you for perhaps symptoms of depression or anxiety or something else. Those assessments would have been missed otherwise, because patients couldn't come into clinic due to self-isolating. But what we could do, of course, was do those over video and have remote assessments with the physician and the patient being able to interact in the same way that they would have done face-to-face, but over the video. So maybe just a few examples of where I think, there's huge potential. And, it doesn't necessarily mean the whole study has to be remote, but these remote study components can be really valuable in individual studies.
You touched on a really interesting point there, Bill, around the patient-reported outcomes piece and how it's becoming increasingly important, particularly for industry, to try and get access to that sort of insight. And the way that we historically or traditionally approach that, it's very ad hoc, it's very inconsistent. And what we're struggling with at the moment is that within the data sets, if you look at a real-world evidence point of view, which is a huge step that's happened over the last couple of years, in particular, how we are able to access data in compliant ways, and suddenly we're recognizing the value of what we can do with this data. I can give a couple of examples just from a real-world evidence point of view, particularly in the US, where the FDA, I think, are real leaders in this space of adapting and advancing guidance around real-world evidence and what you can use it for, and understanding the value of that. And we've seen a couple of really key examples in, I think, last year. Pfizer had a product that are actually able to expand their license off the back of some real-world evidence trials, combining that with phase 1 clinical data, which was absolutely pivotal. It's a huge step forward. The value of that for industry is vital. One of the things I do commonly see, however, is those PROs are often missed off because the traditional data, we just haven't really captured it in that digitalized way. So there's a huge gap that needs filling, and people are starting to almost input this now from normal clinic visits from patients. So we start capturing that. So we might be able to start using the data that we have there for synthetic trial control arms, for example, from the trial side. But until that happens, at the moment, we're almost relying on prospective clinical trials with wearables and applications to capture these PROs that are hopefully validated to some form of quality of life outputs that we can obviously then bring that in. But it's massively shifting. So I'm interested to see what else, from a PRO perspective, you've both been involved in as well.
So I'm going to shift away from PRO for a minute and just say that one of the areas that VivoSense has seen significant success has been in rare disease, specifically using what's called respiratory inductance plethysmography to measure respiratory outcomes in different disease states, including Rett syndrome and infant spinal muscular atrophy. And these are examples of endpoints that would not be feasible to have these people come into a site to measure. It's measured, during wake continuously, and so to have them in a clinic continuously for multiple days at a time. I mean, you could do an inpatient study, but that's just 9 times out of 10 not feasible. And specifically in rare disease, where recruiting patients is difficult, and you often have to recruit from all over the world to be able to, expand your reach for the patients you can recruit by collecting these data at home, I think has really been significant. And these endpoints have been approved as both primary and secondary endpoints by different regulatory agencies. And I think that, this is traditionally a risk-averse field, but because it's rare disease, I think that they're willing to, bend a little bit. And of course, you need to provide, evidence of validation of this method in these groups, in this specific clinical populations. But I think that they're open to exploring these more innovative endpoints in rare disease. So.
Glad you brought up rare disease. So very much the focus from our organisation. We're a rare disease company, so I completely echo and agree everything you just said there. I think there's a real opportunity for us to get more involved and providing more services around these rare disease patients by capturing these new digital biomarkers we can start creating. I'm really interested to understand in the things that you've done. Have you got to a stage where within these trials you're starting to capture the additional data points you bring together, even within these populations, to start creating more prediction-like algorithms off the back of that, or at least within that conversation, because that's where these opportunities can lead to, right? Particularly within these subset populations within rare disease patients, it creates this huge opportunity to start building additional services around that. Have you come across that at any point to date?
We have not, and of course, I think all wearable sensors create that opportunity for these predictive algorithms to better predict onset and progression of disease. But in the specific rare disease state, we've not seen that. And I'd just also like to point out that I think that one of the extreme benefits for rare disease is that most of the time the endpoints are caregiver report. Right. And so being able to collect something objectively really can supplement those reports. I'm not suggesting replace them completely, but really being able to augment them and supplement them. I think that that's extremely valuable.
Some of you, I think, have touched on the issue of the pandemic as well, which has obviously created extra challenges. Bit of a simplistic question, but in terms of gauging the impact there, I mean, in some areas we've had previously up to 70%, 75% of trials failing in a pre-pandemic period. What has that done for normal, if you like, clinical trials? And perhaps with that extra question to Kate and Miles about in the rare disease area as well. What's the challenge that the pandemic has brought onto clinical trials in these straitened circumstances?
Do you want? So I'll tackle that first. I mean, I think the pandemic across the board has brought the challenge of getting patients into a clinic. Obviously, I mean that becomes a risky behavior for all studies, and so being able to measure these endpoints without bringing a patient in contact with potentially infectious other human beings is obviously great. And I think that folks are now much more open to considering these remote monitoring technologies. I won't say that I think that it has completely skyrocketed the use of these remote monitoring technologies in clinical trials, because even though they're interested, that infrastructure isn't there. You know, if they didn't have that set up from the beginning. So they're gaining interest in it and they're exploring it more. But I don't think we've really seen a huge spike in the use of these tools from the pandemic. And I'd be interested to hear what Miles and Bill have to say about that, if they've experienced the same thing as well.
Yeah, well, I think we have, but I would just to sort of answer Steve's question, you know, in terms of what has this brought in terms of the type of data that we're collecting. I think it's added variability to the data that we're collecting potentially, because, you know, we've had to adapt the way in which we're going to collect it. You know, we start out with a clinical trial with a very standardized approach. You know, and we're going to collect the quality of life data, for example, at the site visit using a tablet computer, and they're going to be exactly the same for everybody. So you eliminate a number of different sources of variability. And then we have to adapt because of the pandemic, and people can't come into site anymore. So we're going to now say, okay, we don't want to stop the study. We're going to continue to collect that data, but perhaps one approach might be we're going to do telephone interviews to collect that data with the patient, or another approach might be we use a web backup solution and the patients can access it themselves from home via the web in a less supervised manner. And while we believe that the data will be consistent and reliable, even when measured in that different approach, you know, there is that question as to whether we've introduced some additional variability and what the impact of that might have on the sensitivity of the study to show the treatment effects.
Miles, do you have any comment?
Just to echo what I think Kate just summarised there, it's been a really challenging time for industry over the last 9 months, and I think we lose sight of the people that have been affected by this. It's been pretty challenging, and it's not just for the trials, for the treatment as well. DataCount, one of our UK data hubs, released a study just looking at the reduction of people being diagnosed with cancers and coming in for therapy. And some of those things you can't avoid, and that relates to some of these trials, right? They have to come into centres. So how do we pivot? And as Kate's mentioned, it doesn't happen overnight. It's this huge infrastructure that needs to be adapted. And if trials are already started, then it's going back and almost trying to amend protocols and things, which is, you know, very, very difficult to do. It takes time. So I agree. I haven't seen a huge shift, but I don't think it's because of the unwillingness or understanding now the relevance, how the world is changing and the importance and impact that this can have going forward. I just think that it's going to take a bit more time for people to really shift and think about this in a very different way, like we've been forced to over the last 12 months. So I very much expect over the next couple of years to see greater uptake from a wearable and a remote monitoring perspective.
Yeah, and I'll just give an example somewhat of what Bill was mentioning, that we've experienced a lot of folks that have ongoing clinical trials that use in-clinic 6-minute walk tests as an endpoint. So many trials use that. And a lot of sponsors have reached out to us of how can we measure that remotely? And of course, we have wearable accelerometers, different types of kinematic sensors that we can use to measure things about movement and gait and behavior. But we all know that the in-clinic 6-minute walk test is standardized, right? Like, this is a standard performance test, and being able to conduct that in the real world, it's not possible. Yes, there are other things that you can measure that are related to that. But to exactly mimic the 6-minute walk test out of clinic that's essentially impossible. And so we've had a lot of folks interested in doing that, and they come to us and what can we do? And we do have, VivoSense has an endpoint that we call best 6-minute effort, which we relate to the in-clinic test. It's essentially a real world parallel of the 6-minute walk test, but that of course is not the same thing. And so they're interested in that, but then for them to think about how do I shift my trial operationally to be able to collect this, that's been a real barrier for people.
Poses that interesting question of, are these endpoints fit for purpose anymore? We're moving towards this piece, right? And then it drives into, okay, well, if we need to define something that is more fit for purpose, how do we go about that to ensure the community, the scientific community, can trust it, will accept it within clinical literature, and then be able to use that as a new standard of care? And this is, I think we all agree that we see this again and again at the moment, that it's still very much a learning that we're experiencing, but hopefully, given everything that's been going on recently, it's going to drive people to actually start exploring this and taking it more seriously, to really start validating these additional endpoints, which arguably could be more accurate and more clinically valid than what we've used historically.
Yeah. And certainly more real world. No, it's interesting. I was talking last week to a VP of project management for a global CRO, and he was echoing your comments, really, that the pandemic has shone a light, really, on the greater need for decentralized trials, real world evidence, etc. But this, as you said, Kate, the usage has not skyrocketed. There's something getting in the way. And that, I think, really is at the core of what this session is about. So I'd just like to move the conversation on just a tad, but continue with the same theme. I'd like to explore what is slowing and preventing the wider use of remote monitoring, and the uptake, as you said, Miles, about more or new biomarkers. How better real-world evidence and wearables can support this better data moving forward. Can we really burrow down into that? What's getting in the way? Because the pandemic is such a driver. I mean, obviously clinically driver, but to be blunt, financially as well. There's a lot of money and inefficiency brought into the system. Let's just burrow down into what's slowing down the uptake.
I think just adding to my previous point around, we're in this scenario where we're able to collect a lot of data, a lot of objective data, sometimes passively, continuously. This very exciting phase where we can do all of this, and the accessibility has just shot through the roof. The problem with it is trying to correlate it to a relevant phenotype, something that we can clinically validate against what historically has been defined as standard of care. And that's something I've mentioned previously, that unfortunately that standard of care may not be clinically appropriate anymore. Because is it really a gold standard? Like, the traditional biomarkers we use has been established using averages or heterogeneous populations, and trying to compare that with more digital biomarkers, it might not necessarily be a fair assessment. That's really difficult, because if everyone knows something, and that's what I clinically believe, that is the marker, that's what we've used for decades to assess this patient population or this clinical assessment or whatever, to then try and completely say, well, actually it's not fit for purpose, but if we validated it against that, we're getting lots of false negatives because it's not fit. What do we do? How do we start building that confidence and that trust that physicians and researchers are going to be able to use that now as a future gold standard going forward? And that for me requires a lot of out-of-the-box thinking, a lot of adaptability in this space. It's very, very, very difficult to do that.
And it also raises the issue, I don't know if you've got any thoughts on this, Bill, about wearable or actual device selection as well.
Yeah, so I think that is one of the barriers to perhaps the adoption, the sort of at scale adoption of wearables and sensors for clinical measures is exactly that. You know, what sort of evidence do we need to provide to a regulatory body to support the approach that we've taken to defend the particular device we've selected? And you know, there has been a lot of work done on this. There's a number of different consortia. You know, there's the Critical Path Institute, there's the CTTI group, there's DIME, there's a DIA, and quite a lot of these groups have come up with very similar approaches to how we might address that evidence piece. But I think that's the point. Is a sponsor organisation is going to be conservative and are going to have questions about whether their data would be accepted at the end of the day. And so we know there are a number of things that we need to demonstrate, and it's whether we can actually pull that package of data together quickly enough to be able to do it. So, is the sensor itself providing raw measurements or raw data that's kind of accurate or reliable? Can we analytically validate the outcome measures that it produces? So if it's counting steps, can we demonstrate that in the particular patient population we're interested in, it's counting steps accurately or to enough accuracy that would be sufficient for a clinical endpoint? And then, the other point, I think, to some of the things Miles was talking about, some of the endpoint properties, we need to start to understand. So, one would be, do we understand what a meaningful change is in that endpoint? And again, going back to the kind of the rather substandard way we do this, we usually do that by comparing it to a gold standard, which we think we understand what a meaningful change is. And again, if we're not measuring exactly the same thing, or if the gold standard isn't actually very good, it becomes quite a difficult exercise to generate those endpoint properties that we need to support the use of that endpoint in a clinical trial. So, for me, that's one of the big barriers, I think. And but I do think we've moved a long way in the last 2 or 3 years in terms of understanding what's needed and how to do it. And I think that will start to drive adoption.
Kate, any thoughts?
Yeah, so that last point that Bill made there about we've come a long way, I would say that even in this past year, it feels like we've come a long way. Just the discussions that you hear folks having on panels like this, it feels like we've come a long way in talking about validation and what pieces of validation do we need, because I mean, for me, that and for VivoSense, that's at the foundation of everything we do. As Bill mentioned, counting steps, and the reality of it is that most of these step counting algorithms were developed in healthy populations. We need, at the end of the day, if we want to get our drug or whatever it is approved by different regulatory agencies, we need to, and we're using steps as an endpoint, we need to show evidence that we believe that we're counting steps accurately and that our tool is sensitive to change in that measurement as well. And we know that, patients with Parkinson's disease their gait is different than a patient with multiple sclerosis or ataxia or whatever it might be. So I think that it feels like we've made progress in that validation space and people at least having discussions around what's important, I think, is really important. But and to go back up to the point about clinical validity and being able to establish what is the minimal clinically important difference for this group, I think the reality of it, that's a barrier, but the reality of it is that this is still early days for these tools. And so that evidence and that evidence base is not there in most instances. And I know that this is a dirty word, but I like to promote pilot studies, natural history studies. Like, let's gather these data on these patient populations so that we can begin to gather that evidence needed to establish a minimal clinically important difference. Because at the end of the day, we're going to need evidence to support that when we're, you know, submitting our protocol to whoever it might be. So yeah, I think we're making progress. But I think also I would encourage the field to not be afraid of, I think, small steps in that spectrum of progress.
Yeah, and Kate, I think I can kind of link to that idea around interpretation, because I guess minimal clinically important difference is all about interpreting the findings. And you know, the other challenge I think we have is that we don't necessarily understand whether an endpoint is device specific. So for example, if I measure total number of steps per day using a Fitbit, I know I'm going to get a slightly different answer than if I use a Garmin or if I use an Apple Watch or something else. And so, you know, it's difficult for us to interpret these changes within an individual clinical trial. But when it comes to a regulator or a payer, looking at data from different development programs who are perhaps measuring what they think is the same endpoint but using a different device, it's very hard to find a way to accurately compare the results across, you know, perhaps different drug programs, for example. And so, yeah, I kind of feel that's maybe less of a barrier for us looking at individual drug programs, but certainly a barrier for regulators and payers in terms of understanding how to interpret the data we provide.
I absolutely agree in that if this is validated in a Garmin, it doesn't necessarily mean that it's validated in a Fitbit or an Actigraph or whatever it might be. So I think that is absolutely a consideration that needs to be taken into account.
And to what extent? Sorry, Miles, over to you.
Very, very quick point, just to kind of take on from what you both highlighted on a slightly different tangent, is that taking these sort of devices and wearables you're describing and identifying these other endpoints, I think one thing that everyone's overlooks that we're aware of but don't really take it hugely into consideration is that this is personalizing in a way that we've never been able to do before, and it's very different to how we do healthcare. You know, a lot of healthcare is really umbrella-like approach in a lot of what we do, and all of a sudden we're able to start getting insights in full population, but then look at an individual and personalizing it to a point of view that it's going to completely change the conversation. And physicians are going to suddenly be guided by what these wearables and what these digital biomarkers are telling them, not from a population, but for their individual patients that are opposite them, but then have to suddenly trust and change a whole different way of how they approach their diagnosis, or what therapies they're going to pick, or how that individual is progressing over time or improving over time, and whatever marker that's relevant to them. It opens up like this whole other lens of this is a different way of doing healthcare. And it's great, it's brilliant, it's exactly what we want to be moving towards. But that's a huge culture shift, right? That's a huge barrier around how do we get people to start thinking that way, that we can believe and trust what we're validating and believe and trust what endpoints that we're coming up with, and then trying to say, well, yeah, but this patient is going to be slightly different to the other patient you've got next in your clinic. They might be really different, but they're telling you very different things, even though it might be the same endpoint. It's a very different, summarize that extremely well, but it's a very different approach. I think we overlook it sometimes because we just get so into it, but it's an extremely important point of how we're going to need to approach this in the future.
Yeah, the opportunity for personalized data is absolutely phenomenal. And also getting back to the practicalities of clinical trials, just in terms of patient engagement and patient retention as well. You know, if you can do remote monitoring, these are all the goals that we're all aiming for, and I guess it's a sort of well-trod point. But going back to the previous point, if that's where we're heading, how do you broker this device variability? There is such a a large reliance at the moment on the off-the-shelf. And often I get a little bit disappointed and depressed, really. People will use the standard products in a certain area because it has a track record. And part of the track record is knowing what the deficiencies are. And I get a little bit frustrated at this side of the chasm while we wait and we use the pre-used wearables and the regulatorily authorized ones. But in actual fact, there's a whole world out there which is, new endpoint focused, patient focused. How do we broker that? I mean, you talked before, Kate, about making small steps, which I do appreciate. But at some point, if you think of the millions involved, the expense of a clinical trial, surely it's worth doing a little bit more R&D and branching out in a new direction. I hope that's not too provocative, but I'd be interested in your thoughts.
Well, my immediate thought is that I would challenge everyone in the field to eliminate this phrase "off the shelf" from your vocabulary, because I just don't think I won't say 100% of the time, but 99.9% of the time, there's not an off-the-shelf solution for you. Like as Miles was saying, this is very patient-focused. This is personalized. Everything needs to be relevant for the patient population. And these sensor technologies, when you're collecting data at such high resolution, to get down to the nitty-gritty, the filter matters, right? Like the way that you're filtering the signal, the way that you're cleaning it, the way that you process it. There's, even within one device, there's multiple ways to derive an endpoint. So it's not even just between devices, but sometimes within a device. And I don't say that to scare people away from using these tools because the variability is too great and we don't know what we're getting. I say that to encourage folks to just really, think about and be thoughtful about how they're using them, and to engage others who have used these tools in a way that is similar to how they intend to use them, because there are people out there that have experience using these tools, and this is a new space for everyone. So I think, the more we can create the communication across organizations, then the more that I think people will start to really adopt that approach.
Yeah, no, I agree. I won't tell you how many times I've heard the word "off the shelf" in the last year. It will be quite depressing. Sorry, Bill, did you want to come in?
Well, I think just to add to what Kate said, and I guess coming from the patient-reported outcome side of the industry, we've faced this problem already because we've moved things from paper instruments, which have been well validated. They have a certain format, a certain look and feel. We've put them onto electronic devices, and they might look and feel very different. We might change the way that a scale operates, for example. And we've done a lot of work to validate the fact that the measurement properties of that validated instrument haven't changed when we've moved it into a different format. And the same is true here. So this is what we're talking about. Can we demonstrate that the measurement properties of different devices are close enough so that they don't have a significant material impact on the endpoint measurement? And so it's almost down to endpoint developers to start to identify what are the tolerances in the inputs that are acceptable, that won't have a huge difference, make a huge impact on the endpoint measure itself, but you could accept. So I've got a step counter and I've got another one which has got a bias of 1%. Well, does that make a difference, a material impact on my clinical endpoint? Because if it doesn't, then I'm okay to switch that device and use a different one and measure that same endpoint and feel that actually my data will be comparable between those two different devices. But we don't really understand that yet, and it's probably very endpoint specific in terms of what those tolerances need to be.
Mm-hmm. Well, I can see we're getting towards the end of our session, so thank you very much. That was a fascinating discussion. If you'll forgive the cliche, I'd just like to ask you each in turn, what's the one thing, what's at the top of your list that is going to have the greatest impact if implemented, greatest impact in terms of improving clinical trial effectiveness and getting real world evidence into the cycle? Bill, alphabetically.
There you go. I think using these tools to get richer insights into our therapies and into our treatments. So, you know, examples might be, you know, collecting data more frequently from home. So measuring tremor in a Parkinson's patient, I'm able to do it every day, and I'm able to look at, you know, the number of days when they have tremor and the number of the days they don't. It's a better picture than the monthly or the 2 weekly visit to the clinician's office. Or maybe I instrument a clinic performance test. So I've got a timed up and go test, which normally my clinician would use a stopwatch to figure out how long it takes someone to get up, walk 3 meters, turn around and go back and sit back down again. And that's a good endpoint. But if I put sensors on that person, I can then measure all sorts of aspects of how they conduct that movement. And in particular, the way they turn, that 180-degree turn, the number of steps they take, how balanced they are. That can tell me a lot more about perhaps their risk of falling when they go back home than perhaps just the simple measure of how long it took them to get up and sit back down again. So I kind of feel richer insights is my key takeaway.
Kate?
Yeah, I feel like this is a tough question, and I don't want to repeat exactly what Bill just said. But being able to collect information about a person in their real world, right? Like, we can do these tests in a clinic and they can perform well on a 6-minute walk test, but does that translate to how they're actually living in their real world? I think being able to look at endpoints or biomarkers through that lens of what the patient is actually doing and how they're doing it in their life, I think that really is exciting, and I hope that continues to really motivate people to use these tools moving forward.
Taking all the good ones, guys. It is a really difficult question. From my perspective, from where I am currently, I think that everything that everyone said here today is completely true, and I think it all needs to be taken into consideration. But there needs to be an element of open-mindedness to take a bit more risk and explore in this area, and thinking how, when we doing these sort of trials, identifying these new endpoints, we're really thinking how can we add more value, and how can we bring that back into the healthcare system. And that's something that we're seeing already. There's lots of little examples of that, but I'd like to just continue seeing it, and people really going out there and exploring, thinking, particularly from an industry point of view, around new business models. How can we start building this into a business model? How can we start closing the loop? How can we start increasing value of what we're offering by capturing these new endpoints and these new data, objective data points within each individual in the real world? That is, we can personalize and hopefully start adding some prediction prevention around that service to add more value eventually.
Fantastic. Well, thank you very much for a very interesting session. Thank you for your time. I've certainly learned a lot. I'd just like to say for any of the audience, if you'd like to get in touch with any of our panelists, or if you've got further questions, please do so via the Giant Health website, or as Jacob mentioned earlier, the Giant Health page on the Thrive website, thrivewearables.com. And I think we've now got time for 20 minutes of live Q&A. Thank you very much, everyone.
Thanks very much.
We have had a fantastic show so far, and it's been great to listen to this track today and to hear the questions for the panel from this last session. I'm going to welcome back now live Steve Parr to continue the discussion. Please do take a moment to think about any questions you have for the panel, and for Steve and Miles especially. We're having some challenges connecting the other participants at the moment, and we will get through those questions. We'd love to pitch those out live as we go. But until then, I'm going to welcome back Miles and Steve, who will start the ball rolling, I suspect. Steve.
Yeah. Can you hear me okay?
Indeed.
Great, thank you very much. Yes, so thank you. Welcome back to everybody after that excellent panel session. We've got 20 minutes of live Q&A at the moment. So as Jacob mentioned, unfortunately, we've got a couple of our panel members struggling to log back into the Q&A. But Miles, Jacob and myself will do our best. So Miles, can I kick off with the first question, if that's okay with you?
Of course, absolutely.
How much of a barrier is the lack of regulatory approval for some sensors and wearables? To what extent can the right hybrid trial protocol design and or the right data collection and or post-analysis make up for the lack of full regulatory approval?
Yeah, super interesting. So yes, it is a bit of a barrier. I think there's an understanding there that this is a rapidly changing space, particularly around the regulatory piece. We're getting increasing guidance that's making it easier to get that, to build that trust and to build that credibility with the sort of protocols that we are designing. What I'm seeing is, particularly for myself, in some of the things that we've done, these protocols are different. And you get a lot of challenges internally, and that's perfectly normal. And I think that's a good thing from all different functions, because it is an unusual way to start collecting new insights and new data in particular. How we then sort of turn that into clinically validated to standard of care. How do we bring that in so people can say, okay, right, well, this is what we've done historically. This is what we've got now. How can we try and bring this together so that it is going to be credible within the scientific community, that it is going to achieve the endpoints that we want to achieve, that we are actually exploiting the sort of insights that we can generate from this now, and start thinking a little bit more outside the box rather than the traditional tunnel vision, I think, that we sometimes trapped ourselves into, because it's just how we've always done or taken this approach. But it is changing, and I think there's some brilliant people in the space and some fantastic people in the industry who are really, really open-minded, particularly around the stats side, of how we can try and pull this together. And so, yes, although it is a barrier, I think it is becoming easier as time has progressed.
Okay, thank you. Kate, welcome to the Q&A. Glad you could join us from Denver.
Thank you.
I believe you've had some technical problems, so apologies for that. But in at the deep end, then I apologise. I guess you didn't catch the question, but hopefully. First question was, how much of a barrier is the lack of regulatory approval for some sensors and wearables? To what extent can the right hybrid trial protocol design and or the right data collection and or the right post-analysis make up for the lack of full regulatory approval?
So I guess I need a little clarification. When you say regulatory approval, you mean regulatory approval of the device, the protocol?
Exactly, the sensors and the wearables themselves. It sort of touches on the conversation we had earlier, didn't we, about off the shelf. And I think you memorably said 99.9% of the time don't go for off the shelf because they're not suitable. And so this question, I think, quite eloquently captures that quandary, doesn't it? You've got something that's off the shelf and approved. In your opinion, 99.9% of the time, they're not really suitable to the trial. So I think that's what we're talking about, approval of the sensors and the wearables.
Yeah, so I think that, the FDA has 510K clearance for devices or algorithms or whatever it might be. And we've heard the FDA over and over again say that, a 510K clearance is granted within a very specific context, right? Like in a very specific patient population, in a very specific data collection procedure, processing, those sorts of things. And so when somebody takes a tool and tries to use it in their specific study, in their specific patient population, that 510K clearance no longer pertains to what they're doing. And so we've had experience where a small pilot study collecting that analytical validation prior to starting a full, phase 2 or 3 trial has really been beneficial, and the regulatory agencies are open to that, to accepting those small studies that show really strong validation evidence in your specific context of use, your specific patient population, your specific setting in which you'll be collecting those data. So I think that the fact that these devices don't have regulatory approval isn't necessarily a barrier. We just need to think about it differently in how we get our protocols to the FDA or whatever regulatory agency.
Yeah, no, I think it was an excellent question. If it's not bending the rules too much, I think the questioner has suggested that where there is the lack of approval, what can the protocol design, data collection, and post-analysis make up? Is there anything you would add to that list then, if you're in that position? That list of three. Sort of,
protocol design. What was the other one?
Protocol design, data collection, and then the right protocol collection and post-analysis.
Yeah, I think there are some subcategories within those. Like those are the broad categories, but certainly thinking about like specifications and settings on a device, so that sometimes there are multiple ways you can configure a device for data collection. So thinking about the most appropriate way to do that, thinking about cleaning your data as it comes in. These are high resolution data sets oftentimes. And so being able to manage artifact or noise in the signal that is bad data that you don't want to count in your analyses. So I think, it's a subcategory of processing, I guess, but really thinking about how you clean these data is very important.
Mm-hmm. Anything to add to that, Miles, at all?
No, I wouldn't actually. That was quite a nice summary.
That's what I thought as well. I think we have our... Before we move on, I was just wondering if Bill was going to emerge. Hello, Bill.
Hey there. Hi, Steve.
Hi.
Hi, Steve.
I'm not sure we can see you. Can we see you? Can we see and hear Bill? Okay, technical people. Or do you want me to move on to the next question? Bill, welcome. Can we hear you, Bill?
I think so.
We can indeed. Great. Okay. So, at the risk of boring the audience, welcome, Bill. Yeah, no, I know you're having technical problems there, and it's not your fault at all. But Miles and Kate have just been looking at the first question, so I'll offer it to you. And perhaps, seeing as well, I'm reading this out for the third time, if you can be fairly succinct. But the first question was, how much of a barrier is the lack of regulatory approval for some sensors and wearables? To what extent can the right hybrid trial protocol design and/or the right data collection and/or good post-analysis make up for the lack of regulatory approval?
Yeah, I don't think devices need regulatory approval for use in clinical trials. So I would say they need to meet certain properties around accuracy and reliability, and I guess usability in the population that you're looking at. So it's really down to the protocol developers, the clinical developers, to be able to evidence that a device is suitable for use, i.e. that it meets these accuracy criteria, and whether it has a market approval or not, I think it doesn't matter. I don't know if that's what others said. Having not heard other people's answers.
Yeah, no, those were unique pearls of wisdom, Bill.
Yeah, oh, good.
Okay. Second question, what is the greatest benefit you see in this potential for decentralized trials and real world experience? Is it in the improved clinical data? Is it in saving money? Or is it in improved operational performance, such as patient engagement and retention, or shorter timescales? Do you want me to read that question again, or?
Well, I think it's in increased convenience to participate. So, I think that's the biggest driver. Will it be better quality data? I don't think so. There may actually be more variability in the data because we're not able to always supervise how the data are collected, but we can collect data more frequently. But I think it's really about, for me, convenience. And we've seen this in the COVID, pandemic. Patients either can't or don't feel comfortable attending site, and to be able to conduct assessments remotely in the home
is a way through that. And patient recruitment is a huge issue for all clinical trials, and so being able to participate in a trial in a way that's convenient to you, i.e. not having to go to hospital once every 2 weeks or give up working time to do that, is a real bonus, I think. So convenience, I think, is the one for me.
Anyone else wish to add to that?
Go ahead, Miles.
You, Kate. Now after you, please.
Okay. I'm going to disagree with Bill. For
Thank
me,
you, Kate. No offense, Bill.
for me, it's I don't want to call it improved clinical data. I want to call it different data, being able to capture things that we weren't previously able to capture. I think that is really what motivates me to work in this space. The idea that these tools can lead to better outcomes for patients, I think that's what I'm hanging my hat on, and that's what how I see it.
I'm going to have a massive cop out and say it's a combination of everything, right? Because I think it is. I think that there's clear benefit across the board, right? I don't think we're going to see huge benefit and improvement in all these areas. That's going to be the thing. I think it's going to be more multifactorial in the sense that, yes, it's going to save time. Yes, it's going to be more convenient to an extent. Yes, we're going to capture new data. There's that opportunity. Maybe we increase the volume of that data because we get more people recruited potentially, which again is a bit of a trade-off on some of the quality potentially. But it is thinking about it in a very different way, and I think it's very difficult to compare, and that's the danger. I think in a way we've got to just be cautious of how we're sort of comparing it to previous approaches, and think about, okay, this is a very different way of trying to capture all of this. But certainly from an industry perspective, if we can save time, therefore we can save money, it allows us to do more, and it allows us to get outcomes out faster. So it really helps support that product or that asset. So there's a huge advantage there from an industry perspective, which is why we're seeing a huge uptake.
Thank you very much. I see there's another question. I'd be fascinated in the answer. It may be, sorry to put you on the spot, Kate, it may be more you than the others, or I may be wrong. Are you familiar with the V3 approach, Kate?
Yes.
Oh, I'm glad you said that. That was the right answer. So, the question is quite succinct, and I think those in the know see this as a bit of a way forward in answering this. So the question is, unlike the other questions, is the V3 approach the answer? Now, let's assume that no one else actually knows what the implications of that are. So if you could explain and then go on to answer, and I think that will also allow the other panelists time to assemble their answers as well. So apologies for putting you on the spot, but over to you, Kate.
Okay, sure. So you're asking me to explain what V3 is first?
Well, the question is the V3 approach the answer to these issues? But yes, I would ask you to explain to those not in the know what the V3 approach is, please.
Sure. I guess my response to that question immediately, though, is what's the question? Is it the answer to what question?
Oh, sorry. Sorry, about getting over the chasm, I think is what they mean, to get these better decentralized trials. And, the panel earlier, we talked about what the barriers were.
Okay.
And this is saying is the V3 approach, which is putting, apart from your esteemed opinions, putting an actual process behind this to get us to the other side of the chasm, and able to use much wider range of sensors and endpoints and that sort of thing.
Sure. So the V3 approach, just really quickly, is a 3-step process to validation for these tools. So the first part of the V3 is called verification, and that's basically validating the device at the sensor level. So is what we're getting from the sensor accurate? And then the second step of V3 is analytical validation. So when we put this sensor on a person and we apply some sort of data processing and algorithms to that signal from that sensor, are we estimating or are we measuring steps, for example, accurately? Are we measuring what we think we're measuring from this device? And then the third step is clinical validation, which is essentially, does this endpoint have clinical meaning in this patient population? And I think that the V3 framework, I love the V3 paper. I'm the biggest proponent of it because we always talk about validation. I always talk about validation. And the V3 paper, I think, has really put out this framework that allows folks to be on the same page and to really discuss validation using the same types of language. which I think is really helpful. And so I don't know that the V3 framework is the answer, but I think it is a fantastic framework to, phrase this discussion amongst people in the field.
Yeah, I agree, Kate. I think it's one of a few pieces of work that have tried to help to provide recommendations around the kind of evidence you need to support the use of a sensor and a clinical endpoint based on sensor data. I think the limitation that I see is that the verification step, the kind of sensor level validation, is hard to get hold of. Particularly if you're using proprietary sensors. So relying on that piece, I wouldn't want that to be seen as a barrier if people can't get hold of that verification data. My personal feeling is that with good analytical validation and clinical validation, you've probably got enough actually to be comfortable with an endpoint. But if you've got the verification data, I mean, that's just solid. That'd be really good.
Mm-hmm. Agreed. I think that the verification step is more for people that are thinking about doing analytical validation themselves. And if you're going to partake in this analytical validation, it makes sense for you to go through the verification process first and then move on to analytical validation. But I definitely agree. If you're able to prove through analytical validation that what you're getting accurately compares to a reference standard, then
thanks very much. Miles, do you have any thoughts on that?
So I'll be honest with you, I'm not overly familiar with the process, but I assume you're referring to the Nature paper that was published this year, the 3D process. Yeah. So I'm not super familiar with it, but the one question I recall that came out of it was around the first verification step of who's going to be responsible for it all. From a regulatory point of view as well, there's this huge gap, and that would be my initial concern without, again, sort of being overly familiar with it. I wouldn't add too much more because I think Bill and Kay have done a wonderful job.
Agreed. Thank you, Miles. Next question. Is it better to start a decentralized trial? Sorry, Kate. Is it better to start a decentralized trial sooner with an off-the-shelf sensor and clean the potentially noisy data afterwards, or to wait a little and develop more custom sensors that better match the trial endpoints and clinical requirements and the trial patient ergonomics? So I suspect there's yes, that sounds like a sort of delay now or delay later.
Yeah, I mean, I think you need to think about what's your end goal, keeping the end in mind. We always say that, right? Is the tool, are you confident that the tool and the methods that you're using you have sufficient evidence to support, your endpoint at the end of the day when you're going to try to move on to another later stage trial or a regulatory agency or whoever it might be? I really think that you need to keep that in mind. I think that I don't know if it's an alternative approach or just a little bit differently, is if you have a tool that you think is valuable, but you may not have all the validation evidence, putting it in as an exploratory endpoint to start to gather some data might not be a bad idea. Again, doing a small pilot study isn't a bad idea. And I don't think that we need custom sensors. I think that we need custom methods and approaches. So just to clarify on that a little bit.
Interesting.
I think, Kate, some of that might be also down. Just thinking about activity as an example, and the granularity of data that you can get from a sensor might impact your ability to kind of post hoc look at different endpoints or different measures from the data. So, for example, if I'm just using a step counter that just gives me total steps a day, well, that's kind of what I'm stuck with. But if I'm getting something that's giving me a 1 minute window of every minute, this is some sort of activity that's done every minute, then I can start to look at other things like bouts of walking or other things that I might not have thought about. So I suppose your ability to kind of go back and re-look at the data with a new set of eyes depends upon the sensor's ability to kind of support this, how granular the data it can provide, I suppose. Yeah, I don't know what you think about that. I mean, I know some of the inactivity, for example, some of the research grade devices actually give you the raw accelerations so you can go back to, so you could apply your own algorithms to those as well if you wanted.
Yeah, I mean, I think it depends on how you're thinking of this. So I was thinking more in terms of like the data processing steps. So not necessarily thinking of a different endpoint that I wish I chose instead of steps per day, looking at bouts or something. I was more thinking about the methods in the way that we collect these data, the settings that we collect them in, how we clean the data, how we process the data, those sorts of things. So certainly I've been on, approached by folks, whether in pharma or academia or wherever it is, that have collected data and they've collected it in some way and they come to you at the end and they say, this is what I intended to do. Here's my data. How do I do that? And it's like, you missed a whole lot of steps, prior to starting this trial that now prohibits you from getting where you wanted to go. So that's what I worry about. And that's what I think about. And I think activity data is a great example. I mean, being able to go back to the raw data, that should be something that folks look for when using a wearable accelerometer, for sure.
Yeah, excellent point. Miles?
Yeah, this is one of the questions, right? When you're designing said protocol, it's ensuring that you're capturing all those exploratory endpoints and what you actually want to look at within the data that you're going to capture. There's, and I don't know whether you've experienced this as well, there's this missed opportunity sometimes where how do you do that in that kind of traditional sense to ensure that you're doing it compliantly from when you're designing a clinical trial to ensure that you are, and obviously adhering to data privacy laws as well, that you're capturing the right data with the right device and the right amount of it, because that's what you want to look at, and therefore you sort of limit yourself as to how could we potentially look as a sort of retrospectively explore, like you would do in other areas, but in healthcare it's slightly different. I don't know if you've experienced any of that previously, but it's certainly something that I have seen. I think we overlook, and it's kind of, you can't go back and try and get access to that. It's just impossible. You can't do that, and therefore you miss said opportunity. And it just kind of gets missed. I don't know if you've ever experienced that before. And that is, like you explained, it all comes down to that methodology when you first start and really thinking about, okay, what do you want to look at? What can we grasp? How are we going to capture it? How are we going to analyze it? There just seems to be a bit of a knowledge gap, a lack of understanding as to what we really can do with it and what we really need to be looking at. I don't know whether that's consistent with your experiences as well.
Well, fantastic. Thank you very much. We've actually slightly overrun our time, but that was an excellent discussion. I wish you could have gone on longer, and extremely grateful to Kate along the way there for actually disagreeing at some point, which always makes for a much more interesting event. No offense to the guys. So thank you again to the panelists. I've certainly learned a lot over the panel and the Q&A. Thanks very much for your time and your insights, and also to the audience for tuning in. As I mentioned earlier, if you want to connect with our panelists, if you've got further questions or for whatever reason, please do so via the Giant Health conference track webpage, or indeed via the Giant 2020 page on the Thrive Wearables website, thrivewearables.com. So once again, thanks very much, Bill, Kate, and Miles, for a very interesting session. Thanks very much.
Many thanks, guys.
And thank you, Steve, as well, for hosting the session today. And yeah, really fascinating conversation. Thanks, everyone. And please stay on for the next conference session that we'll be running just shortly. Thank you, everyone.
Thanks, everyone.
So welcome everyone to today's session, and welcome to Giant if it's the first session you're seeing, or welcome back if you've been here for the days preceding this. Thrive have been here for 3 years now at the Giant Health Show, and we're delighted to come back again to bring new speakers to the floor, and in this case obviously in slightly different conditions. So we're really happy to have 5 sessions running at this year's Giant Health Show. And this is the last of those sessions, and we have some excellent speakers today talking about a subject that's fascinating from a theoretical point of view and in terms of how technologies are coming on board that relate to sleep and making us aware and helping us to sleep. It's going to be a fascinating conversation, I'm sure. Just a bit of intro to Thrive. We're a design and development consultancy based in the UK. And we really specialise in creating technologies that have impact in terms of health and wellness. We really look to work in a collaborative way to create new technologies that leverage sensors and data and the Internet of Things as it emerges in the health space. Really excited to talk to people who share that interest and want to connect in relation to that. So the session today will be followed by a Q&A where you'll be able to ask questions of the speakers. Please do get in touch as the discussion progresses and get your questions ready for us, and we'll try and get through them all at the end. And yeah, I think with that, I'm going to hand over to the panel to introduce themselves. And I'm going to start with Michael Larson. Would you like to introduce yourself, please, sir?
Sure. I am Michael Larson, and my interest in wearables took off when I was confronted with needing to help someone that I love very much. My daughter had a chronic health problem, and pharmaceuticals clearly were not the best option for treating her. And it was clear to me that seeking ways to leverage technology to work naturally with our body was a good way forward, and I think a way that everyone here can appreciate. I am a professor by day of mechanical engineering. I earned my PhD from MIT. And right now I have a particular interest in sleep, and whereas that might not seem to naturally go together, again, this relationship between technology and helping people naturally is motivating my interests at the moment.
Fantastic, thank you, Michael. I'd like to introduce now Rachel Wingfield. Would you like to introduce yourself, Rachel?
Yeah, great. So thank you for inviting me here. So I'm an artist and designer of experiences. I studied many, many years ago at the Royal College of Art, and I was looking at responsive environments. And my work was very much looking at smart textiles and integrating electronics into textiles well over a decade ago. And my interest back then, whilst I was studying, was really looking at light as medicine. So I was really researching issues around seasonal affective disorder, which I think we're all experiencing right now. And how you could use light to kind of really remedy that. So I was really integrating light into fabric. Many years down the line, I've continued to work with ideas around sort of well-being and health, and how we can create responsive environments and situations where the public can come together and engage with a scientific discourse and learn and share information around different areas of well-being, from sleep to your diet, to different ways of sort of living healthily and happily together. So a lot of the work that I do now as an artist has been through a collaborative studio called Loop.ph, and we really look at restorative placemaking, where we create these environments in which people can really relax and go through different meditation techniques, and we really look at the different ways to control the environment in order to kind of put ourselves into sort of a relaxed state and a place of kind of sharing. I've now turned my art studio, not here, it's very messy, but I've turned my art studio into a public kind of wellness place. It's quite experimental, but we run sessions throughout the week. Where people can come, they can do gong baths. We do create different kind of sound and light environments. We look at sort of well-being and mindful fitness and movement. So we're just looking at wellness on lots of different levels and invite different practitioners to come and experiment. So sleep is something that I'm kind of really interested in on a personal level. I've had insomnia for most of my life, and I've been trying to understand and look at different ideas around sleep, why I'm not sleeping. I've actually come to the conclusion that it's okay. I don't perhaps need to sleep as much as other people do. I'm kind of really interested in sharing what I've learned, but it's very much from a personal perspective. How do we deal with issues around anxiety, different mental health issues and how they relate to sleep? So yeah, I'm here to sort of share my experience as an artist. So thank you very much.
Fantastic, thank you. And Lizzie Hill, would you like to introduce yourself, please?
Hi, thank you very much. My name is Dr. Lizzie Hill. I'm a lecturer in sleep medicine at the University of Oxford, and I'm coming from a slightly different background in that my background's in healthcare science. So having worked as a clinical physiologist for the last 20 years, specialising in the diagnosis and treatment of sleep disorders in various different clinical and academic settings based in Edinburgh. I'm obviously passionate about promoting healthy sleep, and I'm now a full-time educator in the field. And I'm based at the Oxford Online Programme in Sleep Medicine, which is one of the first online programmes to come out of the University of Oxford. It's been running for 5 years now, so we were slightly ahead of the game in the online teaching field. But we have a course that's a 2-year master's programme, which is open to anyone with a professional interest in sleep medicine. So as well as my role within the online programme in sleep medicine, I'm currently the education lead for the British Sleep Society, which is a multidisciplinary organisation for sleep professionals, and I'm also president of the European Society of Sleep Technologists. So I'm coming from quite a clinical and academic perspective, and also from a teaching side of things. So I have a lot of experience in sleep diagnostics, so I'm really excited to be on this very interesting panel of people with a lot of interest in sleep diagnostics today. Thank you.
Fantastic, thank you all for the introductions. What a broad panel we have. I'm really fascinated to see where the conversation goes. I'm going to start actually by asking you, Michael, because of my sort of understanding of the technologies and the sort of development of those things. I'm really interested about the measurement of sleep and what you can see when a person is sleeping. And it may be useful for our audience to kind of get a fix on that. You have a product in the market that is about sleep and about measuring sleep. I remember talking with Tim Antos at Cocoon about sleep technologies and how the intelligent kind of interaction with sleep cycles was a really sort of a hotbed for innovation. Can you tell us a bit about sleep signals and the cycles of sleep and how those two things kind of meet?
Sure. And whereas I'm sure Lizzie includes this in her course, no doubt, but for healthy sleepers, we typically go through a number of cycles regarding our brain activity during the course of a night. And a healthy sleeper will maybe have 4 or 5 of these cycles typically. And it all has to do with the rate of our brain activity. So literally across our cortex, we have electrochemical signals washing across them. And when we're awake and alert, doing something fascinating, like participating in today's session, that rate can be 40 to 60 times a second as a baseline. And as we begin to move towards sleep and we pass through that meditative state that we have all felt maybe when we're studying, we're very interested in something, our brains have those brain waves moving at about 20 hertz or 20 times a second. When it gets down to about 10 to 12, that's we're on the edge of being awake to asleep. And most people have that sensation periodically of not really knowing, am I awake, am I asleep? And it's that zone. Slower brainwave rates put us into stages of sleep. Right now, there are 3 stages of what we would call regular sleep that we can really think of in terms of that brain activity slowing. And in the deepest sleep, sometimes called delta sleep, the rate can be as low as 1 hertz. So our brains still have some activity that spans the whole range of rates, but we're looking at the predominant activity. And then the brain will speed up after slowing to complete one of these cycles that we're talking about. And right when it looks like we might be headed to wake up, we enter the REM period, which is our eyes flashing back and forth. This is when we're dreaming, and our brain activity as measured by an EEG, looking at the voltages on our scalp, can look very similar to being awake. It's that fast, but yet we are asleep. We experience some involuntary paralysis of voluntary muscles, presumably to stop us from acting out these dreams. And then the cycle starts again for a healthy sleeper. And that first REM activity happens typically, about 100 minutes nominally after we first fall asleep. And the time we spend in the deepest sleep part of the cycle is larger at the beginning of the night than at the end, because our bodies are very hungry for that deep sleep and all the good things that happen. Our tissues are being repaired. Probably what seems to be the most beneficial thing is it's during deep sleep we now know that our brains activate some cleaning mechanisms where it cleans out a lot of the byproducts of cellular activity. We don't have a lymphatic system in our brains to clear that away. So our brains literally shrink, by some estimates, up to 20%, and that allows a profusion of cerebral spinal fluid to go through our brains and wash out this stuff, which may include those beta amyloid plaques that are the hallmark of Alzheimer's. And we've got the first longitudinal studies that show a direct link between lack of deep sleep and a propensity to develop Alzheimer's. So it's very important that we get sleep. We've got to get away from this idea that it's a badge of honor to go without sleep. I worked all night last night showing what a great person I am, when in fact we will pay a price down the road for this lack of attending to the benefits to our overall health for getting sleep. So we want to encourage these cycles, and we do know that when people go without sleep, it messes up that sleep cycle pattern completely. Alcohol messes with it, so we need to understand it and help people understand their sleep better so they can change their behaviors to get the maximum benefit.
Yeah, that's really interesting. So in terms of this engagement with sleeping, it's a science and it's a necessity. But I guess the engagement with it and the narrative and the stigma around certain types of sleeping or not sleeping, or the tendency for some people to overwork and to kind of eat into that's kind of obviously one of the big problems. Rachel, I'd ask you this question in relation to your work as an artist and the engagement of an audience, I suppose, with this idea of sleep. Can you just tell us a bit about how you engage with the topic, first of all, with your audience, and then kind of how you interplay with some of the science parts of what Michael was describing?
Yeah. So as an artist, I've always been really interested in bridging the gaps of understanding and the different communities, scientific communities and artistic communities, and finding a way to, I guess, go a bit beyond like public engagement. We've been, as a studio, creating platforms in public spaces which bring scientific researchers together so that they can really share their research and engage with the public directly. One of the projects that we did was called the Cranarium, and it started off in Singapore, I think in 2016, and it was like an installation that we built in quite a busy shopping mall, and we were really looking at how we could control the environment and different environmental stimuli in order to shift people's bodies into deeper states of relaxation. So we were looking at ways in which we could control the lighting and the sound, and really looking at different frequencies and the effect, physiological effect, but also just kind of a general state of well-being. So that's kind of how the project started, and it kind of has been growing and been shown in different communities. We then showed it in Manchester at the at the Science Festival. And again, it went right into the Arndale Shopping Centre, which is an extremely busy, there's a huge amount of people passing by, and we sort of built this almost temple dedicated to sleep and sharing sleep facts over there. And yeah, we had a sort of a forum and a platform to share like tips and information about sleeping, but it really became like a discussion point and a platform where people could come, they could enter this space. And what was really interesting about the work that we were doing, which wasn't really thought about in such great detail, was this sense of togetherness. And obviously when we go to bed, we're generally, some of us quite often alone in our bedrooms. It's quite an intimate, alone type of experience, and it was interesting to start doing these projects, which were where you would go into the space and there'd be like 20 other people all suspended in hammocks, being held by these textiles and being bathed in different frequencies of lights and sound, and really being looked after by some facilitators. Some sleep scientists were there, and just to kind of really look after people. And this sense of togetherness was something that became quite interesting, and the socialness of sleep, which doesn't normally kind of exist. So we worked with researchers who would then had different EEG headsets. We would have some participants who would answer some questions and actually end up dedicating and being part of actual sort of research projects. So it was interesting to engage with the scientific community in this way, where it became beyond public engagement, but where we were actually helping different scientific communities conduct their kind of research. And we were just looking at how we played and controlled and did things in the environment, what kind of effect this had in terms of shifting people, through the different brain states, from theta, alpha, beta, how we can shift these different states. And we've worked with various kind of biometric sensors to do this. We've been recently looking more at meditation, meditative states, and just different ways of observing and analysing this and getting kind of biofeedback. And we've found, EEG headsets, it sounds great to be able to monitor your brain waves, and it has a very kind of nice kind of sci-fi thing. But in terms of useful data, it's quite difficult to really engage with. But we found just really looking at breath and heart rate, so using chest breath expansions and really looking at how people change their breath and how that affects their heart, and how we can look at states of relaxation. And I think looking at that actually became more interesting when we're sort of starting to talk about sleep and sleep science, really. How can we make people feel calm and to clear the mind, so that you're in a position to sleep? Because even just, for someone who suffers from insomnia, being told you must sleep, I must sleep, I must sleep, I'm not sleeping, is just, you put yourself under a huge amount of personal pressure. And it's I'm a bad person, I can't sleep, oh my God, I need to go to bed, why am I not going to bed? So it's how do we prepare ourselves for sleep? And how can we have a conversation around it, a public conversation, which is kind of less guilt driven, you must sleep, it's so important. So I think,
It's a tough one, isn't it? The psychology and the physiology, they kind of interact. Lizzie, yeah. I'd love to ask you about broader technologies. Rachel and Michael have talked about EEG as a method of measuring brainwaves and how that relates very, very closely to sleep. You're the president of the European Society of Sleep Technologists, which sounds fantastic. I want to do that. That sounds awesome. Tell us about what's out there. What can you measure in terms of sleep signals, and what's the kind of input for sleep science and measurement of sleep, and what's out there at the moment that people may or may not have heard about?
Sure. So it's quite interesting that we're talking about EEG, because the sort of traditional EEG-based polysomnography is really, when we talk about sleep technology from a clinical perspective, that's generally what we're talking about. Sleep physiologists and sleep technologists tend to work mainly with the EEG-based PSG. But there are a lot of newer technologies out there, and of course the consumer wearable market has blossomed hugely in recent years, which obviously you'll know a lot more about than I do. But things like movement are very important. We can use things like actigraphy as a a surrogate marker of sleep and wake. So when someone's moving, we assume they're awake. When they're not moving, we assume they're asleep. But then also, as Rachel mentioned, things like breathing, heart rate. There are devices out there now that use things like peripheral arterial tone, so changes in the blood pressure at the tip of the finger, as a way to measure proxy measures of sleep and sleep stages. I mean, I think what's exciting for me as a sleep technologist is how these novel sensors that are coming through from people like Michael, from engineers and data scientists, the sort of new side of things that's coming through could really revolutionize sleep medicine from a technological perspective. I guess things like artificial intelligence and machine learning are big areas at the moment which are being applied to sleep data. And I think that gives us a lot of exciting interdisciplinary opportunities to replace the traditional technologies with something quicker, easier, more reliable, easier to do in big volumes. To sit down and score an EEG-based sleep study can take anything up to 3-4 hours of manual labor to score that study. And if we can have big data, use big data sets to use AI to automate that process and take out the inter-scorer variability that there is there, anything that's based on humans interpreting physiological signals is subjective and fraught to sort of variation between scorers. So I think from my perspective, having something like AI applied to physiological data that can just take out that step for us and give us reliable automated scoring of sleep studies would be really, really important. And we've actually got our DPhil student working on this in Oxford at the moment, but I know there are lots of other people out there who are using deep learning and machine learning to automate the process. I guess some of the other exciting things that are out there at the moment, there's a new technology, a device called Sunrise, which uses mandibular movement, so movement of the jawbone, as a way to work out breathing and sleep stages. And then all of the wearables, anything that uses a sort of limited channel EEG, that's a sort of minimally invasive technique that people can use in the home. So there was a technology called the Zio a number of years ago, which was really promising, and then kind of died a death. So I guess the sort of limited channel EEG coming through again would be really quite useful from a clinical perspective, but also could be really useful for consumers, because I think it's clear, the reason that we're all here is because consumers are really keen on monitoring their own health and their own well-being. And I think, there's lots of opportunities where the new sleep signals and novel sensors to measure sleep could have an application there.
Yeah, that's fascinating. I mean, I guess brainwaves, that's kind of the one, isn't it? That's what you want to measure. But as someone who's worked on these signals and the sensors around them, I'm struck by the starkness, I suppose, of the example of brain monitoring technologies, and just the void between what works scientifically and what consumers are willing to use. And it took me a while to find any kind of plausible consumer application in my sort of training, I guess, as a wearable tech person many years ago, until I came across sleep. And it was like, well, if the person's asleep and you've got reasonably good electrodes on them, you've got a fighting chance of taking their brain waves and getting some useful information there. So for me, sleep and EEG, that's the perfect combination. But even that, you won't get away with using wet electrodes across the head, measuring all sorts of, it's kind of a dry electrode, badly placed through hair scenario, and that's the the challenge that we face in a lot of the product development we do. It's around user experience, and I think having you, Rachel, on the panel to talk about that kind of engagement, that user side of things, I want to come back to that in a moment. I'm going to ask Michael first of all, though, about that from a sort of engineering and productization point of view. What have you had challenges in that space? Wet electrodes science, consumers and consumer electronics?
Sure, a lot, and I appreciate leading question because it is very challenging. And as you point out, not the least of which is even assuming we have something that would give quality data regarding brainwaves, it's getting people to use it. And I've had companies do professional marketing studies that included my product, which right now is a headband. And a lot of people are reluctant to put something on their heads. And it is a challenge to help them appreciate the benefit outweighs the time or perceived discomfort. And what we find is that, for a long time, people used to wear sleeping caps before central heating became ubiquitous, but they're reluctant now to wear something on their heads. And I will say that as an engineer, please know that I appreciate data, and data is very important. And it's very important, especially if we want to help people understand their health, as Lizzie says, and as Rachel made clear, sleep is about an experience, and understanding how to optimize that experience is dependent upon data. But for me, the part that I think we maybe as a community have been missing out on is the focus really is how do we help people sleep better? And it's a little frustrating when someone, say, is wearing an actigraph on one's wrist, and it tells them, you had a bad night's sleep. Well, the first reaction is, I know I had a bad night's sleep, and they put that thing in the drawer, and it stays in the drawer. And it turns out to not be a net positive for them when that's the end. And if we have this idea of we're coming at it from the perspective of, first and foremost, what do we need to do actively to help them sleep? And then ask ourselves, how does the data feed into that as a goal, where too often I think we get this notion that big data is somehow the end point. And again, that might be good for big pharmaceutical companies who are looking for ways of decreasing costs of doing an analysis of a new pharmaceutical solution. It isn't helping that particular end user. And a drawback of using many of the surrogates for brain activity, and although brainwaves sounds a little scary for the typical user, and I'd much rather just wear a wristwatch than something that's touching my scalp, what I have found through my own testing, and without mentioning any companies' names, it is clear to me that the typical mode of presenting the consumer with data about sleep is to fit a curve that simulates that type of sleep I talked about at the beginning with these cycles, and we go in and out of deep and light sleep. And then companies are using the motion data to try to figure out where the peaks and valleys, and then they present that to a user. And whereas that might be good enough for maybe the majority of people, I can tell you for those that we would like to identify in the population who have something serious going on with their sleep that maybe they should need to see an expert about, these devices can cover that up. For example, someone with narcolepsy can immediately go into that REM period of sleep and not wait 100 minutes or so before experiencing that. And a lot of these devices will not pick up on the fact that a person is asleep but having a REM period of sleep at the beginning, because it doesn't fit the curve fit that is the foundation, again, of this presentation to consumers. And I do believe that because of this, and I think it's done with the best intentions of taking what many times is an inadequate data set because you're dealing with someone's bedroom, they haven't put this thing on right. So we're doing the best we can, but it can end up being a disservice, at least, of showing someone something that maybe isn't an accurate representation of their sleep, all the way to turning them off of the notion of sleep tech, because all it does is tell me that I slept bad when I know I slept bad, or even worse, I had a horrible night's sleep, but my wristwatch tells me I had a pretty good night's sleep. Who am I going to believe in that scenario? So it is a big challenge, and I think we, again, as a community, haven't done people a service by allowing them to think that somehow from a bedside unit we can tell you how your sleep is, and we actually have done nothing to assist you in sleeping better. And I do understand when Rachel says she's not sleeping well. Every day I get messages from people who tell me that their life, the quality of life is not good because they're not able to get enough sleep, and there is this pressure to perform. And there is some research showing that blue light will indeed help stimulate the brain into thinking that, oh, it's wake time, so you should stay away from those screens at night for that input. But I believe in most cases, looking at the cell phone as you're trying to sleep, it's what's written there that is far worse than the blue light. When you see that, yes, Jacob is going on vacation again, that guy is always going on vacation. I never get to go on vacation. How are you going to sleep after reading that? Because again, you're not allowing your brain to slow down because of all the worries and cares in modern society. And what we need to think about, I believe, with wearable tech is first and foremost, how do we calm people so they can allow their own brains to slow down and get that deep sleep?
That's a great segue, Rachel, into a question for you in relation to, I guess, the broader picture of a product or a kind of piece of tech in someone's life trying to assist them. And I guess with your work, you've kind of looked at the journey of sleep and the narrative of sleep and people's perception and the social engagement of sleep, potentially. Lots of different dimensions to it because it's such a personal thing. It's such a universal thing. How can we design technologies that are sensitive enough to engage with that quantity within people's lives?
Yeah, thanks. It's a really interesting question, and thank you, Michael, for what you were saying. I think it really resonates with me. Like, how do you allow people to calm their mind? I mean, I've done a huge amount of work myself, working with different lighting suppliers, lighting technologists, and dealing a lot with light and taking probably quite a scientific and almost engineered view to the environment. But I'm very much aware that. It's how you can use technology to help people get into a place where they can empty their mind, or they can record something, or they can really prepare themselves and move away from an environment or a way of thinking which is incredibly stressful and catastrophic. And how do you calm down? So how can we use technology in a mindful way and allow people to meditate, contemplate, calm down? So I'm really interested in that use of tech. And also thinking about, this doesn't answer this question enormously, but I'm just really interested in thinking about sleep, not just for like a specific group of people, but what does sleep mean for someone who's doing shift work? What does sleep mean for someone who's like, I don't know, in a state of like constant panic and they're traumatized? What does sleep mean if you're homeless, which actually really became an issue when we were doing this project in Manchester. The biggest community and people that would come and actually use the sleep lab were homeless people, and they were just like, "Thank God, there's a safe space. I can just sleep. I only ever get 15 minutes of sleep because that's the longest I could really sleep somewhere, and then I have to move on." So I found myself speaking to this group of people. that I wouldn't normally be speaking to about sleep. And it just made me think about the topic very, very differently. So how do we design society, not just technology, that allows everybody to have better quality of sleep? And there's obviously this very strong link between mental health, mental well-being, and sleep quality, which obviously perpetuates people's situations if they're getting a poor sleep. So I found that quite challenging, being there talking about sleep to the privileged people rushing about shopping. And it made me think about how do we design technology, environments, society, even for everyone really, looking at the sort of equality of sleep. But then also I've been doing sort of my own personal research and looking into ways in which I can use light and feedback from light. So I've been through the whole thing of collecting data, looking at the data, my data, other people's, and analysing it. But being an installation artist, I'm always really excited about live data, live feedback, immediate. You don't necessarily get that when you're sleeping, but you can get that before you sleep and when you're in this preparation environment where you're preparing for sleep. So I'm kind of really interested in kind of neurofeedbacks, biofeedbacks, which can help retrain you. So perhaps there's a way of wearing these EEG headsets or different biometric sensors, which actually retrain you, and you can go, okay, I'm doing this, I'm breathing in this particular way, I'm now shifting into this particular brain state, I'm shifting into this state, okay, now I can adapt my behaviors. So I'm really interested in how tech can be used to get immediate feedback so that you can kind of retrain and adapt and learn about what's going on in your body based on your immediate kind of experience, I guess, rather than analysing a night's data, and you don't really learn much from it.
It's interesting. You touched, or you're talking, I guess, about biofeedback and that idea of looping round many times rather than it being a kind of one shot. That's your status. Yeah. I guess. I'm fascinated with biofeedback across all sorts of products and projects that we've been involved with. I wonder, Lizzie, have you had any kind of engagement with those kind of technologies where you're not just looking at the science of sleep, but you're actually looking at cause and effect relationships? Can you affect people to improve their sleep, for example, with biofeedback? Have you been involved in anything like that?
Not particularly. What does interest me though, and both Rachel and Michael have touched on this, is about the subjective experience of sleep. And we tend to, coming from a scientific background, we tend to focus a lot on the objective measures. But actually, sleep's a very person-centered process, and it's all about how you perceive your sleep. There's no use in me sitting in a sleep lab telling someone that they sleep well if their subjective experience is that they sleep poorly. And I think what's interesting is a lot of the consumer devices will give you feedback on the quality of your sleep or the quantity of your sleep. But as Michael alluded to, if it's telling you you've had a great sleep and you know that you haven't, then that's not helpful. The flip side of that is if you're getting feedback that your sleep, if the feedback that you're getting isn't accurate, then that in turn impacts on your subjective perception. And my colleague Dmitry Gavrilov in Oxford, he carried out a study using actographs where they were rigged to give sham feedback. So participants would get randomly assigned sham feedback that either told them, you slept for 80% of the night last night, that's great, or you slept for 80% of the night and that's bad. And that actually influenced the subjective experience of sleep for the user. So I think that type of feedback, what kind of interests me is the quality of the feedback and the accuracy of the feedback. I guess it comes back to our different backgrounds, but I always want to know that something's valid and accurate, and particularly if that can have a negative impact on our consumers or our patients or our clients. I guess the other thing is that we have this new concept now of orthosomnia, where patients become excessively preoccupied or obsessed with monitoring their sleep. And if you've got someone who's already sleeping poorly, it's quite easy for them to get into a cycle of obsessing about their sleep. And I'm sure, Rachel, you can, relate to this yourself. But someone who doesn't sleep well, they start to obsess about their sleep. And we have to be very careful with our devices, whether they're consumer devices, whether they're clinical devices, we need to make sure that the feedback that we're giving people is proportionate, that it's valid, that it's accurate. And I think we do need to be careful that we don't, actually make people sleep worse. In terms of the actual biofeedback, I've not really been involved so much in that side of things. We do have devices that are available commercially for clinical purposes, where we use things like vibration feedback to get patients with sleep apnea to turn from their back onto their side, for instance. But beyond that, I've not had a huge amount. It's really been more with it tends to be the clinician that's giving the feedback. And I think that's where our backgrounds are very different. I guess what we're looking at is consumer devices where the consumer is managing their own health rather than the clinician giving that feedback. But as I say, I think it's interesting to remember that the feedback that comes from these devices can actually affect people's subjective experience in a negative fashion. But I guess we could also harness that to try and improve their sleep. And I guess there's the whole ethics around giving placebo feedback and whether that improves people's sleep. But I guess the ethics of that's quite complex. So maybe not a discussion for today.
Maybe don't prescribe that one today. So I guess, Michael, do you have any experience with biofeedback and the interrelationship between sort of cause and effect? Or indeed, as I was listening to your answer, Lizzie, I was thinking also about stress and anxiety and how these things are quite often intertwined. Is there any way of deconvoluting stress and anxiety and comparing it with sleep? And, if you're measuring people's brainwaves, broaden it out from just the sleep factor.
Well, as far as biofeedback goes, the approach I've taken with this Sleep Shepherd headband, which it's gratifying to have lots of positive feedback from people who have used it. So when you do help someone sleep better, that is a good feeling that you get. And I will just say, Rachel, I think it's wonderful that you took time to talk to people who are homeless, because I can only imagine the extra difficulties that they have. And I love the idea of our caring about them. But with biofeedback, I do measure a simple single channel EEG. And when you're only measuring with at one place on the scalp, you do miss out on some of the wave-like behavior. So it is more difficult to get out what are just little anomalies in the signal. But for determining whether someone is awake or asleep, a single channel seems to be acceptable as long as you are getting an accurate signal, which I will also say can be problematic, again, when you're dealing with the realities of someone's bedroom and relying on them to put something on properly without help is a challenge in and of itself. Sometimes I have discovered that people were not satisfied with my product, and it came to find out they were wearing it backwards on their head, which to me is just, how can this be? There were pictures, but it's a reality that we have to face if we really want to help someone in that consumer space. We don't have the benefit of everything being in a sleep lab or on a benchtop in a laboratory, really helping people. But taking these measurements, I then play through thin speakers some very interesting binaural tones. And if you want to talk about those, I can all day, because they have a very interesting effect on the brainstem in kind of hypnotically fooling the brain into thinking that it is exposed to a periodic input when in fact none is actually being presented. And then we rely on brain entrainment, getting the rest of the brain to kind of follow in step with an external stimulus to encourage brain activity to slow down. And then using this sensor, I customize those tones in real time to try to maximize their benefit. And when someone is in deep sleep, the tones will fade away, ready to come on again. So there's that little biofeedback loop in the operation. But I also have come to appreciate anecdotally, and I haven't been able to do a study specifically about this, but users tell me that their sleep gets improved and they don't have to wear this thing every night. And as an example, my attorney, when I first started trying to commercialize this product, he was going through a very difficult time in his life. And he started wearing a sleep shepherd and was actually, like many people, shocked at how much help it gave him in sleeping. And now he tells me that he doesn't wear it normally, but he finds it helpful to use, say, right before he has to be in court the next day, or he's got a big meeting and he wants to make sure that he's sleeping well. So I hope that means that there is this brain learning through biofeedback, and the brain actually is teaching itself how to slow its activity when it is sleepy time. So that is a biofeedback loop that I hope is active, and there is some research to support that idea.
Yeah, you've definitely got to the nub of it. I didn't realise quite how integrated your platform was in terms of that biofeedback loop, but that's definitely kind of a really great example. And we've done work with binaurals as well, so I know very much about that mechanism. It's fascinating and a great brain interface, that kind of technology. I'm going to run out of time, so I'm going to wind things up. I'm going to ask a question, and if you could just give me a kind of quick one-line response, each of you, if you have a thought on this. What can people do in terms of using technology to enable sleep right now? Is there something kind of obvious that they should be doing if they're struggling to sleep? Is there a product or a service? And maybe this is maybe you go somewhere else, Michael, than the Sleep Shepherd, which is an obvious candidate. But just a quick one-liner on that, if you have something to say. Let's start with Lizzie.
Put on the spot, I would say thinking about technology that's already out there and already in use. There's an app called Sleepio, which delivers digital online cognitive behavioural therapy for insomnia. It's been validated, it's in use in the NHS, and it's a great example of how we can sort of move the therapist out of the hospital or out of the office and into someone's pocket. So yeah, that would be my quick one line off the top of my head.
Fantastic, great answer. Rachel.
Yeah, there's loads of amazing sleep apps out there, and ones that I use. And I mean, for me, I like to use kind of lighting. I use the Philips Hue lighting, and I set it and I program it in the bedroom to fade through the Kelvin scale, to fade into a sunset, so it gets dark. And I also couple that with using binaural and using sound within the space. I listen a lot to the work of Leo Kasendai, who's a sound meditator who helps with sleep. So I listen to his stuff before bed in a sort of darkened environment, and I find that really helps.
Fantastic, thank you. Brilliant answer. And Michael?
Well, I would just say kind of where we began. If we as individuals as society, culture, just take a different view of sleep and don't perceive it as being the thing that is expendable whenever we need a little extra time to get something done. There is no badge of honor in missing out on sleep.
Yeah, I think those are great insights from the team. And thank you so much for joining this discussion today. We're going to move to questions now from the audience, and we've got 10 or 15 minutes to look at some of the questions that are coming through. So just let me say thank you again to the panel for today's session, and we'll open the floor up now to questions.
Yeah, as far as her screen looking artistic,
think we're just issues. Thank you so much. Fantastic. Well, another great panel discussion today around sleep, and we're all gathered here to kind of now take some questions from the floor, hopefully. At the moment, we have few questions, and I'd love for the people on the channel to start putting some stuff into the chat window rather than the questions tab. Counterintuitively, it's the chat window that we'd like you to stick your questions. So, yeah, please have a think about the discussion today and pitch some ideas in for some questions. I've got like a whole page of questions that I've written, and I don't really want to ask them all because I've asked tons of questions already. But I will start with one, and I'm going to pick one at random, sort of. We talked in another show that we did, or another session we did, around pharmaceuticals, and we're a health show. There's still a lot of pharma in the world. People still use drugs to achieve things with their health, and that's all well and good. But there are ways of doing things without drugs now, and we were talking about mental health and about how one can use methods to improve mental health. But in terms of sleep and pharmaceutical interventions, are there any ways that we can use technology instead of pharmaceuticals for the purposes of improving our sleep?
Shall I take that one?
Why not? You kick us off, Lizzie. Thank you.
Yeah, so the one that jumps to mind immediately is the Sleepio app, or there are a number of different apps. I shouldn't really single out one, but certainly Sleepio is one. There's another one called Sleep Station, and these are digital online cognitive behavioral therapy for insomnia. So that's a way that interactive technology is already being used in place of pharmaceuticals. So the NICE guidelines recommend CBT for insomnia as the first line treatment for insomnia over and above medication. So that's a way that technology is sort of sidestepping medication in some ways. And that's already out there and validated and being recommended. It's not always necessarily available free to everyone. I know that there are parts of England at the moment where Sleepio and Sleep Station are available for free, and Sleepio is available to all health and social care professionals for free at the moment because of the current situation, as a way to improve the sleep of healthcare workers. But it can be a bit patchy in terms of availability, but it is out there, either free or at a cost, and that's a way that it's already being implemented. But I think that as we go forward, there's going to be far more new technologies that will come through that will start to do similar sort of techniques. And I know that there's already some out there, for instance, looking at anxiety disorder and depression. And I think this is something that, anything where face-to-face therapy might be an option can be in some ways automated or replaced by digital technologies.
Yeah, and following up with that, and I agree with that. Part of the issue around cognitive behavioral therapy of all kinds, though, is getting people to follow through. Most of us know, stay away from refined sugars, and the list goes on of how we should live and floss twice a day, brush 3 times a day. And just knowing that these things are good for us are difficult. Part of the appeal, of course, for pharma solutions is it's popping a pill and I'm done, right? It's going to happen without my participation after I swallow. So in the kind of form of what I would call more pure technology would be ways of trying to stimulate the brain through, right now, the 5 senses. It remains to be seen whether or not the various attempts to sink electrodes into people's brains in order to stimulate directly inside the skull. We'll see. But right now, using the senses to affect body changes, physiological changes, is interesting. And we can look at some of the changes that naturally occur when we sleep. And we talked about in the session brain waves slow. So if we can think about ways of affecting that, core body temperature goes down. So if we could affect that change, maybe there would be a feedback to encourage sleep. There, of course, is the visual inputs. And people have tried a variety of these things, even including transcranial electrical stimulation, in hopes of getting a frequency of electrical impulses that would encourage the brain to adopt that. I caution people to try that, especially that is one of those don't try this at home kinds of solutions, I think. But as we learn more about how the body responds to sleep, I think we will get better and better about using technology to try to affect those changes by working naturally with body systems. But I still think we're at the front end of that.
Rachel, I know you've got some video problems, but you're on the call, and thanks for joining us. Do you have any thoughts on that sort of topic around, removing the drugs from the sort of poor sleeping equation?
Yeah,
you must have experienced lots of stuff in that space.
I've personally looked at lots of different options. Apologies for the no video, by the way. But I'm really interested in ways that we can meditate and have more understanding of what's happening within our inner world and our brain. I've also been doing a lot of work into looking at how sound and light can be really considered as medicine, really. And how we can basically use sound and binaural beats to shift our brain states, which is obviously sort of a fairly old concept, really, in terms of using tech, but really looking at ways that we can bring this into the bedroom and bring it into sort of everybody's home, really, so that we can, reprogram our brains. It was actually one of the only things that helped me when I had periods of insomnia, was listening to binaural beats and sound, and using sound in that way. So, yeah.
I've got a question that follows on from that, because we're still waiting for some of the audience to push their questions forward. So please, everyone out there, give us some questions. There's a fantastic panel here, and they'd love to hear what you've got to say, and we can answer those questions live to the audience across the globe. I'm going to ask about prescribing technology, leading on from the pharma discussion. Can we go to our doctor, Michael, and get a sleep shepherd on prescription?
Well, currently, of course, things that, at least in the US, where I'm more familiar with regulatory approvals, once something is regulated, then it almost restricts its use, because using things off-label, people get a little worried about that. Lawsuits can ensue. And for me, in the wellness regime, I think if we really believe that wellness is about a lifestyle that keeps us from getting sick and maybe having to get prescriptions, that we would like the technology to fit more into that and be less regulated, so people have better access, certainly lower cost access. Clearly, if we're dealing with a tech solution that has the possibility of doing harm if used incorrectly, we need to think long and hard about how we control that, of course. But most of the technologies that I see coming online that are meant to encourage healthier lifestyles, I think can sit for the most part in the consumer category. And the ones that help will flourish, and the ones that don't really help will get pushed to the side, we hope. But I think if we can keep it out of the hands of the regulators to the extent that's reasonable, it's a good goal.
Do the panel have any other thoughts on the prescription of technology? We're in the UK, Rachel and Lizzie, and I guess we have slightly different regulations, but similar kind of challenges, I guess. Any other thoughts on that one?
Yeah, I mean, there are some aspects where technology is already being prescribed. So the one that springs to mind is light therapy. So patients who have circadian rhythm disorders can, in some parts of the country, certainly in Edinburgh, where I worked previously, and many other sleep centres around the country, you can be prescribed light therapy, you can be given a light box to take home, but obviously that's quite large, quite cumbersome. There are cost implications around supplying these devices to huge numbers of people, and I think we need to find smarter ways to deliver that kind of technology. certainly with the current situation, the days of just popping into a sleep centre and picking up a piece of equipment to take home, which you then bring back and is reused, with problems that we have with COVID at the moment, that's just not feasible. And I think finding ways to miniaturize technology and, wearable devices in particular would be a way around this. And I think part of what Michael's alluded to as well is, we want to look at prevention rather than treatment. So looking at the preventative aspects that would stop people from having to come and receive the therapy from a specialist tertiary centre, for instance, or even from a primary care provider. I think looking at the preventative aspect of consumer monitoring and wearables and how that can reduce the need to visit a specialist, I think that's one of the areas that we should be concentrating on.
Thanks, Lizzie. I'm going to pick up on a term that was used in the discussion. I think it was you, Rachel, who raised seasonal adjustment disorder, and it got me thinking about that and vitamin D and sleep and the interplay between those things. I don't know the answer, or I don't even know the question to some degree, but can the panel sort of talk about those things and the interplay potentially between those?
Is anyone else? I can take this one if no one else is jumping in. So the vitamin D side of things, not so much, but certainly the changes in light across the seasons. We know a lot now about the receptors in the eye, which control the switching on and off of melatonin, which is the sleepiness hormone. And certainly part of the story is that over the course of the year, the amount of light and dark that we have on a daily basis changes. And if you were to take away all the external cues that we have on a daily basis that pin us down to a 24-hour rhythm, then light is the most potent one of these cues that pins down our circadian rhythm. So as the seasons change throughout the year, then in theory, if we were following the natural seasonality, then our bedtime and rise time would change. So if you put people in environments where they're completely governed by light, so for instance, there's a project in Norway where they have a glass house that you can go and live in, and that 24-hour, or rather the light and dark cycle will determine your sleep and wake cycle. So I'm not so sure about the vitamin D side of things. Obviously vitamin D is very important and is produced when we're exposed to sunlight. But in terms of sleep, it's more the effect of the light entering the eye, switching off the melatonin to tell you that it's morning, or the sun going down at sunset and switching your melatonin on, that tends to be more of the driver. And seasonal affective disorder is not my specialist area at all, but there are obviously very clear links, bi-directional links between the sleep and mood and sleep and depression. And it makes sense that as the amount of light and dark changes and you're perhaps working against your natural cycle, so the light outside is telling you should be going to bed, but the light inside your house is telling you should be awake, it makes sense that there would be an impact. Like I say, seasonal affective disorder is not my area, but certainly there are clear links between sleep and mental health and light. So yeah, I don't know if I've answered the question there, but maybe some of the other panelists have something to add.
I mean, I've done a lot of work around light and light therapy as an artist, but I remember when I was researching it, what became really clear is that light therapy in relation to controlling the circadian rhythm was really important for people who are traveling, so people suffering from jet lag, and people doing shift work. So it's just interesting how we now have to use artificial lighting to deal with a certain artificial way of living where we can fly across the globe at such a speed and expect to work through the night when usually we wouldn't. So we're sort of going against some of our biological instincts and then remedying it with technology. So I guess it's important to look at those natural cycles and maybe look at this glass house sort of scenario. But yeah, I think there's a huge amount of health problems, mental health issues around people working and doing night shifts when they're sort of working under sort of extremely bright fluorescent daylight tubes, and this has like a really great impact on the sort of physiology and mental health. So yeah.
I've actually this past summer I spent the summer waking up with the sun. So rather than the sort of the notion of having blackout blinds and kind of metronomically sleeping, I went for the kind of like keep the windows open, and I found it fantastic actually, and I felt my sleep was much better for doing that, which probably links to what you're describing in terms of the melatonin and the cycle, and I guess over time people have become accustomed to 8 hours rather than swaying between 7.5 and 8.5 maybe, or something, as the seasons adjust. Really interesting topic. Michael, I'm going to jump back to a comment you made about Alzheimer's and about this idea that the brain shrinks and gets cleaned up by sleep. It's quite fascinating but scary at the same time that we can be potentially giving ourselves long-term problems without going through that cycle. Is it possible to kind of really link those things together, Alzheimer's and lack of sleep? Is that something that's in the literature and a thing, or what is the link between those sort of categorically?
Yeah, it is a thing that there is a link between missing out on deep sleep in particular and the propensity to show signs of dementia later in life. The exact mechanism is still being investigated about what causes the link, but there is a clear one. In fact, sleep is typically, I've seen listed as the second most important indicator for Alzheimer's next to genetics. So there is something there. And the general thinking now is, as we talked about, the buildup of these beta amyloid, the twisted proteins that result from normal activity aren't being cleared away as they should be, because the mechanisms that the body uses to do that are initiated when we are in deep sleep. So the thinking goes, and it certainly seems rational, that if you miss out on deep sleep, then you're not activating those mechanisms, and therefore that would result in this buildup that we see of the plaques. And it's only recently that we have some imaging techniques that allow us to see these beta amyloids. We've got some now markers that will adhere to those. And what's been noticed is, again, we used to think that Alzheimer's, other dementias were something that plagued older people, but not people under 65, say. But we now see that these plaques are building up over time. And then some other mechanism that some people are beginning to work out kind of activates it by running around and clipping the tails off of all of these beta amyloid proteins that cause them to wrap around and destroy neurons. That is then a progressive situation, and we see a decline in mental acuity and the other things. So getting sleep is very important now for our health later in life, for sure.
Yeah, we've done a bit of, oh, sorry.
I was going to say, if I could go back to something Rachel was talking about with shift workers, there is a company that is a global manufacturer, and shocker, they discovered that the workers who are working the night shift have much more errors on the manufacturing line than do the workers in the daytime. And of course, the solution they want is what any good capitalist enterprise would want, and that is to fix those nighttime employees so they can perform better at night. And they did a study with almost 100 people using my product. And since I had access, there was someone doing the study independently, but I had access to the data. And the thing that was most shocking to me is it isn't just we're asking these nighttime workers to change their schedule to somehow sleep in the day and not at night. But what we're doing is we're putting them in a horrible situation, because when I actually got to look at the sleeping patterns of people who are on the job from midnight until 8 a.m., it is just horrifying how they are sleeping for 2 hours, and then another 45 minutes, and then 3 hours scattered through the day. And that kind of fragmentation does not allow, again, the brain to do its natural cycles that we look to for good health. So I think that is something that we do need to address as a society and do something better for workers put in this situation.
Lizzie, were you going to jump in on the previous point?
I was, yes. I was just going to comment on the glymphatic clearance of the brain that Michael was talking about. So a lot of that work was done in animal models, but there have been a few studies now which do seem to show that this glymphatic system, as it's known, that's upregulated during slow wave sleep is active in humans as well. And some of the work that we have ongoing in Edinburgh, in conjunction with a team in Toronto, we've been looking at the sort of vascular aspects of that. So looking at the very small spaces around the blood vessels in people who have obstructive sleep apnea. So people who have very broken sleep and drops in oxygen levels. And what we've been doing is some MRI imaging of the small vessels around the brain, around the small spaces around the blood vessels in the brain in people with sleep apnea before and after treatment. So we don't have the results as yet because the study's still ongoing, but certainly it looks like there is some impairment of the clearance of the fluid because of these enlarged perivascular spaces. So it's a kind of watch this space, but I think there's a growing body of evidence now that poor sleep and sleep disorders do seem to be implicated in both Alzheimer's type dementia, but also in vascular dementia. So we see a lot of cardiovascular problems in people who sleep poorly, and certainly on the small vessel disease, stroke side of things, we're starting to get a lot more information there. So yeah, I mean, I think it is a growing problem, and we are starting to gather the evidence. I think we've always kind of assumed that because there are cognitive effects when you don't sleep well, that it would follow on, that there would be links with dementia. But I think we're now starting to get some really solid evidence. So it's not out there to scare people, but just to start to highlight the importance of sleep, not just for your physical health, but for your brain health and for your mental health as well.
Thank you. That's really informative. And the linking of sleep and cardiology happened within that description. I'm really kind of fascinated to go away and have a look at that. We do a fair bit of work on cardio signals. I'm gonna wrap things up because we've talked. I've got still more questions, but I'm gonna just ask one more, and it's this one. The session today has been called "Learning to Sleep in a World Turned Up to 11," which is obviously a bit of a clickbait sort of title, and we thought it would bring in some really interested people, and the conversation has been fantastic and interesting. But I'm gonna get that question answered. How do we learn to sleep? What are the approaches that we should be taking to improve sleep? On a basic level, let's not cover the don't drink at 12 o'clock 3 pints. Let's avoid that. But what can we do to improve our sleep? And are there any technologies that we should be using to do that potentially?
Well, I'll kick off with this one as well. I think going back to Rachel's points around light and the manipulation of light, I think it's almost about going back to basics, about using technology to enhance our inbuilt physiological mechanisms. So rather than trying to work against our bodies to get us to, be in a state that is incongruent with where our body wants to be, I think using the environment and using the inbuilt capabilities that we have, sort of using technology to enhance our own body's brilliant ability to sleep rather than the other way around, if that makes sense. Rachel kind of talked about us working against our bodies and then using technology to try and get back to where we were to start with. Maybe it's about, taking what we've already got and using the technology to enhance that even more. Just yeah, I don't know how we go about doing that. I guess that's the job of people like yourselves, but that would certainly be my thought.
Yeah, I really agree with you there. Looking at the body's natural rhythms, understanding our bodies more, looking at, I guess, having a broader definition of what technology is also. For me, it's understanding quietness, meditation, perhaps looking at ideas around social technology, making sure that there's connection, like loneliness, anxiety is one of the biggest causes of like not being able to sleep. So having maybe technology which helps remedy our digital hygiene, clearing from the bedroom, that kind of thing. I know it's not really what people want to hear, but yeah, being in a situation where we're not overly stressed, overly anxious, and looking at the kind of the role that technology plays in our lives on a daily basis through work, because it's all completely shifted at the moment for everyone, hasn't it, in terms of COVID and the lockdown, and we're all working from homes and working from bedrooms, and what kind of hygiene, digital hygiene, should be implemented in order to allow for relaxation and sleep to happen.
I agree with both of those. And for me, though, I think we are faced with the problem that we tend to enter all of these fields with very idealistic and noble goals. The computer age was supposed to usher in a time of leisure to free people up to pursue those higher level pursuits. But yet we have this tendency to turn everything into a game of efficiency. We always have to be ever more efficient, ever more getting more done. And sleep is kind of the odd one out when we think about living a good life. Everyone can agree nutrition is important to keep our bodies running well. You got to put the right fuel in. And exercise is important as well for maintaining fitness. And both of those things are interesting in that you get instant feedback. When you're eating, it's a visceral experience. When you're exercising, you feel your muscles moving, and even though it might hurt, you feel good about the activity you're doing. And sleep is different in that you're getting no feedback, no conscious feedback while it's happening, and the benefits come actually when you're awake, the antithesis of sleeping. So you feel better when you're awake instead of kind of getting the reinforcement that this is a good activity. So I get back to our natural tendency is as technology comes online, and we do that with the hope of improving sleep to improving people's life, I think so often the way it is desired is rather, how can I use the technology so I don't have to sleep as much, so I can accomplish more, get more done in life, and be more successful, more productive, more even useful. So we need to battle against that whole idea that somehow sleep isn't as valuable, and the natural tendency, I think, is clear because we don't get that feedback while it's going on.
Fantastic answers, and really appreciate you joining us today live for this this conclusion to our track. And great to speak to you again today. I wish you all the best of night's sleep, and do take care. And thank you everyone who's joined us on the track. If you want to connect with the panel, remember you can connect to them via the Giant Health platform or at thrivewearables.com/giant2020. So thank you everyone, and good night.
Thank you.
Thank you very much. Good night.
Good night.